me the honor to present this talk on in the Gravicon, and I would like to thank Novartis too for allowing me to. So our main topic today is coming directly to the topic, that is road ahead to the CML patients. So why I'm discussing this topic, because if we see go through the survival curves of the CML patients, now they are approaching similar to a normal patient. So with the event of with the now with imatinib and TKI is available in India, these patients, they live a normal life as compared to the normal patients. So if I go to the history of CML, we know in 1960 the CML patients, they were being diagnosed with the abnormal chromosome 22. In 1990s, we came to know about the BCR-ABL gene is identified as leukemia, cause of leukemia in the mice, and then the trials were started. And in 2001, this study confirms that imatinib works in CML patients, and it is approved by FDA for the treatment of CML. So since 2001, just 20 years, 20 decades, so 20 years, this imatinib, the wonderful magic bullet, has changed a lot. So these are the survival curves. If I compare with the patients once they are on imatinib and once they are on other treatment lines like busulfan, hydroxyurea, interferon alpha, and interferon and stem cell transplant. So if I compare it with imatinib, the overall survival, the prognostic, the curves are statistically significant. So now imatinib is approved drug for the treatment of CML. And this was the study IRIS study, which was designed for the approval of imatinib when imatinib is compared with interferon alpha and Ara-C. In this study, there was crossover limbs was also available. Those who have lack of response either on imatinib or on interferon alpha and Ara-C. So the patients were randomized with 553 patients in both the arms, and they were followed. And in this study, if the 10-year survival curves were compared, as we can see in imatinib patients who are on imatinib, the 10-year survival curve is more than 80% in the patients who are on imatinib as compared to the patients who are on interferon alpha and cytarabine. The 10 years survival in imatinib was 83%, and in the second limb was 78%. The main objective was designed to confirm the international randomized study on interferon and this imatinib IRIS is to explore whether the treatment with imatinib at 400 could be optimized or not in the study 4. So in this, the methodology was they consider the 5 arms in which imatinib 400 was used, imatinib and interferon was used, imatinib 800, and imatinib with cytarabine, and imatinib after interferon failure. And these are the number of patients who are enrolled in each arm. And recruitment to the later 2 arms was stopped after the pilot phase was over. So if we see in this, one sec. If we see in this, the 10 years overall survival of all the patients was 82%, while 10-year PFS is 80%. Risk group comorbidities and major root chromosomal aberrations, smoking, or type of center does not influence the survival. Gender transcript is hardly any influence on the survival curves, while patients reaching molecular response is the milestones which are considered at 3 months, 6 months, and 12 months. And the faster response was seen in the faster response of with 800 patients did not translate into detectable survival advantage. So the dose of 400 was approved in for the treatment of CML patients. Now, what are the survival predictors about the prolonged survival? From this study, we came to know that faster and deeper molecular response is the major predictor of prolonged survival. Prevent and progression to accelerated phase or blast crisis during TKI therapy, prevention of development of resistant mutation, and management of TKI-related toxicities. In the IRIS study, the patients who on 8 years follow-up, the 45% of the patients, they discontinued imatinib, while 55% patients, they continued imatinib as the first line. The patients who discontinued is because of the adverse events in 35%, unsatisfactory therapeutic effects in 13%, while death was reported in 6.7% cases, and 6% of the cases, they progress to stem cell, they opt for the stem cell transplant, while in other 37, the reasons were not cited in the study. And moreover, we have seen that events like loss of complete hematological response or major cytogenetic response, progression to accelerated phase or blast crisis, and death during the treatment was more reported in the initial 3 years of imatinib therapy. While if we continue for the next 8 years, the estimated PFS is about 83 3%, and progression to accelerated and blast crisis is 92%. Uh, there is some issue at my okay, leave it. Survival is poor after the progression to accelerated phase and blast crisis. We have seen in EARNEST and IRA study the patients who have progressed to accelerated or blast crisis on imatinib, the overall survival is not good. The survival is poor. At the 3 years data cutoff, 23 out of 34 patients in EARNEST who progressed to accelerated or blast crisis had died. The median survival was about 10 months in the patients who progressed to accelerated or blast crisis while on imatinib. Survival post imatinib failure is, as we have discussed in the previous slides also, the patients who they failure to imatinib, the post imatinib resistance or recurrence, the median survival is in the patients who remain in chronic phase is 72%, while those who progress to accelerated or blast phase, there is a significant variation, like 30% at 3 years, and blast phase is 7%. So initial 3 years, initial follow-up of 3 to 6 months, the achieving the response, optimal response is the prognostic marker for the survival curves. So the debatable questions we have: should we wait till the progression before we switch? So once the patient has not progressed, so should we wait for it? Can we predict the early treatment failure? What is the ideal time to switch? At 3 months, 6 months, 1 year, or 2 years? Or should we consider the switching depending upon the treatment goals or the risk stratification? The answer to it lies is the milestones in the molecular response. As we have seen in BCR-ABL, at the time of diagnosis with cytogenetics is 100% if we consider, and we follow it on the month of at 3 months, 6 months, and 12 months. According to it, we came to know that at 3 months, if BCR-ABL IS ratio is 10, it is optimal response. When at 6 months it approach to 1, so it's optimal response. And at 12 months, if we get 0.1, that is major molecular response, it is an optimal response. So we continue on the same therapy. Why? If at 6 months, if the response is more than 10, so as per the ELN guidelines, this is a failure. Or at 12 months, if the response is more, if the IS ratio is more than 1, so this is a failure. So we need to change the therapy to other second line TKI. Still, there is a window of the patients at 6 months and at 12 months when there is in between 10 to 1 and 1 to 0.1. So there are the warning signs are there. We have to monitor them closely. While in NCCN guidelines, they say ki if the similarly in the NCCN guidelines, the only difference between this ELN recommends the repeat testing before changing to the second line TKI. So the patients who respond at 6 months in patients failing to achieve the EMR at 3 months, so 87% of the patients who have EML failure at 3 months, only 13% achieve the adequate response, optimal response, if we switch to second line TKI, while 31% the ratio lies in the warning sign, 1 to 10%, while 56% they don't achieve. So this also gave us, while at 3 months, if the patient doesn't achieve the molecular response, if we switch to TKI or we continue the same, so the response is not as good as the patients who responded at the 3 months. This is the ELN guidelines 2020 recommendation on which cytogenetic criteria is the similarly the cytogenetic and the molecular response is evaluated at 3, 6, 12, and then at any time. So uh, optimal responses with BCR-ABL less than 10. So these are the figures which we usually monitor in the CML monitoring. So as we have discussed in the chart also, the warning signs, so depending on the BCR-ABL values. But in ELN, they say the failure is, so they recommend the early switch to whenever they don't achieve the adequate response. So at 3 months, 6 months, and 12 months, if the response is not achieved, they recommend to switch to second line. While in NCCN guideline 2020, so they have classified the similarly on the basis of BCR-ABL ratios, but when there is a yellow window is there, so they always say either we can switch to alternate TKI or we can continue same TKI other than, or we can increase the imatinib dose. So this is the clinician variation. So which guidelines they follow, either they can switch on to second line TKI or they continue with the same TKI. Now with the presence of second line TKIs, generic molecules, and with the Cigna patient assistance program, I prefer to follow the ELN guidelines. We switch to second line TKI if the patient doesn't achieve at 3 months or 6 months. In ESMO guidelines, the same to the previous guidelines, but they have also included the deep molecular response, that is BCR-ABL less than 0.01 at 18 months. This is the only difference between the two. So similarly, they have included this BCR-ABL cytogenetic response and the failure. Now coming to the second line molecule, that is nilotinib. So why the nilotinib is more effective as compared to the previous TKI, that is imatinib? It is because of the 4 hydrogen bonds, that is the molecular pharmacodynamics and pharmacogenesis. I'm not going into the much details into it. These are the few literatures which I would like to discuss with you on the success of the nilotinib in the patients who are imatinib resistant or imatinib intolerant to in CML patients in chronic phase, and they followed for 48 months. So the patients who have resistant to imatinib, and when they are on switch to nilotinib, the estimated progression-free survival was 57% in 48 months. While the 102 events which were recorded, only 11 patients, that is 3%, they progressed to accelerated phase and the blast crisis. Similarly, as we have discussed in the previous slides, the patients which have achieved baseline hematological response or achievement of low BCL-ABL transcripts at 3 or 6 months, they respond better when we switch to second line TKI. Their response is better as compared to the patients who have not achieved even with the imatinib. The patients with complete cytogenetic response as 12 months had significant higher PFS versus patients, those who haven't achieved any cytogenetic response at 12 months. The estimated rate of overall survival was 78% in this study, with median survival has not yet achieved. So these are the orange line is for all the patients, while the blue line is the patients who have achieved baseline hematological response, complete hematological response, while the yellow line symbolizes the patients who have not achieved the baseline hematological response. As we can see, the PFS, the patients who have achieved the baseline hematological is significantly better as compared to the patients who have not achieved at the baseline. Overall survival curves is about 78% in this, and median overall survival has not yet achieved. Coming to the adverse events in this study, the rashes, the grade, any grade like 99% and 30 and 26%, they reported with rash and pruritus of any grade. While grade 3 and grade 4 adverse events which were reported was rash, headache, and diarrhea, and this was just 1%, 1.6 to 1.9% of the patients. There was no new grade 3 or grade 4 non-hematological adverse events reported while patients were on second line TK. There were no new cases of QTC interval prolongation, or there were no pleural effusion reported in the patients when they were switched to nilotinib from imatinib. And while coming to the hematological events, there were newly occurring or worsening of grade 3 or grade 4 neutropenia occurred only in 2 patients between 24 to 48%, 48 months of the follow-up while on nilotinib. And newly occurring or worsening of grade 3 and grade 4 thrombocytopenia was seen only in 1 patient when they were switched to nilotinib on the 12 months of follow-up. So in conclusion, the study has concluded that minimum follow-up of 48 months and nilotinib continued to be the effective in patients with Philadelphia positive CML in CP phase with imatinib resistance. No new safety signals were observed and few additional events have occurred. Deep molecular response at 3 and 6 months was significantly correlated with the PFS and OS at 48 months. Now coming to the next option, like when the patients have accelerated in the accelerated phase and they are imatinib resistant. So should we switch to nilotinib or second line TKI? This is a study which I would like to share with you. The nilotinib in patients with Philadelphia positive CML in accelerated phase following imatinib resistance. So in these patients at 24 months, 70% of the patients were alive. However, the median duration of overall survival had not yet achieved. So even the patients who have accelerated phase on nilotinib, 70% patients alive, so quite significant figure. And the drug-related toxicity, similarly, there was no drug-related pleural effusion or CNS side effects were seen, CNS bleedings were seen. Only 1 patient has grade 4 gastrointestinal bleeding event, while rash and pruritus were the most common non-hematological toxicities were seen in these patients who are in accelerated phase. While coming to the hematological adverse events, myelosuppression events were predictable and generally easily manageable. In the patients, about 59% patients shows anemia and 64% were neutropenia was reported and thrombocytopenia was reported in 67%. And grade 3, grade 4, as depicted in the figure, about 20 to 27 to 40% was seen in the patients who are on nilotinib, who have progressed to accelerated phase and imatinib resistance. In conclusion, they concluded that 24 months of the follow-up data with nilotinib continue to be the effective with durable hematological and cytogenetic response in the patients with imatinib resistance. Hematological response is seen in 55% of the cases. Complete cytogenetic response is seen in 21% of the patients, and overall survival is about 70% of the patients in the patients who are imatinib resistance and has progressed to accelerated phase. Initially, there was dead end for these patients, but with the presence of nilotinib, the patients they do well. So median exposure of nilotinib was 780 milligram per day. Minimal occurrence of grade 3, grade 4 adverse events. Myelosuppression was manageable and reversible. Fluid retention and bleeding were uncommon in the patients. This is another study in which minimal cross intolerance with nilotinib in patients with CML in chronic or accelerated phase who are intolerant to imatinib. In these cases, the patients who are already on who are imatinib intolerant, so the patients, these are the blue and orange, they corresponds to the patients who are in chronic phase, and the patients who are in accelerated phase corresponds to the orange bars. So the complete hematological response was seen in 90% of the patients who are intolerant to imatinib when they were switched to nilotinib, while major cytogenetic response was seen in 65% of the cases, and 51% patients shows complete cytogenetic response. So the figures are quite comparable when they were intolerant to imatinib. And the cross intolerance which was reported in imatinib, like 60%, 63% patients who have shown non-hematological adverse events, out of which only 4% of the patients they showed intolerance to nilotinib, and like rashes, fluid retentions were not seen with the nilotinib while they were seen with the imatinib. Grade 3 side effects were seen only in one patient, that is with diarrhea, and these adverse events has not lead us to any dose reduction or discontinuation. So the patients who are intolerant, they tolerate the nilotinib well, better, while patients who are in accelerated phase, the non-hematological toxicities which were seen in 56% of the patients, they were not seen in the patients when they were switched to nilotinib. Now, coming to the hematological intolerance, the imatinib, while they were showing 33% of the cases who are showing hematological adverse events, and when they were switched to nilotinib, only 20% patients shows adverse events, and out of which the predominantly is the thrombocytopenia which was persistent. The patients who have thrombocytopenia with imatinib, they persist also with nilotinib, and about in 7% of the cases we have to stop the nilotinib due to this adverse event. While in accelerated phase, 33% patients shows hematological toxicities, while 0% on accelerated phase. In conclusion, cross intolerance was minimal in patients with imatinib intolerance. Thrombocytopenia was the only imatinib related adverse event that led to nilotinib intolerance and discontinuation of the therapy. This is another in which the crossover is this: can we switch to nilotinib or not, and when should we switch? The patients who have not responded at 12 months, so the study design was they were on 400 and 600 imatinib, and they were randomized on nilotinib or they were continued to the imatinib. And once they have randomized, they were followed further for 24 months, and then crossover was seen. And as we can see, the patients they achieve MR in the difference is about 19%, 22%, and the patients who were continued on increased dose of imatinib and they switched to nilotinib, the 11 cases and 14 cases they again achieve MR 4.5. So now coming in this era, we can say the initial goal of the CML therapy is the disease control and best overall survival. But now we have shifted to operational cure, that is no evidence of disease in the absence of treatment, and TFR is the next goal which we are moving ahead. I'm not discussing the TFR in this, so this, and thank you.
Hello, thank you, Dr. Ankur. Dr. Nazeez, sir. Hello.
It was an excellent talk. It was an excellent talk, updated knowledge. But I just want to know, can we start directly as an initial treatment with nilotinib?
So now with the presence, yes, there are the data is there in some cases when the SOCAL index is high or the patients have intermediate or high risk category or in accelerated phase, we can progress. We can start with the nilotinib as a startup therapy first line also. And in patients who have coagulation parameter deranged, there are few cases. I have one or two cases, those who are presented with coagulation parameters. We start directly with the nilotinib as 300 milligram BD. Now, yes.
Okay. And the second thing I just want to clear now, I think the dasotinib has also come in this CML nowadays. For example, if a patient is on nilotinib started and then he had initially imatinib resistant or intolerant, can he be switched later on, say after 1 or 2 years to imatinib if he cannot continue or afford nilotinib?
Yes, sir. The patients who can't continue, like who are intolerant or who can't continue medicine for a long, we can get the TKI mutations done. According to the mutations panel, we can switch to nilotinib. And even if the patient is on nilotinib and we are losing the response, we can again get the TKI mutation. Might be there is development of new mutations, and we can switch to another second line TKI with dasatinib or bosatinib. Uh, Might be we get the ponatinib in the future also.
Thank you very much. Back to the Nitika and Gupta for further.
Thank you, Dr. Nazir, and thank you, Dr. Ankur, for the wonderful presentation. I would like to take this opportunity to welcome our revered principal, ma'am, Dr. Anjali Bhatt, ma'am. Under her patronage, our institute is going at a great pace. Good morning, ma'am. Beginning with the next academic session, I now request Dr. Raj Rishi, sir, Professor and Head Department of Surgery, GMC
Nitika,
Kathua.
Rakesh has joined, I think, Dr. Rakesh Kumar, our other chairperson.
Yeah.
Can you please invite him also?
Yes, sir. I would like to invite Dr. Rakesh Kumar, sir. He's in charge Advanced Cancer Research Lab at SMVDU Katra. Sir, have you joined, sir?
Yeah, I have joined.
Fine. Okay. Good morning, sir.
Good morning. Good morning.
I also request Dr. Anil Gupta, sir. He's Senior Consultant in the Department of Surgery, to kindly chair the session, along with Dr. Rakesh, sir. I now request Dr. Rajrishi Sharma, sir, who's Professor and Head Department of Surgery at GMC Kathua, to speak on the topic carcinoma gallbladder, the surgical perspective. Sir, unmute, sir. Raj, sir, unmute, sir.
Thank you, Dr. Nitika. Can you hear me?
Yes, sir. You're audible.
See you after a long time.
Thank you.
And thank you, Dr. Deepak, also. So I would like to speak on gallbladder cancer. First slide.
Can we have Raj, sir's slides, please?
Today we will talk on gallbladder cancer, a surgeon's viewpoint. Because the day we diagnose a patient with gallbladder cancer, we are assigning a death warrant for him. Such is the morbidity and mortality associated with the gallbladder cancer. And such is the pessimistic and nihilism associated with disease. Next slide. It was first described by Maximilian Stoll in 177, and more than 200 years later, it is still considered to be a highly malignant disease with a very poor survival rate. That's why Blalock in 1924 said that in malignancy of gallbladder, when a diagnosis cannot be made, no operation should be performed, as this shortens the patient's life. So leave him, as we were doing in house surgeon, and after 30 years, again as a professor of surgery, we don't do much in the case of gallbladder. We refer this patient to the next patient, right? And when we send the patient to home, patient says, my God is stronger than the gallbladder cancer, but the things are otherwise. Most of the patients die within 1 or 2 years. Next. So why the need to discuss the gallbladder cancer? Because it is the 5th most common cancer involving the GIT, and it is the most aggressive tumor. Because the tumor is considered highly lethal, with overall survival rate at 5 years is only less than 5%. And the percentage of patients diagnosed with gallbladder cancer after operating for 0.5 to 1%. And the incidence of gallbladder cancer has increased for the last 20 years due to the incidentally diagnosed gallbladder cancer following lab colis. But the strange point is that the increased recurrence rate is same as in other cases. Slide 2. It has the shortest median survival rate from the point of diagnosis, and it is very aggressive. And the problem is that we can't screen a patient because for gallbladder cancer. There are no sensitive screening methods for that. Next. So why it has such a poor prognosis? Because the complexity of gallbladder placed in below the liver and in associated with portal other structures, anatomic complexity, and high morbidity and mortality associated with the liver resection. It has a very high recurrence rate and increases spreading due to the tumor manipulations. The GBD, next slide. Now a few facts about gallbladder cancer. But the median survival rate of all patients with gallbladder cancer is 3 months, and with 1 year survival rate of 14%. The 5-year survival rate is less than 5%. It counts for 1.2% of all global cancers, but 1.7% of all cancers death. Look at the incidence. Back. Look at the incidence of the gallbladder cancer. It is 22nd in the incidence of whole cancer rate, but the death rate, it is 17%. And it is the only digestive tract cancer that is more common in females. And in countries with high development index like Norway, the mortality is same as compared with the countries of lower high development index like Nigeria. So the negativity or the cancer death is same as per the high. Next slide. Now we will talk about the risk factors or the demographic factors. The GBD, the gallbladder cancer incidence increases with age. The average age at diagnosis is mostly 72, and with the other factors are also contributing. If you go by the region wise, in India, Delhi has the highest cancer rate, and in Pakistan, it is the Karachi. It is very rare in the Western world, USA, UK, Canada. And the gallbladder cancer rate is now increasing in Iceland, Costa Rica. This may be due to the difference in the environmental exposure and some regional predisposition to cancer. This variability of the gallbladder cancer, it may be due to the dietary factor, with diet high in calories, carbohydrates, red meat, oil, and red chili pepper causes increase in the incidence, while green leafy vegetables and fruits turns out to be protective as per the gallbladder cancer risk. The obesity has a big factor. For each 5-point increase in BMI, the risk of developing gallbladder cancer is 1.59 for female and 1.09 for male. Thus, every 5 centimeter increase in the waist circumference is ready to increase in the gallbladder cancer rate. Next slide. Now, as per the gallbladder pathology is concerned, it has a definite role in the cause of gallbladder cancer. Cholelithiasis. We all surgeons know whenever we see a case of gallbladder cancer, most of the time it is associated with gallbladder stones. Rarely I have seen a patient of gallbladder cancer without stone. So gallbladder stone has a 8.3% increase than the other population, and it's more in the female because gallbladder stone is more in the female. The large stones have a greater potential for developing the gallbladder cancer, and stones more than 3 centimeters have 10 times more risk of developing cancer rather than the stone having less than 1 centimeter. This increase in the rise of gallbladder cancer is due to the local epithelial irritation caused by stone, which leads to dysplasia and chronic mucosal damage because of mechanical effects of gallstone. Between 0.5 to 1% of patients who underwent cholecystectomy have incidental gallbladder cancer, while autopsy of gallbladder cancer shows 1.2% presence of gallbladder stone. Chronic inflammation of the gallbladder causes DNA damage, tissue proliferation, cytokine and growth factor release. Also, the chronic inflammation causes calcium deposition in gallbladder wall, leading to porcelain gallbladder, which is a precancerous condition. And only 1% of GB turns porcelain. In all the cholelithiasis, only 1% of the patient turns into porcelain gallbladder, while gallbladder cancer has 25% associated with porcelain gallbladder. Gallbladder with stipple calcification are pre-malignant and it different to diagnose it differentiated from transmural calcification. macrolithiasis, large stone, are more harmful than small stones. If we go for the polyps of the gallbladder, 5% of the adult gallbladders have polyps, and majority of these are pseudopolyps with no neoplastic potential, like in cholesterosis, adenomyosis, or inflammatory polyps. The risk of malignant transformation is rapidly growing when the polyps grows more than 10 millimeter. Solitary sessile GB polyp less than 2 centimeter is mostly benign, while higher one has a more potential. The pancreaticobiliary maljunction anomalies, they predispose to the formation of cancer because of the biliary reflux. It is abnormal fusion without a sphincter diagnosed by ERCP, MRCP, or endoscopic ultrasound that turns out to be a major factor. This is diagnosed by endoscopic ultrasound. It shows thickened layer of epithelial hyperplasia with subserosal fibrosis, with or without muscular. The leading cause of the pancreatic biliary reflux is the damage to the lower end, and it is more common seen in females. A channel length of more than 3% causes increase in the rate of, next slide. Certain exposure to certain drugs or chemicals can as a risk factor in development of gallbladder cancer. Increase in the level of heavy metals, radon, low level of zinc, selenium, increased copper, lead, cadmium, chromium is associated with increase in the formation of gallbladder cancer. Smoking is also the contributing factor for the development of gallbladder cancer. Next. Infection, next slide. Infection with certain parasite like H. pylori, Salmonella, or Clonchitis sinensis is associated with formation of gallbladder cancer. Next slide. So if we see it common, a vulnerable gallbladder, vulnerable because of the cholelithiasis, porcine gallbladder, Medici syndrome, GB polyp. In a host like advanced female and with stones, fatty female, associated with certain infection, is a both all the three things can lead to the formation of gallbladder cancer. So it's not an isolated variable. It's a combination of all the three variables that can cause gallbladder cancer. Next slide. If we see the prevalence of gallbladder cancer in India, most commonly the sub-Himalayan belt, Delhi, UP, and in Jammu Kashmir also. Thank you. Next slide. If we see the histology of the gallbladder, why it is so morbidity and mortality associated with gallbladder cancer, it is because of the position of the gallbladder and its histology. The normal GIT shows characteristic layers of, next slide. Next slide. The normal GIT shows characteristic layers of mucosa, submucosa, muscularis externa, and serosa or adventitia. The submucosa is again divided into three layers like lining epithelium, connective tissue, lamina propria, and muscularis mucosa. The gallbladder differs from the other GIT tract because here the muscularis mucosa, the submucosa layer is absent, and the muscularis externa or fibromuscular layer is also absent. So the spread of malignancy is faster than the other part of the GIT. Also, the site of the gallbladder, which is attached to the liver, but has no peritoneal covering. It is the serosa attached to the gallbladder plate of the liver. So there are no separating structure between the liver and the gallbladder. So it is directly attached to the cystic plate of liver, which is the fibrous lining only. So GB, which is all, partially interperitoneal also, it is attached to segment 4 and 5 of liver. So simple cholecystectomy, the plane between muscularis mucosa of gallbladder and cystic plate is dissected. So it is inadequate for the carcinoma gallbladder. Next slide. And the site of GB cancer in carcinoma in gallbladder, it is 60% located into the fundus, 30% in the body, and 10% in the neck of the gallbladder. Why 60% in the fundus? Because it is the site for the resting phase of resting gallbladder stones. The larger the stone, the more they are located at the fundus. But when we do lab chole, sometimes stones are located in the neck of the gallbladder also. So that's the 10% rate in the neck. Next. So what are the signs and symptoms? How a patient presents with the gallbladder cancer? In advanced stage, it is the jaundice. We all surgeon knows the deep jaundice in the eyes and the skin of the is a death warrant. Most of the patient present with discomfort or pain in the right upper side of the body. Patient can have lump in the abdomen. It is due to the cancer blocking the CBD or the common hepatic duct. His stools are lighter colored. Colors become dark. And one of the main features in advanced stage is persistent itching. Unexplained weight loss is again a major presenting feature. Loss of appetite, or patient feel full after a small meal, nausea or frequent vomiting, and sometimes patient in advanced stage present with swelling and distension of the abdomen. Next. If we see the study of 4 individuals, it's abdominal pain, which is the main symptoms in the patient presenting with gallbladder cancer. Jaundice, weight loss, and anemia are the late presenting signs. Next. This is a classification. The time is running short. It's mainly what we see adenocarcinoma and adenosquamous carcinoma, but other are some benign conditions also. Next. Next. This is the pathogenesis of gallbladder cancer, how it is formed. There are 2 distinct independent biological pathways leading to the formation of gallbladder cancer. One is dysplasia carcinoma sequence, the other is adenocarcinoma sequence. Chronic inflammation of the gallbladder shows metaplasia in 50% of cases, leading to change in the epithelium of the gallbladder. It can turn out to be gastric type or intestinal type. This dysplasia progresses to carcinoma in situ, which become invasive typically over a course of 15 to 19 years. One study has demonstrated that metaplasia, dysplasia, and carcinoma situ adjust to a cancer of gallbladder exist in 66, 81.3, and 69% respectively. The other, only 3% of patients have adenoma carcinoma sequence, though it is very common we see in the surgical practice. The other are the genetic mutations leading to the formation of cancer, like oncogenic mutation, tumor suppressant gene inhibition, microsatellite instability, and methylation of gene promoter area. This is very poorly understood in the case of carcinoma gallbladder, and over 1,281 genetic mutations are implicated in the development of cancer. Thus, pathogenesis of gallbladder cancer is very ill understood. The key factor in carcinogenesis is chronic inflammation. It causes DNA damage and tissue proliferation with the release of cytokine and growth factor. The earliest sign of intercellular chatter, which initiates carcinogenic pathway, is yet to be explored in the pathogenesis of gallbladder cancer. Next. The incidence of gallbladder cancer, if we by histological type, it is mostly carcinoma, then it's adenocarcinoma, papillary, mucinous, and squamous cell. Next. So how to diagnose a patient of gallbladder cancer? Normally, it is mainly ultrasound. It is more frequently used, and gallbladder cancer may appear as a mass, it may appear as growth or intraluminal polyps, or sometimes it presents with asymmetric wall thickening. But the main drawback of the ultrasound is that it misses the early finding. So we need to have high resolution contrast enhanced ultrasound for early diagnosis of gallbladder cancer. Ultrasound also tells us about the biliary tract pathology. The endoscopic ultrasound is the definite imaging modality with FNAC. We can also use contrast enhanced harmonic endoscopic ultrasound, a newer technique of real-time elastography to diagnose a gallbladder cancer. The other modality which is used is CAT scan. It is commonly used for diagnosing and staging of gallbladder cancer, and we can use multi-detector MDCT to increase the specificity of that. The other is ERCP, and nowadays we are using MRI, magnetic resonance imaging, magnetic resonance angiography, and magnetic resonance pancreatography. PET scan is also used, but is not very helpful. Then we can use percutaneous transhepatic FNAC to next. Now to study the staging of the gallbladder cancer, we have to, we must know gallbladder cancer. The gallbladder cancer is, the gallbladder is drained into cystic lymph node of Lund, which is located in the Calais triangle. And gallbladder has a typical lymphatic spread. Most of the lymphatics of the gallbladder go downwards. They follow the lines of gravity. After that, from the Lund, they go to the para-aortic, and then to the mesenteric, and then to the pancreatic nodes. The idea of knowing the lymphatic drainage is that whenever we go for surgery in a case of carcinoma gallbladder, we have to remove all the lymphatics or the lymph nodes surrounding the gallbladder, and we need to remove the nodes around the pancreatic biliary channels also. The three pathways which are used to by which gallbladder malignancy spread is cholecysto-retropancreatic pathway, cholecystocelic pathway, and cholecystomesenteric pathway. They all pathways converge into abdominal-aortic lymph node. Next slide. This is the specimen, and here showing all the nodes which are. This is the toxic specimen. Next slide. So, in this staging of the gallbladder cancer, the role of lymphatic spread is very important. The cholecysto-retropancreatic pathway, it has two routes. One running spirally and posteriorly from anterior surface of CBD to right, and the other runs straight down from the posterior surface of CBD. At the retroportal segment, these routes converged at large lymph node called principal retroportal node. The other is cholecystocelic pathway. Lymphatics from gallbladder run to left through hepatoduodenal ligament to reach the celiac nodes. And the other is cholecystomesenteric pathway. Lymphatics run to left in front of portal vein to connect to the superior mesenteric. The rate of progression of precursor lesions to invasive carcinoma has estimated to be around 15 years. And this is the age at which the various lesions can develop. Like normal epithelium at age of 30 to 40, it is the early sign. It is carcinoma, and changes are occurring. Then intermediate lesion is dysplasia. In later stages, at 55 years, carcinoma in situ develops, and after the age of 60 years, it can turn out to be invasive carcinoma. And there are the other genes factors which are affecting the growth of the gallbladder cancer. Next slide. So the incidence of regional invasion and metastasis. In most of the cases, the gallbladder, when we see a patient of gallbladder cancer, it is already widespread. Other than in which we remove a gallbladder and carcinoma in situ comes, in only 10% of cases, gallbladder is confined to the gallbladder wall. The liver invasion, because of the association of the gallbladder to the liver bed, 4 or 5 segment of liver, it is 59%. While common bile duct infiltration is 35%. The lymphatic invasion into the other nodes is 45%, and portal vein and hepatic artery invaded in 15 cases. That is a sign of inoperability. Next slide. These are the basic classification of gallbladder cancer. We will skip off all it because whenever we see, our idea is whether it is operable or inoperable. Next slide. Next slide. Next slide. Next. In stage 0, carcinoma in situ, no nodes and no metastasis, which can be operated. Stage 1, T1 and 0, M0, we can again take a chance. In stage 3, 4, widespread metastasis is there. We refer the patient and we don't have much. Next slide. So this is summary of staging of carcinoma gallbladder. There are modified Nevin, Japanese, and AGCC classification. Next. This is how will you manage case of gallbladder polyp. Most of the time it's demonstrated on ultrasound, and we have to exclude whether it's a true polyp or it's a pseudo polyp. Polyp more than 10 mm, it needs cholecystectomy, and less than 10 mm, we wait for the symptoms to develop. If there are symptoms like stone or inflammation, we again go for cholecystectomy. If there are no symptoms, we look whether the patient is below 50 years or other associated findings are there or not, or whether we go for serial ultrasound. If the polyp is pedunculated and there is no growth for the last 3 or 6 months, then we can wait. Otherwise, we go for the cholecystectomy. Next. The National Comprehensive Cancer Network management of the various symptoms presenting upon the gallbladder cancer, like jaundice. The first and foremost is the history and clinical physical examination. After that, we go for liver function test, chest, and then we will check whether it's a resectable growth or unresectable growth, and then the various treatments. Next. Next. So again, the other presentation mass on the imaging. Our main idea is whether we can operate it or we can't operate it. If it is resectable, normally it is laparoscopy being done, but normally it's contraindicated. Next. The incidental finding at surgery. We are going for surgery, we can find in the intraoperative staging, we can go for frozen section, and then depend whether the growth is there or it's how much involvement is there. Then we can show divide whether it's resectable or unresectable. That's how we manage. Next. 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 So depending on the staging of the gallbladder, we do simple cholecystectomy or cholecystectomy with en bloc resection of the segment 4 and C5 of liver with regional lymphadenectomy, or we can do right hepatectomy or Roux and Y later on. Next. Surgical pitfall or surgical techniques. Idea is to whenever we go for surgery, we have to avoid the spilling of gallbladder contents during the surgery. Failure to convert laparoscopy to open procedure at appropriate time is not a good sign, and the failure to use retrieval bag during surgery. We do 2 types of surgery. One is radical cholecystectomy, then is extended radical cholecystectomy. The difficulty to remove gallbladder along with other structures is because of the complex anatomy and the spread of the gallbladder cancer. For radical cholecystectomy and extended radical cholecystectomy, the pre-operative diagnosis is to be there. The radical cholecystectomy The radical cholecystectomy was first proposed by Glean and Hayes in 1954, in which gallbladder bed with the rim of liver tissue, lymphatic tissue within hepatoduodenal ligament are removed and blocked. In extended radical cholecystectomy, we remove lymphatic tissue within hepatoduodenal ligament, posterior superior head of pancreas, around portal vein, hepatic artery and block with rim of liver tissue and extrahepatic bile duct. During surgery, avoid incising or spillage of gallbladder and its content. So what's the role of laparoscopy? Routine diagnostic or staging laparoscopy may be helpful in gallbladder cancer, but it increases the morbidity and mortality. And some suggest that it is a waste of health care resources. Earlier on, we were saying lap chole is contraindicated when pre-operative diagnosis is confirmed, but people are going for robotic surgery. Second stage that we encounter is incidental or identification of gallbladder carcinoma, which occur in 0.2 to 3% of cholecystectomy for benignity. Only 30% of gallbladder cancer are suspected of the disease pre-operatively. It is proposed that all gallbladder specimens should be opened and examined post-operatively for finding of carcinoma gallbladder. Next. If we are going for surgery, we suspect during lap chole or open there is a carcinoma gallbladder, so we go for intraoperative frozen section. So what are the indications for intraoperative frozen section? Macroscopically contracted or sclerotic mucosa, asymmetric thickening of gallbladder wall, normal tissue of the gallbladder wall is replaced by connective tissue in all the layers, macroscopic mucosal color change, presence of polypoid lesions, porcelain gallbladder, and Mirizi syndrome. Frozen section has 90% sensitivity and 100% specificity, but it cannot separate carcinoma in situ from epithelial atypia, but can determine wall depth invasion with 70 to 86% accuracy. importance in the while doing surgery is the cystic duct margin. If the cystic duct margin is positive in intraoperative section while doing surgery, we do resection of common hepatic duct with portal nodes and liver pad. And if the cystic duct margin is negative during the cholecystectomy,
Sir, due to time constraint, I think we have to hurry up.
okay, we can split the bill and a morbidity. After surgery, the time of recurrence is generally 4 months, at time of resection within 10 days. One point is next slide. Next. The other is port site recurrence. It is because of direct mechanical contamination, indirect mechanical contamination because of the chimney effect, changes in the host immune response, hematogenous or inadequate surgical technique. Next. Next slide. The criteria for non-resectability are metastatic disease, involvement of the hepatic artery in portal vein of both the livers, and continuous involvement of more than 2 segments in each lobe. Next. These are figures of how we do extended cholecystectomy. Next. This again, better views. Next. This is how the patient, the diagrammatic representation, how it is done and look afterwards. Next. Next. So it's not a alone disease, it's a part of the family. So in this family, no one fights alone. Thank you.
Dr. Rakesh, please unmute, sir.
Thank you, Dr. Raj, for a wonderful elaborate lecture.
Rakeshji, because of time constraints, can you please speed up the session?
Okay. Okay. So I have a small question. I think we can take the questions later on.
We can take the questions later on. We'll start with the next sessions. We are running late.
Okay. Okay. I'll get back to.
Please take over.
Okay.
Okay. Thank you, Raj, sir, for the presentation, and Dr. Rakesh, thank you for managing this session. We will now begin our proffered paper presentation session. I request Dr. Nazir Khan, sir, to kindly chair the session, and I would request the judges to kindly give the marks out of 25 and share the marks or the scores to Dr. Deepak on WhatsApp. I would now request Dr. Kanika Sood, Consultant Radiation Oncology, Dharamshila Narayana Super Speciality Hospital, Delhi, to kindly be our first judge.
Thank you.
Thank you. I'm already there. Thanks.
Thank you, Dr. Nikita. Should we start the proffered session?
Yes, sir. Sir, I'm just inviting the judges, sir.
Okay, okay.
I now invite Dr. Raja Paramjeet Singh, sir, radiation oncologist from Faridkot, to kindly join the session. Sir, are you there?
Yeah, good morning. I am there. And now just small correction. Now I am not at Faridkot. I have joined Government Medical College Patiala as a
All right,
president.
sir. Okay, sorry, sir.
Fine.
Then,
Thank you.
then we have Dr. Kundan Chofar. He's radiation oncologist from Rajiv Gandhi Cancer Institute, Delhi. Sir, are you there, sir?
Yeah, hello, good morning. Yeah, I'm here.
Good. Okay, then we have Dr. Sanjay Basin, sir. He's professor, Department of General Surgery at Government Medical College, Jammu. Sir, have you unmuted, sir? Sanjay, sir?
Yes, good morning. Good morning, all. Yes,
good
thank
morning,
you.
sir. And we have Dr. Byas Dev, sir. He's Senior Consultant Orthopedic Surgeon at Government Medical College, Jammu.
Sir, please start the session. Nazir, sir, please start the session.
Nazir,
Okay.
sir. I would once again request the judges to give marks out of 25 and share the scores with Dr. Deepak on WhatsApp.
So now
Okay,
we call
We'll do that.
first profit presenter, Dr. Ravi Kant.
Good morning. Slide, please. So,
Yes.
Good morning. Shall I start?
Yes, sir.
Yes. Good morning, respected chairperson, respected judges, and thanks to the organizing secretary and team for selecting my abstract in proffered paper session. And myself, Ravikant, I am assistant professor in medical physics, Department of Radiation Oncology, Dehradun. So my topic is effect of endobronchial brachytherapy on the target volume and evaluate the doses to the organ at risk in the carcinoma lung patients. Next. The radiation therapy is used in lung carcinoma is mainly by external beam radiation therapy, but there are some indications where radiation therapy is used as brachytherapy. So American Brachytherapy Society issued guidelines for brachytherapy in lung carcinoma. APS recommends that the patients with hemoptysis and post-obstructive pneumonitis can be considered for palliative endobronchial brachytherapy. Next. Endobronchial brachytherapy generally give fast palliation of blockage than external beam radiation therapy. So ABS recommends that in endobronchial brachytherapy is performed via transnasal technique with the help of flexible fiber optic bronchoscope under conscious sedation administered well trained person. Next, a guide wire is used to visualize the catheter under fluoroscopy because through bronchoscopy endobronchial lesion is visualized but not by fluoroscopy. So ABS suggests the dose regimes are 7.5 gray per fraction per week for 3 weeks, 10 gray per fraction per week for 2 weeks, and 6 gray per fraction per week for 4 weeks for palliation treatment. So those prescription point in SDR endobronchial brachytherapy can be selected by 2 ways. One is at 1 centimeter from center of the catheter. Other is at various distances around the center of the catheter. So to treat the adequate tumor coverage, we need 1 to 2 centimeter margin recommended by the ABS and at each end of the catheter. The optimized dose distribution is completed in treatment planning system. Next. So the aim of my study is to analyze the effects of endobronchial brachytherapy on the volume of target volume and evaluate the doses in the lung carcinoma in the treatment sessions. Next. So the material method is dosimetric analysis was conducted on the patients of carcinoma lung receiving endobronchial brachytherapy session in SDR brachytherapy with Vanadium-192 source. A flexible 6-branch catheter was inserted in the lumen of the patient. A position tip of the catheter at the tumor. CT simulation was performed for the patient session. Each session. Source position simulator device was used to measure the catheter length. Next. CT data of the patient was acquired and sent to the treatment planning system for planning purpose, and OARs and target volumes were delineated for the accurate evaluation of the doses to OARs and target volume with each brachytherapy treatment session. Dose prescription was done at 1 centimeter from the center of the catheter. DVH with the detailed dose table is used to note down the doses to OARs and target volumes in treatment planning system. Next. The prescription dose was, we have taken 7 gray per fraction for 3 sessions of each patient. Those parameters such as the volume of the OARs receiving D5, D10 were calculated and measured from the tables, and maximum and mean doses were taken from the DVH. Doses to the target volumes were also find out for each treatment session of the patient. The variation in the volume of the target volume from its first session to third session were noted down from the dose volume table. Next. So here there are 2 pictures. One is at the first session of the same patient, and the second one is third session. So here there is showing a volumetric variation in the target volume from first session to third session in endobronchial brachytherapy treatment. Next. The results are 30 sessions were analyzed in this study. Average volume variation in the target volume was found in the range of 20.45 cc to 13.7 cc in first session to third session respectively. Average mean dose to esophagus was ranged from 0.85 gray to 1.18 gray. Average maximum dose to heart was ranged from 3.69 gray to 4.77 gray. Average maximum dose to left coronary artery was ranged from gray to 0.91 gray. Next. So here we can see the variation in the target volume from first session to third session of the same patient. So this graph is showing there is a reduction in the volume from first session to third session after endobronchial brachytherapy. Next. In that slide, there is a mean dose to esophagus is shown from first session to third session. And here there is a slightly increase in the dose from first session to third session of endobronchial. Next, average maximum dose to heart for the patients after receiving endobronchial brachytherapy is also seen, and here there is a slightly increase in the dose from first session to third session. Next, average maximum dose to left coronary artery was seen from after the endobronchial brachytherapy treatment, first session to third session, there is slightly increase in the doses. And next, the conclusion of my study is shown that there is a significant volume reduction in the target volume from first session to third session, treatment session of brachytherapy, and the doses to OARs are significantly increased from first session to third session of endobronchial brachytherapy. Although the doses are to OARs were in their tolerance limits, it implies that endobronchial brachytherapy is much effective in the treatment of lung cancer patients with the lesion in the primary and the secondary bronchi. Thanks.
Excellent talk, I think. Yes, by Dr. Ravi.
Yes, sir.
Should we call the next speaker, or there is any question to anyone?
Yes. Can I ask?
Yeah.
Yeah. So, Dr. Ravi, first of all, it's very good to see that people are practicing endobronchial brachytherapy that often. My question is, like, once you did the first session, did you not consider reducing the prescription depth at the subsequent sessions? Because once and continue to prescribing at 10 millimeters, despite that there was a volume regression. Any reason for not reducing the prescription depth?
Actually, ma'am, we are just it's our protocol that we are giving 1 centimeter prescription point from center of the catheter. Maybe there are some uncertainties of the catheter placement in the lumen. So sometimes it is at the towards end of the organ, and sometimes it is away from the target volume. So we it is an isotropic distribution, so that's why we don't want to miss the tumor exactly. So we have taken 1 centimeter margin, not reducing it that much.
Because you yourself mentioned that your target volumes were shrinking on the subsequent sessions. So that was my question. As for the reduction on your CT scan, could you consider decreasing? Because otherwise you would end up having more bronchial sloughing. What were your hotspots in the subsequent sessions in the bronchial mucosa with 10 mm?
Actually, it is not exactly we have find out from that that the patients are already treated. So we just see the patterns of the effects of endobronchial brachytherapy on the patients from first session to third session. So that we have evaluated from these.
Okay. Okay.
Thank you.
If there is any brief comment or question from judges, just 1 minute.
Sashiva, judge.
Okay.
We can move ahead.
We can move ahead.
Dr. Sanjay, want to ask something? Dr. Sanjay, you want to ask something?
I think judges, I think judges are here to judge the things. If they ask questions, it will be an inbuilt bias. So let the others ask the questions and we'll judge as per the content.
Okay, sir. Okay, sir. Okay, sir.
Okay, noted, sir. Yeah. So now we'll move ahead and we'll call Dr. Rahul Singh for next proffer paper presentation. Dr. Rahul Singh.
Good morning, sir.
Yeah. So we are sharing your presentation. You have 6 minutes to present, okay, and 2 minutes for question answer. So please stick to the time.
Rahul, stick to the time.
Good morning, everyone. Topic of my presentation is analysis of quality of life in patient with esophageal cancer after chemoradiotherapy and surgery. Next slide. Now coming to introduction, as we all know, esophageal carcinoma is a highly lethal malignancy. Despite the improvement in diagnosis, surgical treatment, and neoadjuvant therapy, prognosis remains poor, and management of esophageal cancer is associated with high morbidity, and it entails at least a temporary detrimental impact on health-related quality of life. Next slide. So aim of our study is to assess the variation in quality of life of patients with esophageal cancer before and after chemoradiotherapy and surgery. Next slide. Now coming to methods, experimental study before and after study. All consecutive patients were equal to or more than 18 years of age presenting carcinoma esophagus. Now coming to inclusion criteria, histopathologically proven squamous cell carcinoma, patient with middle and lower 30s of facial malignancy. No evidence of symptomas or previous malignancy. All patients with ECOG perform status of less than or equal to 2. No prior chemotherapy or radiotherapy. Next slide. Now, coming to clinical staging and workup, a complete history and thorough general physical examination was done for all patients. Dysphagia was evaluated according to Atkinson's classification. Upper GI endoscopy along with tumor biopsy followed by CT scan of neck, thorax, and abdomen was done. Next slide. Nutritional determinants and laboratory tests were also done. Treatment delivered was neoadjuvant chemoradiotherapy of 41.4823 fraction along with tablet capecitabine followed by surgery within 4 to 6 weeks. Patients were evaluated during the course of chemoradiation to assess the acute toxicity according to RTOG toxicity grading criteria. Patients' quality of life was assessed before and after chemoradiotherapy as well as 1 month after surgery. Patients were provided with quality of life questionnaire performer as per URTC guidelines. 41 eligible patients were enrolled. All completed proposed neoadjuvant concurrent chemoradiation. 36 patients underwent surgery. Out of them, 20 underwent definitive surgery, whereas 16 underwent palliative surgery. Coming to demography, male to female ratio was 1.5 to 1. Mean age of patients was 60 years and range was between 21 to 80 years. Coming to ECOG performance, most of the patients were of ECOG performance 1 and 2. Whereas this figure showed initial clinical symptoms at presentation. Most of the patients presented with dysphagia, followed by weight loss and retrosternal pain. Next slide. Grades of dysphagia prior to concurrent chemoradiation. Most of the patients presented with grade 2, grade 3 dysphagia. Next slide. This table shows global health status and various functional scale according to this URTC QLQ30 questionnaire performer. As we can see, global health status improved during the treatment, whereas most of the functioning scale deteriorated during the treatment. Next slide. This graph shows global quality of life analysis. It shows gradual improvement after chemoradiotherapy and surgery. Next slide. Physical functioning score were moreover similar throughout the study period, whereas role functioning gradually improved from pre-chemoradiotherapy level to post-chemoradiotherapy level. Next slide. Coming to emotional functioning and cognitive functioning, both deteriorated during the treatment. So patient needed emotional support during the treatment. Next slide, please. Social functioning also showed a deterioration and was lowest at post-chemoradiotherapy follow-up period, and it was further worsened at post-surgery follow-up. Next slide. This table shows various symptom scores. Most of the symptom scores improved during the treatment with significant p-value. As we can see, fatigue, nausea, vomiting, pain, and diarrhea and insomnia improved during the treatment. Next slide. So fatigue was maximum among the patients prior to chemoradiotherapy. This gradually improved and was lowest at 1 month post-surgery follow-up with significant p-value. Next slide. Nausea and vomiting score gradually improved at 1 month post-surgery follow-up period, whereas pain, maximum number of patients had pain prior to chemoradiotherapy, and pain score gradually improved. Next slide. Dyspnea was gradually improved from pre to post chemoradiotherapy and again worsened at 1 month post surgery, whereas constipation was maximum among patients prior to chemoradiotherapy. This gradually improved post chemoradiotherapy. Next slide. In appetite loss, significant results were found in terms of loss of appetite loss. And for diarrhea, QL score was gradually improved pre to post chemoradiotherapy and again worsened at 1 month post surgery. Next slide. Financial difficulties increased during the treatment, being maximum at month of post surgery with statistically significant p-value, whereas insomnia was maximum in patients prior to chemoradiotherapy, gradually improved and was lowest at 1 month post surgery. Next slide. This was organ specific QLQ OES 18, which showed different symptom scores, 10 symptom scores, and most of the symptom scores gradually improved during the treatment. Some having significant p-value like eating problem, reflex symptoms, pain, trouble swallowing, and choke when swallowing, dry mouth, trouble with taste, and trouble talking. Next slide, please. So to conclude, neoadjuvant chemoradiotherapy for carcinoma esophagus patients followed by surgery with curative intent is a safe and well-tolerated regimen with respect to quality of life. Thank you.
Excellent, you have finished it in time. But the question, you had given capecitabine as a neoadjuvant in all patients.
Yes, sir. All patients, sir.
And you had squamous cell carcinoma.
Yes, sir. Squamous cell.
Capecitabine is not a routinely drug to be given to the patient of dysphagia because in the capsule form and you will have got difficulties. Not like that?
Yes.
You have not understood it. Hello?
Yes, sir.
I mean, the capecitabine is a capsule form, and patients who had grade 2, grade 3 dysphagia, they had not difficulty in taking this capecitabine?
So mostly we have given it in crushed form. We have asked patient to crush it before using it. Most of the patients were on rice tube. So we asked them to take it through rice tube in a crushed form, sir.
Okay, if a question is from the judges. There is no question, we can go to the third.
So now we'll invite the next presenter, Dr. Sonali Verma. Dr. Sonali?
Yes, I'm here, sir.
Yeah, Dr. Sonali, please go ahead. Your PPT has already been shared.
Okay.
Stick to the time, 6 minutes you have.
Sonali, please
Okay.
stick to the time.
Okay, sir. Okay. Good morning to all of you. The title of my presentation is the evaluation of polymorphism of TP63 gene in breast and ovarian cancer patient of the North Indian cohort. Next slide, please. Before I start, let me give a brief introduction about the beginning of the cancer. The cancer start from whenever there is any abruption in the normal cell cycle replication, the normal cell get converted to the abnormal, which lead to the formation of the invasive cancer. Next. Reproductive organ are the major site for malignancy among women worldwide. Among these major malignancies, breast and ovary are the most common malignancies. They have high morbidity. In Asian countries, breast cancer ranked first with an incidence rate of the 11.2%, and the ovarian cancer ranked 8, then incidence rate of the 4 among all malignancy in the women. Breast and ovarian cancer are multifactorial in region where both genetic and non-genetic factors are associated and contribute to its etiology. The genome-wide association studies are the recent approach to identify the genetic variants related to breast and ovarian cancer in precise for early diagnosis of the breast and ovarian cancer. So it is recommended to identify the genetic changes that lead to the progression of the cancer cells and metastasis. The regulation of gene is controlled by its corresponding single nucleotide polymorphism, which can confer a biological effect. This is the incidence of the cancers from India in women, where breast cancer ranked first in women and the ovarian ranks third. Next slide. These are the number of cancer registries from Jammu Kashmir region, where the breast cancer falls in the first rank and the ovarian rank third after the esophageal. And this graph shows the increased rate of the ovarian breast cancer in the Kashmir region. Except this, we have not found till date the incidence study from the Jammu region. Next slide. TP63, sorry. TP60, the aims and objective of our study is to understand the sample and data collection procedure related for case control study. We have done this study after we have found that this variant of the TP63 has been found to be associated with the lung gastric cancer in various population, and we have replicated this study in the lung cancer patient of Jammu and Kashmir region, and we have published our data in the Journal of Genetics, where we found that this variant caused risk to the lung cancer patient of Jammu and Kashmir region of North Indian cohort. And after this, we have just replicated our case control association study in the breast and ovarian cancer patient of JN. In this study, we are the first to replicate and investigate this variant that could be act as a risk factor or progression indicator for breast and ovarian cancer. We have collected our sample on the basis of the religion, ethnicity, place of origin, menopausal status, and done the statistical analysis on the basis of the allele frequency estimation, comparison of the frequency of in both cases and controls, and then in the odds ratio calculation to calculate the risk. Next slide. Coming to the role of the TP63, the TP63 gene is important in the development differentiation and in response to cellular stress. The alternative splicing of this gene and the use of the alternative promoter result in the multiple transcript variant encoding different isoform that play important role in the DNA whenever this TP63 exposed to the DNA damage, the accumulation of the DNA damage and the deficient response to genotoxic stress contribute to an earlier process of the carcinogenesis. As the TP63 is required for the formation of the epithelial layer, it has been identified that it regulates the development of the memory cells through the signaling pathway, that is the SSH, W and T signaling pathway. Next slide, please. For the completion of the genotyping of this TP63 variant, we have collected the 2 ml whole blood from the cases and control after the ethical informed consent, and all details were filled in the in our standardized performa. All samples were collected from the various hospitals and clinics of the Jammu and Kashmir region. For this study, we have collected 510 blood samples, where 150 is from ovarian cancer patient and 150 from the breast cancer, and 210 were the age-matched healthy women that were included in this study. And after the collection of the blood sample, we have done DNA isolation from the blood, and we have excluded all those patients who have undergoing the chemotherapy or radiotherapy, and we have done the genotyping from the real-time PCR. Next slide, please. These are the demographic details for the cases and control that we have collected in our study. Next slide. The genotyping of this variant has shown that there are 3 types of genotype we have found. A subject with the TT genotype have the homozygous mutant genotype, and the subject with the CC genotype have homozygous wild type, and the individuals with the CT genotype are the heterozygous mutant, where the yellow color of the this yellow color dots show the negative template control. Next slide, please. And this is the amplification plot we got from the after the genotyping, and we found that the positive reaction signal which was detected after the accumulation of the fluorescent signal, where this CT value show the number of cycles required for the fluorescent signal to cross the threshold value. Next slide, please. These are the results that was calculated after the binary logistic regression, where we found there is a very slight differences in the allele frequency in both cases and control. Next slide, please. TP63 gene is homologous to TP53. That has been reported an important aspect in the proliferation and progression of the cancer cells. So it has been estimated that it is important in the development of the epithelial cell, and various studies prove that increased expression of the P63 is significant for the growth and depreciation of the epithelial layer. And in the breast cancer, the increased expression of the P63 help in the breast tumorigenesis that has been correlated with the poor prognosis. Next slide. The regulation of this gene, all gene controlled by its single nucleotide polymorphism, and in this study we replicate our previous study that we have done in
Dr. Sonali, 30 seconds left, please.
This means our results from this study, we have indicated that this variant not pose any risk to the breast and ovarian cancer patient of the JNK region. Thus, variant of this TP63 decrease the risk of breast and ovarian cancer, but the heterozygous status may appear to be a strong risk factor for the breast and ovarian cancer development in the population of the North India. Thank you. Next slide. Thank you, sir.
Okay. Okay, I would like to ask one question. Was it is the significance in early detection of breast cancer? Hello. Are you hearing?
sir. So there is a much different. Hello. Yes, sir.
Yeah, I am listening.
Yes, sir.
Sonali, go ahead.
I was okay.
Dr. Sonali, can you hear the question, please?
No, sir. Can I? Sir, I'm
I
not.
was okay. I will repeat. My question was, what is the significance in early detection of this breast or ovarian cancer by this TP63?
Sir, till date we have not found any study of this variant where we found that this TP63 has been associated with the breast and ovarian cancer in other population. Then this TP63 found to be associated with other cancer, gastric, lung, and our research group from SMVDU, we have published our data in the Journal of Genetics that this TP63 has been found to be associated with the lung cancer risk.
Okay. If there is no question, so we can ask next.
Sonali, what are the different types of methods which we can use for genotyping, and how do you decide which method to choose?
Okay. Ma'am, there are a lot of methods. Most simple method is the restriction fragment length polymorphism method. Second, we have used in this study, that is the Tachman based probe genotyping from the real-time PCR. Then we have highly robustic techniques. Our research group published that technique, mass array genotyping. And then when we have vast number of samples, we will go with the exome sequencing. Within a short span of time, we have done a lot of SNPs genotyping. In the 2 or 3 samples, we have thousands of SNPs were genotyped with the exome sequencing.
Okay, thank you.
Thank you, ma'am.
We'll call upon Dr. Ruchi Shah. Dr. Ruchi Shah, are you there?
Yes, sir.
Yeah, please go ahead. You have 6 minutes.
Good morning, everyone. I am Dr. Ruchi Shah, scientist working as a scientist in Department of Biotechnology, University of Kashmir. The topic of my presentation is SNP analysis of RS1219027 of TCF21 with ACC in the population of Jammu and Kashmir. Next slide. First of all, incidence rate of ACC worldwide, it is highest in the Eastern Asia, which includes the countries like China, Japan, and North Korea. And if in Asia, it is highest in the Turkmenistan, Mongolia, and Kazakhstan. And in India also, it is in the list of the highest incidence. Next slide. It is a depiction of the most incidence cancers in India, and here we have taken up the population of Jammu and Kashmir. So at esophageal cancer is at the number 2nd in the Jammu and Kashmir. And if we can see the graph, figure number 4, it has been rapidly increased from 2000 to 2012 due to the various risk factors associated, mostly the food habits, the junk food that we are taking, processed food, that is an important risk factor in the esophageal squamous cell carcinoma. Next slide. There are 2 types of esophageal cancers. One is the ESCC and second one is the ADC. ESCC is the esophageal squamous cell carcinoma and ADC is the esophageal adenocarcinoma. About 90% of the cancers in the esophageal cancer are ESCC. So I have taken for my PhD, while doing my PhD, I have taken up the ESCC. And there are the various risk factors that have been associated with the esophageal cancer, physical factors and the genetic factors. I have taken up the genetic factors during my PhD work that include the SNP genotyping, genetic mutations, and the microRNA analysis. Next slide. Inclusion criteria. The study comprised of blood samples of 166 ESCC patients of Jammu and Kashmir and 592 controls, age and sex matched. General parameters that have been included are the family history, dietary habits, age, gender, and BMI. Next one. Next slide. These are the clinical characters of cases and controls for the present study that include age, BMI, metastasis, and family history. Next slide. The SNP genotyping has been used. I have used a high throughput SNP genotyping technique that is known as the mass spectrometry. It is actually a 3-step process in which the high biomolecules like DNA has been fragmented using the ionization technique. Electric field is accelerates the ions. It consists of, first of all, a multiplex PCR is used. We have used here 396 well plate, and in one well there are about 30 to 36 SNPs that can be genotyped in one go. And then there is bombardment using the sequinium. Sequinium consists of a metal detector. First of all, the analyte is ionized. Analyte consists of the samples and the matrix that is mixed together, and then electric field is generated, and then there is a detection with the help of a metal detector. The light, and as here we use the, instead of probe, we use the UEPs, that is the universal extended primers, that help in the generation of the ions. And detector helps to detect the collisions, the maximum ion collisions, and produce a graph. The graph can be analyzed on the analyzer software, and here we get the three types of the graphs. Next slide, please. Next slide, please. We get the result in the form of three types. That is the call cluster plot and traffic signal, and then the genotypes. In the call cluster plot, you can see that there are three types of clusters. One is the green one, another is the blue one, and then is the, another is the non-template controls, where we used everything instead of DNA. Water is used. That is for the that is for the purity of the experiment. So and the call rate should be about 90%. We have taken up only those SNPs whose call rate is about 90%. We have designed a 66 SNP panel. Here it is a cancer panel that we have designed using the DB SNP, and the cancer here only I have taken up only one SNP due to the time constraint. Otherwise, I have in this experiment we have analyzed 66 SNPs, and in association with the ESCC. Next slide. And here are the SNPs. Only those SNPs were selected which have the call rate about 90%. And here I have taken up the TCF21. This RS1219028 genetic variant of TCF21 has been primarily associated with the multiple cancers in the different populations. But our study is the first one to associate this genetic variant with ESCC in the population of Jammu and Kashmir. Next slide. TCF is in transcription factor 21. It's also known as POD1 capsulin or epicardin. It's present on the chromosome number 6, and it includes 3 exons. It is very essential for regulating properties of mesenchyme that are critically important, and includes several aspects of living and kidney morphogenesis. Next. TCF21 gene polymorphism were found to play a very important role in the tumorigenesis of some solid malignancies. TCF21 gene polymorphism has been associated in the Chinese population with the osteosarcoma, and CG and GG genotypes predicted elevate risk of osteosarcoma and worse surgical stage and higher potential to form the metastasis. It is very important in several types of cancers, and thus is known to function as a tumor suppressor. Next one. In my present study, the TCF21 has been associated with the increased risk of ESCC with the p-value 0.00876, that is less than 0.05, and odds ratio 1.412. If the odds ratio is above 1 and within the class interval of 1.09 to 1.8, and it is within it is following the Hardy-Weinberg equilibrium, that means this variant is highly significant and can be associated with the ESCC within the population of Jammu and Kashmir. Next slide. Transcription factor 21 is a member of class A of basic helix loop helix family, and it acts as a tumor suppressor. And this genetic variant under study within the population of Jammu and Kashmir has been associated with multiple cancers in different populations. In the current study, it has been explored with respect to ESCC. It is the first study within the population of Jammu and Kashmir. In conclusion, TCF21 probably can be used as a prognostic factor and may provide a new therapeutic target of ESCC in the clinic. Next slide. This work has been published recently in the BMC Cancer by Springer Nature. Thank you.
I would like to
Dr. Nazir, sir?
If
Any
Dr.
questions we
Nazir
have?
has lost connectivity, I think.
Any questions we have from the judges?
Anyone who asks question?
Yeah,
I have.
Yes, please go ahead.
I have one important comment to make. You didn't tell about India, because if you see the Northeast data, as for the National Center for Disease Informatica and Research, probably you will find the East Khasi Hills, which is in Meghalaya district. They have the highest incidence of esophageal cancer, and probably the incidence is as high as 71 per 100,000, which is, more, the average, which is highest in the Malawi, which is 24 per 100,000. It is much, much higher. And if you see the top 10 places as far as the esophageal cancer incidence is concerned, there's all top 10 places, belong to northeastern part. So this is the most common cancer among male in northeastern population if you combine 8 states together. So it's a big, it's a very big problem as a cancer incidence. So this is a, point to make.
Thank you, sir. Actually,
So,
due to
Dr.
constraint, I try to show my work. I give much importance to that rather than to the incident.
I think there is a question from Dr.
Point.
Dr.
Dr.
Kanika wants to ask
something.
some question.
Yeah, so we should be fair. We should be giving her also an opportunity to answer a question. All three have. So, Dr. Ruchi, I really enjoyed your talk, and I think it is times that we all start getting aware about these genetic changes in cancer types and implementing them into the clinic. So, you spoke about osteosarcoma. Are you aware of other solid malignancies and non-malignant conditions with which this particular mutation is associated with?
Ma'am, we are actually my work was on esophageal carcinoma only. So, though I have done the literature survey, but this particular genetic variant has only been studied in the Chinese population with respect to osteocarcinoma. Much work has not been done worldwide on the genetic variant.
I think in one of your own slides you have mentioned there is renal and lung deposition of this particular mutation. So renal cell carcinomas, bladder carcinomas are also the ones which have been associated.
Ma'am, it might be connected to the TCF gene 1, but not the genetic variant associated with the TCF.
And there are also some incidences of VSTs and cardiac malformations which have been linked to this particular subtype.
Okay, ma'am. Thank you.
Ravindra, next.
So I request, no sir, we have
All
done
the
with, yeah, all the 4 have presented. So requesting all judges to send the scores to Dr. Deepak Abrol's WhatsApp, so we can access all the proffered papers. Over to you, Dr. Nitika.
Please send within half an hour, sir. It's request to judges to please send within half an hour.
Hello.
Hello. Yes.
My video is not coming. Hello.
Dr.
Okay,
Nazir,
sir,
are
go
you there,
ahead.
sir?
Dr. Ashraf from Srinagar.
Yes, sir.
Yes.
We can start the next session.
Hello.
Right. Hello. Yes, Dr.
Yeah,
Ashraf, you have some
yes,
questions,
yes.
sir?
No question. I was just missing video link. I was missing.
Okay.
Sir, you have to
Issue,
start from your own set.
There are a lot of interruptions. Anyway.
So proceeding on to the next session, we have a panel discussion on lung cancer, a frontier to be conquered. On expert chair, we have Dr. J.P. Agarwal from Mumbai, who's a radiation oncologist. And the moderator for the session would be Dr. T.P. Sahu, who's oncosurgeon from Bhopal. On the panel, we have Dr. Kaustav Salpatra, who's consultant radiation oncologist from Mumbai. We have Dr. Sanjeev Narang, who's consultant pulmonologist from Jammu. Then we have Dr. Madhu Sairam, who's radiation oncologist from KMCH Coimbatore. We have Dr. Sridhar PS, who's radiation oncologist from Bangalore. Then we have Dr. V. Srinivasan, who's radiation oncologist from MEOT, Chennai. We have Dr. Arvind Kohli, sir, who's a CTVS surgeon from Jammu. We have Dr. Vivek Gandotra, sir, who's CTVS surgeon from, again, Jammu. We have Dr. Subhas Pandit, who's consultant radiation oncologist from Nepal.
JP, sir, something.
Hey, do this one. Sorry.
Do I start?
Yes, sir. Dr. Jay Prakash, sir, you can start, sir.
Well, welcome, sir.
You're the expert on the chair, sir.
Conquered.
So your voice is breaking, sir.
Dr. Sahab.
So you are not audible, sir.
Dr.
I
Jay
think
Prakash, sir.
he lost the connectivity. So I think Dr.
We can
Sahu
start, sir.
start.
Sahu, sir, we can start with, and then expert chair
Connect
will
him.
chime in.
I'll connect Dr. JP on phone.
Yeah. Thank you, Dr. Deepak. Thank you, organizers. To one small correction, I am a hardcore medical oncologist, and the point was thank you, Dr. Deepak. First my disclaimer. I would be missing some finer grainy points about radiation oncologist, and I have an elite panel to correct me if I'm missing something. But I learned a lot in this last 24 hours about radiation oncology, and I've learned to respect this specialty more than what I did maybe 24 hours back. So with that small thing, I start off and I have a lovely panel, long panel. So next half an hour, 12:05 is stop. That's for the organizers. I won't go a minute beyond that. 30 minutes was given to us, and I will take that only. Number two, the panelists, please be crisp. We are going to speak only about non-small cell and bring out the point which you want. Don't go into details. Bring out the real brawny points, and I will let Dr. JP, who better than Dr. JP, to really brief out at the end of it. So this is a 57 years old smoker presented with dry cough. X-ray chest was suggestive of this, what you see in X-ray chest. So we can have the first panelist, Dr. Sanjeev Narang, who's a chest physician. Dr. Sanjeev, what would you do with this? Quick, small answers. Dr. Sanjeev. So you're there?
Dr. Sanjeev. Sir, okay. I think direct this to somebody else.
I will. Let's go to Dr. Arvind, the cardiothoracic surgeon here. Very quick with this. What do you want?
Dr. Arvind, sir, you need to unmute, sir.
Can I request all the panelists to be really handy to mute and unmute themselves as the name comes in?
Yeah, good morning.
Yeah, please. Dr. Arvind.
Yeah, it's a higher mass, and we'll definitely like to go ahead.
You are not audible. Can you come near the mic? Yeah, please.
Increase the voice.
Dr. Arvind, sir, near the mic.
Yeah, am I audible now?
No, sir.
Okay, please go on. Please go on. We can hear you a little low, but we can hear you. Please go on.
Am I audible now?
Yeah, sir. Please go on. Please go on with the answer.
Yeah, actually, it's a higher mass, and definitely we'll go ahead and investigate the patient. Most likely a lung mass, and we'll like to investigate in all aspects.
Okay, with all aspects. So Dr. Sanjeev has joined in. Is Dr. Sanjeev there still? He's not there. Okay. So
Dr. Sahu,
yeah.
So sorry to interrupt, but Dr. Bharat Chauhan from Mumbai, who's a medical oncologist, has also joined, sir.
I know.
He's also on your panel, sir.
Yeah, I know. Bharat is there. There are questions. Dr. Sanjeev, quick. Where would you place bronchoscopy today in the field of diagnosis of lung cancer?
The bronchoscopy remains to be if we have a central lesion.
Yeah.
If we have a central lesion, then the bronchoscopy remains to be the main diagnostic tool to do a biopsy. If we don't have a transthoracic biopsies and FNACs are helpful if so far the peripheral lesions are concerned. But the bronchoscopy is the main tool to do if we have to diagnose. If we have to refer to you people, to oncologists, you people need a report. You people cannot simply rely on the CT report or some imaging. You need a tissue diagnosis.
Okay. So it's rightly said that bronchoscopy is a very much integral part of lung cancer diagnosis, and we do send most of our central lesions for a tissue biopsy for many reasons, which will come in the whole course of the panel. To Dr. Kaustubh, yeah. A patient comes to you directly, PET scan versus CT scan. What would be your quick point answer.
And sorry for interruption. I'm having a very heavy load in my OPD because of this COVID
So
nonsense.
I will,
If you can please,
will spare you,
with
sir.
folded hands, if you can excuse me. My apologies to Deepak in particular. I have to leave.
Sir,
I
thank you, sir.
just had to show my presence, sir.
Thank you, sir. Thank you, sir, for being there. Sir, CT scan versus PET scan. Dr. Kostov.
क्या बोलूं बोलो
Sridhar, I see you. Can you take this question?
See, the moment if you in the first instance you told that the moment if you are talking about a bronchoscopy guided biopsy, we are looking for a panel of tests. So in the same manner, the PET CT scan is the preferred method in any of the suspected case of lung cancer, irrespective of the stage.
So PET CT would be your preferred choice.
First choice, yes.
Okay. So we will come to that. Dr. Arvind, this case comes to you, and you are a cardiothoracic surgeon. You want to operate. Do you want to have a biopsy report, or you would like to go ahead with a lung mass as we do with gallbladder cases? Probably, or maybe some abdominal malignancy.
I definitely like to have a biopsy report.
Okay.
I should be well equipped with a biopsy report and staging.
Okay.
So, like you have told about to start with the X-ray, CT scan, endobronchial, this ultrasound, mediastinoscopy, and biopsy. Of course, all these things are available. Then we are well placed to take on this case.
Okay. Dr. Vivek.
I'll need a biopsy, definitely.
Dr. Vivek, you're there? Okay, he's not there.
Dr. Vivek, I think.
Sir, he's there. He needs to unmute, sir.
Yeah.
Sir, Dr. Vivek, please unmute.
Please, all the panelists.
Okay.
Yeah, please. Dr. Vivek.
Can you repeat the question? I was not able to.
I just want to know what basic workup you would like to do when you're going to operate on a lung cancer. Dr. Sridhar, who's a radiation oncologist, went ahead and did a PET scan for you. And let's say the PET scan shows an N2 lesion, which is a 2.5 centimeter lymph node, which is a subbronchial, subcarinal. So would you be comfortable with that? Think of it's a surgical case, or would you think that I will not do any more further tests, or would you like to do a mediastinoscopy in such case?
So I would like to go for a mediastinoscopy and to see the extent of the lymph nodes.
Okay.
And I think it can be a surgical case.
Okay. Okay. So I think the oncologist and the surgeons will differ a little bit here. What the main consensus would be in such cases that probably when you do a PET scan, that's most of us do it, that if you have a lesion that is around 1 centimeter, if you have suspicious N1 lesions, that's where that EBUS and the TBNA really comes in to get a tissue biopsy. And if that is still not conclusive, then we do a mediastinoscopy. But there is now growing consensus that if you have a definite N2, N3 nodes, and you probably can spare the patient, and these patients, if it's a size like 2.5 centimeter, you just can take it up for a CTRT or a neoadjuvant approach, and then probably go for surgery. Dr. Kostov, do you agree with this approach?
Yeah, I agree with this approach. Only thing is, even in non-small cell lung cancer, there is more and more evidence coming in of doing a MRI brain before going ahead, because there is a lot of, in M1 disease, the incidence of brain metastasis is to the tune of 16% in a particular study.
So for any operable case or a stage 3, Agreed.
Yeah, like I'll agree with Kaustubh, like PET CT and MRI brain. It goes hand in hand irrespective of the stage.
That is true. MRI brain for a metastatic, if asymptomatic, can be questioned, but for operable, for stage 3, that is definite done. 10% would have MRI positive, asymptomatic. So there's no doubt about it. Biopsy, why I put this up? Because you could get a small cell cancer. Although the small cell cancers could be operated T1, T2, and 0, but normally the standard of care has been chemoradiotherapy. So with this, I will go to the cases. So now really comes the oncology part of the thing. So let's go to Dr. Madhu. Sir, unmute, sir. And I request all the panelists to mute and unmute quickly so that we don't waste time on this part of it. Dr. Madhu, adjuvant radiotherapy. When do you do, or you never do adjuvant radiotherapy in today's era? And second question, you can take it. Does technology matter in adjuvant RT?
Sir.
Please answer. Okay, so I'm not able to hear it.
Answering the first question. In post-op, we usually do adjuvant radiotherapy.
You are not audible. Somehow all of the panelists have to come into the range so that we can hear each other very nicely. Please, Madhu. You are stuck. Your video is stuck now. Can I have Dr. Srinivas till Madhu comes into the picture? Dr. Madhu, you need to come into a network area. Your voice is breaking.
All N2s.
No, I want to go
Yes,
to
sir.
the
I
first
am
two
in
questions. I
network
want to go
area.
to first two questions. When do you practice adjuvant radiotherapy or you never do that in operable lung cancer? Does
We do
technology
practice
matter? Does the
adjuvant.
LINAC versus non-LINAC machine matters in this adjuvant RT scenario? Two questions.
Yes, sir. We do adjuvant RT in N2s. Operated N2s, we give adjuvant RT.
So all
And in
N2s you
margin
give adjuvant RT.
positives.
Okay, next.
Yes, sir. And in margin positive primary, we do consider adjuvant radiation. Most of the times after adjuvant chemotherapy only.
Okay. Okay.
And we prefer to do IMRT in such cases to reduce toxicity. And especially there has been a recent study that was discussed in ESMO this year as well, where PORT is not beneficial in N1. So we radiate only N2s in our centers.
Okay. Dr. Kostov, can you take this and take the final comment on this part of it? Do you do adjuvant RT? Where are the adjuvant RT? Do you think there's evidence to show that higher technology have a survival advantage? My question is very specific, survival advantage. Yeah, please take it.
No, so first coming to adjuvant radiation, we have had the 1995 meta-analysis, and then in early 2000 another meta-analysis. So for N2, the subgroup analysis had definitely shown improvement in local control with adjuvant radiation in the N2 subgroup. Now the ART trial, the adjuvant radiotherapy trial, which has been published in the abstract has been published in ESMO, has shown no benefit even in the N2 group, but that is just the abstract form, and we really have to wait for the full test. Adjuvant radiation in N2 can be three types of.
You're still not audible. Your voice is breaking, Kostov. You need to yeah, please.
Of various types. Initial N2, which has not responded to chemotherapy. Initially, stage as N0.
You're not audible, Kostov.
Am I not audible still?
Yeah. Okay. I'll take it till Kostov does it. What he really was speaking about, I driven the meta-analysis, also the recent trial which is coming out. And I'd like to ask Dr. JP when he finishes off to point on this topic. So adjuvant RT, if we look at it, the technology also, the last three have been the LINAC technologies, the machines which have been a criticism that the old ones did not do benefit because of the technology which they used, the machine they used. The LINAC did show advantage on the loco-regional, which Kostov alluded to. And if you look at the OS benefit was really missing. And that's probably the take-home message, that till now we don't have a clear answer really where the adjuvant RT would help. But probably if you do it, even the Astro tells you that the patients will be a positive margin on surgery, and N2 some subsets would benefit, but there is a catch. Those patients who really benefited in the adjuvant RT also were patients who took adequate chemotherapy cycle. There was trial to tell you that when half the patients did not take the chemotherapy cycle, the adjuvant RT really did not work. But this is a work in progress, and we really do not know and where the further refinement would be required. But I would like to ask Dr. JP when he concludes to take this and give the final take-home message. Yeah. Anyone wants to come in quick radiation or any radiation oncologist before I move to the adjuvant chemotherapy?
I agree with you, Dr. Sahu. Like adjuvant RT, there's no OS benefit, but definitely local regional control is better with adjuvant RT.
That's a huge local regional benefit. Yeah.
Correct.
And the LINACs have shown to be superior to the older machines. That's also there.
Yes, agree with you. Yeah.
Okay. So now we come to Dr. Bharat or Dr. Hussain. Adjuvant chemotherapy, what regimen, how many cycles? Quick, Bharat.
Adjuvant chemotherapy is
adenocarcinoma. This is adenocarcinoma.
Yeah. Adenocarcinoma, I'll give 4 cycles and pemetrexed and carboplatin. If you see, most of data in history is more of with EP, etoposide and cisplatin.
So you go for pemetrexed and carboplatin, 4 cycles.
Yeah.
Okay.
4 cycles.
Dr. Hussain, you practice. I was told you're a medical oncologist also. Dr. Hussain? Dr. Mir? Okay. Till it comes in, I will just go off to tell you there has been a meta-analysis which looked at the 5 big trials, and this was the non-pemetrexed trials, and this did show a benefit which is a significant p-value, and the diamond was on the side of chemotherapy. One more important, in stage 1A, it did not have a benefit. So whenever you practice chemotherapy, Dr. Bharat, what would be the size of the tumor beyond which you would adjuvate, you would take chemotherapy?
4 centimeter.
Okay. So this is the take-home message, that anything less than 4 centimeter adjuvant chemotherapy has not helped. 3 to 4 cycles has been a standard. If it is pemetrexed carboplatin, one study is available in adenocarcinoma and they have gone for 6 cycles. Otherwise, it is 3 to 4 cycles. So, quick question to again Bharat or Dr. Hussain Mir, if he is there. I cannot see him through, although if Dr. Hussain can take this, when would you give neoadjuvant chemotherapy? Any patient, when would you give neoadjuvant? All patients, or would you choose your patients when you choose for neoadjuvant chemotherapy?
Basically, it's a tumor board decision. If mostly in N2, if there is a bulky N2 or multi-station N2, then probably yes, neoadjuvant chemotherapy will help, followed by local therapy, be in the form of chemoradiotherapy or surgery. In early stages, if in a tumor board scenario and if the surgeon feels that he is not able to operate, or there is a borderline case of a scenario, then one can think of neoadjuvant chemotherapy. Otherwise, in my practice, I mostly resort to neoadjuvant chemotherapy in N2 disease.
Perfect.
Otherwise, I am not practicing.
Perfect. And that is what the take would be, that when you feel that adjuvant RT is indicated, probably in that N2 scenario, only when neoadjuvant chemotherapy really makes a benefit. If you are doing it below that, probably you will be losing out on giving adjuvant radiotherapy, although there's a controversy on that. Although trials have shown that the benefit is across stages, but because of the adjuvant planning, probably neoadjuvant is the best take only in the diseases which are stage 3, and that's probably where we should stop for neoadjuvant. So, any takers for SBRT or radiotherapy in early operable, let's say the stage 1 lung cancer, and I would like now Dr. Sridhar to come in. Dr. Sridhar,
yeah,
stage 1 lung cancer comes to you, 68, non-smoker, fit, good PFT. PET scan shows 1 centimeter peribronchial lymph nodes, and not diagnostic or not picking up any hotspots on the PET scan, and that is it. Would you just consider a patient for SBRT or refer it to a surgeon, or would you do something before that?
No, there's a single lesion. There is not a node. It's a single lung lesion.
There's a single lung mass, and
lesion.
there is a 1 peribronchial, 9 millimeter. That is what the thing is, and it is not bright.
Yeah. So you need to discuss with the patient the choice of patient. If both the SBRT versus surgery. If it is an operable, like if the patient is fit and patient agrees for the treatment, yes, it is an option for surgery. If the patient has and it's equally, if the SBRT is also equally effective, and if the patient agrees for SBRT, there is no hesitation in considering for SBRT in this case at all.
So I take up when she's the left. There is no hesitation in taking up this case for SBRT. Would you hesitate? Tell me one randomized trial, Kaustubh, where SBRT is superior to the operable lung cancers in this scenario. No, Kaustubh, can you take that?
STARS and ROSES were 2 randomized controlled trials. They tried to do, but they could not accrue. There was a pooled analysis, and in certain stages, actually SBRT did better, but there was a lot of criticism. So ASTRO has come up with a guideline clearly that the first point is, if because of lack of randomized evidence, if it is a medically operable, no other comorbidities, a combined decision should be taken, and the first priority should be surgery and not SBRT. That is the ASTRO guideline. If there is a medical comorbidity, then the option should be given, though the results may be equivalent, but we still lack the randomized data because of failure of STARS and ROSES.
Dr. Subhash from Nepal, would you agree, concur, or differ with Dr. Kaustubh and Dr. Sridhar? Dr. Sridhar was little towards tending, but Kaustubh was more emphatic that yes, he would do. Both of them are actually correct. Both of them are actually correct. Dr. Subhash.
In the present situation, SBRT is not established. It is because of the poor accrual. I don't think the technology is poor, but it's true that we don't have randomized data.
Okay. To be fair to the scenario, there was 3 trials which really wanted to take this up, and as Kaustubh told, they did not recruit even 5% of the intended recruitment. They were stopped. We probably have further studies, but at this point of time, yes, there has been studies that looked into that. There has been series, and there have been a lot of review articles. I could pick up 2 of them. And if this is the scenario, as per the JAMA paper, Probably in this scenario, surgery is the better option to go ahead till we get a randomized proper trial for medically inoperable. That is the scenario that SBRT is good enough. Can I come to Dr. Madhu? If you are doing SBRT, would you do, if SBRT good enough or conventional radiotherapy is also fine, or would you be okay with RFA plus conventional RT? Which do you feel is the better modality?
Currently, I would, the best evidence is for SBRT in stage 1 lung cancer. We would definitely do a bronchoscopy to make sure the nodes are negative in this case. Then go ahead.
I don't know why your voices are not clear. Some of, yeah. Can you come close to the device? Dr. Srinivas.
All those
Yeah,
things
you're
are
audible now. Please,
established. All those things are established, and the clear cut is a stage 1 disease.
Okay.
Yeah, if it is a stage 1 disease, I would vote for SBRT over any other technique. Standard radiation would not be the treatment of choice in this case. I would definitely not consider RFA. SBRT would be the best at this point for him, sir.
Okay, there was a trial that tried. There was a series that compared RFA plus conventional RT versus SBRT. The only point was the toxicity was much better with SBRT, and the 30 days mortality was also much better. So all said and done, although there has been okay things, you can offer a lot of things, but ultimately surgery stands up. SBRT is where you cannot really operate. So that would be my take-home message from this part of it. So now this patient stage 3, we operated adenocarcinoma, went to Dr. Bharat, gave 6 cycles or 4 cycles of primitive carboplatin. On follow-up, had back pain for 15 months. After 15 months, PET scan shows multiple liver, lung, and bony mets. Approach. Dr. Sridhar, would you do a PET scan, or this is a PET scan has shown this? Anything what you want to do? And the patient is symptomatic. The patient is symptomatic for the liver point. There is abdominal pain. Anything what you want to do?
See, the liver functions, the MRI brain is required for this. Probably the MRI liver also is important, because PET CT scan only avidity should not be more. We may pick up some more if the lesions. You need to check it out how much is the liver. If the liver is one of the factors.
Dr. Srinivas, MRI liver, does it sound too far-fetched?
No, I don't think we need MRI liver, because PET CT is going to show liver mets, and MRI brain is definitely mandatory, what Sridhar said. And like what you have put in the next slide.
Even for asymptomatic, even for asymptomatic cases, you do MRI brain routinely.
Yes, definitely.
Okay, okay, we can debate that someday. Okay, treatment options, would you choose one of them?
Yeah, it depends on the molecular signature. So you have to look into the molecular signature and then decide the treatment.
So anyone in the panel believes the molecular signature? Yeah, Dr. Srinivas, Dr. Sridhar, I saw your hand up.
Actually, yeah. So the probably like in lung cancer, irrespective of the stage, when we do a biopsy, the tissue, whatever that is there, the whole lung panel has to be considered. And if it is, including if it is ctDNA, for if it is anything is there for the follow-up, is definitely is going to be helpful. In this case, the 15 months of 15 months, the patient didn't add anything. But yeah, probably the first 2 years may be one of the things which makes a lot of difference in terms of frequent PET CT scan, depending on your 3 to 4 months or 4 to 6 months.
Molecular, if yes, which modality, which technology? Quick. NGS. So I'll stop here, rather go in details of it. It's NGS platform is preferred. You can do the breakup, but tissue is the issue always normally. So please do NGS platform if possible, and finances are not an option. You do a lot of tests coming up in one time. The only drawback is you need 2 to 3 weeks to wait for that. Till that point of time, chemotherapy can be started. If you feel there is an issue, the patient cannot do it. So I now come to Dr. Subhash, then it can go to Dr. Kaustubh and Dr. Sridhar, the last on this. Any indication of radiotherapy in the metastatic setting except for in bleeding or pain? I take those things out. Any role of SBRT in a metastatic disease? Dr. Subhash.
You are talking about the primary, right?
No. Any in the metastatic. Now I'm coming from metastatic setting. I have liver mets. I have four liver mets. I'll take the scenarios different. I have 4 deposits across in the metastatic site, and there are 2 or 3 liver and 1 lung and 1 bone. And the patient is the patient ever eligible for SBRT? Would you consider that? Is the data evolving?
No, we'll consider only if it is oligometastatic.
Only.
Not
Dr.
only
Kaustubh.
that.
Dr. Kaustubh.
Can I add, Dr. Sahu?
Yeah.
Yeah. See, there are upcoming trials with radiation and immunotherapy. So where you still have a role of sorry, Kaustav. Still
No,
have a
sorry,
role
no,
of
no, I was, yeah.
still have a role of SBRT where you treat the metabolically active sites and combine along with immunotherapy. So radiation also has immunotherapy component in it. So I think this is going to be the future, a combination of immunotherapy and radiation and SBRT in even in stage 4 NSCLC.
So, yeah, Dr. Sahu, so Pembro-RT trial, 2 phase 2 trials having positive results in favor of SBRT, and now the NRG conducting 1 phase 3 trial for the local treatment with SGBRT. With that, as Srinivas has said, the future really looks bright.
Okay.
We have to define what is oligometastasis, not all comers, but certain oligometastatic sites.
Sridhar, the last line was my catch take-home slide. This is catch for costume.
Yeah.
Do you agree or do you disagree?
See, it's actually that's what he's talking about. I agree partly, and what I am talking about is already what your experience talks about. So it's very clear. When I'm like, if you just take one step back, your question was in this particular patient where what has happened, and what Subhash has answered is oligometastatic setup as a whole. What Kaustubh has answered is what is the standard practice in favor of SBRT for what is happening. So if you combine all together. Like I'm talking about SBRT in a metastatic setup. So number one is oligometastasis. The definition of oligometastasis is
we can leave that. All of us know that. Number 2.
So multiple areas is the one is also considered oligometastasis.
Okay.
Subhash's point is, are you going to irradiate the primary site in the oligometastatic site? Yes, we need to irradiate the oligometastatic site and include as number as possible. SBRT is possible is the one. My answer for that, when I asked for that MRI liver is important for me, when I'm concerned for an SBRT for a liver, the combination of the PET-CT and the MRI, we have seen that I would like to irradiate maximum whatever the number of liver lesions are there. If it is less than 5, I would like to irradiate all the sites. For that, the MRI liver is required. Answer to your question, SBRT to all the sites, plus if it's the immune PDL1 is positive or immune markers are positive, probably that is the best combination. And
so 2 things. I'll take over. There is data that if you have a very good control, only left with few sites, there could be a data of local regional control if you go for radiotherapy to these sites. There's one data for that. One data comes up what people are talking about, and this is a very good thing which all of us should remember, that has to be less than 4 sites is what the trials have included. If you have a multiple deposits all across, SBRT with immunotherapy is not being tried, and Kaustubh really picked up, and Sridhar alluded to that also, that we should be doing, and the future could be there. There are trials, but we still need robust trials, but there is nothing to correlate with the PDL1 status. This technology, this thing has worked beyond the PDL1 negative and positive. The basic thing is to make the cold areas hot for immunotherapy, and that's what the concept comes for the SBRT. That's probably where it is. So I'll just move on. And tissue versus liquid, I will just skip, and I'll come down to Bharat for the last part of it. 2 minutes more left with us, 3 minutes. The mutation analysis comes back at exon 19. PDL1 is positive for 52%. Bharat or Dr. Mir. Dr. Mir first. What to do? The patient has exon 19 mutation, PDL1 for 52%. What to do? Quick. Osimertinib, gefitinib, afatinib, immunotherapy plus minus chemotherapy, gefitinib plus chemotherapy, or chemotherapy only.
Difficult call. I feel it's a difficult call. Both the things are positive. So I'll because the disease load is high. I'll go with the chemo plus immuno.
Okay, Bharat.
Yeah.
Bharat, you told that.
Yeah.
Oh,
chemo plus immuno.
Dr. Mir. No, see, I somehow I hate to differ with Bharat.
Yeah. I also. Yes.
I went very fair on scientific ground. If you have a driver mutation positive, do not try immunotherapy on the first go. Ever. Please go for one of the targeted therapies.
Yes.
Immunotherapy should be left only for
negative,
when your options are lost. I'm very sorry. I'll move on. I don't have time for that.
Okay.
We started osimertinib. After 22 months had progression, what to do? Bharat, again, would you like to do a liquid biopsy again for something?
Now immunotherapy.
Hello.
No.
I can't hear
now,
actually.
Yeah, please, Bharat. Yeah. So what we normally do is look at the liquid biopsy once again to look at the mutations and try to do, and chemotherapy probably is a good option here, and immunotherapy I'll still defer it to the last part. But there is data from IM Power that we can use Pacli, Cabo, bevacizumab, and atezolizumab.
Yeah.
So I'll just stop it here, and I will conclude. Is there anything which we missed, which is a burning topic in 30 minutes with this panel? I thought I tried to cover most of the burning topics. Dr. Kaustubh, any quick word? Dr. Srinivas, any quick word?
So perfectly done. Yeah, perfectly done. I think. Yeah.
So I'll conclude, and then I'll ask Dr. JP to just take home the what I could do, not take up. Inoperable disease, PET scan and mediastinoscopy. EBUS also plays a big role. EBUS FNA also does a good role. SBRT, inoperable cancers only in medically unfit, as the panel really pointed out. It looks good, but trials are lacking. Adjuvant RCT in tumors more than 4 centimeters. Adjuvant osimertinib could be given now with ADURA trial coming up in adjuvant setting, stage 2, stage 3. It's a good PFS data. Adjuvant RT to be considered in probably N2, that the data is still lacking, but all of us feel N2 is a disease. Positive margins, no question about it. Neoadjuvant in stage 3 probably. Then last slide, biopsy is a priority in advanced disease, mutation analysis, especially in non-squamous. SBRT, we spoke a lot. The future probably lies there. We could do something more. A frontier that could not be conquered probably can be little bit best conquered with SBRT, with immunotherapy to select patients in an oncogen-driven NSCLC as per driver mutation. Never try immunotherapy in first go. Avoid immunocheckpoints till the last. And that's where I stop. And thank you, organizers. Thank you, panelists. If I missed someone, not given enough time to someone, I'm sorry. Dr. JP, it's all yours.
Thank you.
Dr. JP sir, for quick word comment, sir.
Dr. Tarini, excellent job in a brief time. And I must congratulate. All my opinions, I have put it forward on my chat. So you can have a look on those things. And in the interest of the time, I still recommend what we should also concentrate is palliation, which has been missed, I think, at some point of time. And it's purely because of the time issues.
Yeah.
Palliation to bone, brain, how to do it, apart from the oligometastasis, is a very important factor for all radiation oncologists or oncologists in general. And I hope with this, we conclude this session. Thanks. Thank you, everybody. Thanks
Thank you, sir.
for the opportunity.
Thank you, panelists, and thank you, Dr. TP Sahu, for agreeing to do this. Thank you.
So do we move to the next session?
Yes, sir.
Yes, sir.
Deepak, permission?
Yes, sir.
Okay.
Now moving on to the next session, we have Dr. Shyam Agarwal, sir, who's medical oncologist from Delhi. He'll be speaking on lung cancer, working towards increased survival. On the chair, I would request Dr. JP Agarwal, sir, and Dr. Suresh Kumar, sir, to kindly chair the session.
I welcome Dr. Shyam, and I think he's really a genius, a very well-read, very comprehensive person. I've seen him with the personal touches with the patient. I really welcome to him on this very important session. Dr. Shyam, I, along with Dr. Suresh, welcome you with open hands, sir.
Thank you, Professor Suresh, for your kind introduction. I think we are running behind schedule, and so much of development which has happened in lung cancer, improvement of overall survival. I think we're going to be focusing on overall survival. And before I begin the talk, I must thank Deepak and the organizers for Krabicon, who have been instrumental in organizing a conference year after year. And in spite of COVID, they have successfully conducted this conference as well. So I'll take you through a flurry of slides where I think by and large new things and the survival benefit in lung cancer will be shown. So I think you have the slides. Can you show my first slide, please?
Ravindra, show slides.
Can we have Dr. Shyam's slides, please?
Yeah. So can you put it full screen? Okay. So this is, what we have today, in the last 3 or 4 decades, from one entity to several entities in lung cancer, non-small cell, and then histology, and then molecular, which I'll be talking about. And now we are talking about PDL1 and TMB. Next, please. Next slide. So I think, as was discussed in the previous discussion, a biopsy is critical for establishing the diagnosis. And now, of course, you need the tissue, particularly in adenocarcinoma or non-smoker squamous cell carcinomas, to look at these markers. And I think it is very, very important before we proceed to any treatment for lung cancer, particularly non-small cell, we should have these panel of molecular biomarkers. Next, please. So I think I'll talk about these, but these are the markers we are looking at: EGFR, ALK, MET, HER2, ROS1, BRAF, RET, NTRK, and these are upcoming like PIK3 and MEK1. Next, please. I think you're all aware of all of the data, but I'm just going to put it in a capsule. So this is EGFR, ALK, ROS, BRAF, NTRK, RET, and MET exon 14. So these are new things which are coming up now, and the approval has come from FDA recently for these two molecules. One is capmatinib, and I'll show you the data. Next, please. So I'll go, mutation by mutation. So this is EGFR mutation. As you can see, the incidence in Northern Asia and South Asia is around 30 to 40%. And we are looking at exon 19 and exon 21 in about 90%. Next, please. So I think we've come from IPAS to FLORA and even beyond. I'll show you the data. Next, please. So this is the FLORA study. You see here, so we are focusing on overall survival. So for the first time, osimertinib has shown superiority to gefitinib, and the overall survival is to the tune of 54 versus 44. So osimertinib stands out there. Next. So now the other drug which is recently launched is decometinib, where you see 34 months versus 26 months in a randomized trial. So decometinib is also giving you overall survival advantage. Next. If people can't afford drugs like decometinib or osimertinib, next slide, please. So you have this combination of chemotherapy and gefitinib, which came from Tata Memorial, where you see the overall survival better with gefitinib and PEM carbo combination than gefitinib alone. So I conducted a lot of these webinars and part of the panel discussions, and a lot of doctors use this combination of Gef and PEM carbo because most people can't afford drugs like osimertinib. Next, please. So the other thing which is upcoming is the use of TKIs and VEGF inhibitors. For example, erlotinib bevacizumab or erlotinib ramucirumab. But again, these are expensive. Next, please. So now coming to the ALK gene rearrangement, which is there in about 3 to 4% or up to 7% of cases of adenocarcinoma. And as you can see, alectinib, which is more expensive yet available, is better than crizotinib, which is now readily available for our patients. And similarly, ceritinib. Next. But I want to draw your point to this, this attention to your point that the kind of mutations which occur in patients who are exposed to ceritinib or alectinib are different. So G1202R, this is more stubborn mutation than as compared to crizotinib exposed patients where G1202 is much lower. And finally, next slide, on ALK mutation is the CROWN study where lorlatinib was compared with crizotinib, and this data was presented in this ESMO, and the results are mind-boggling in patients with brain metastasis, where a complete response of 71 in the brain metastasis was seen with lorlatinib. So it's a wonderful drug. It's available now, particularly in second line. But you have to look for data for the first line in comparison with crizotinib in the near future. Next, please. The next mutation is ROS1 mutation. Next. So you have crizotinib available. You see 72% response rates, and ROS is in about 1% of patients of lung cancer. Next, please. Next. So ceritinib is also effective in ROS1. Again, 70%. And so lorlatinib in second line. Next, please. Next, please. So, you're using these drugs in a sequential fashion to improve upon the survival of a patient who has ROS1 mutation. Next, please. So we are talking of, 3-4 years of overall survival, which was unheard of.
So BRAF mutant, again, 1 to 2% of non-small cell lung cancer. And you see, V600E is around 50%, and that's where the drug is effective. Next, please. And this drug has also become available, by and large, to be used mostly in second line. Next, please. So you see, again, in second line, dabrafenib or trametinib is effective in 63%, and after chemotherapy, 9 months of progression free. So chemotherapy, dabrafenib, trametinib gives you a survival of beyond 2 years. So, that is what you're focusing on. Next. So we must do these BRAF mutations. Similarly, CMET mutation, several drugs. I think I showed you, capmatinib. Next, please. We'll rush through these slides because the incidence is so small, but you need to be aware of this. So crizotinib does work, 32% response rate, but you have a better drug, which is capmatinib or tepotinib. And actually, these drugs are available on compassionate use. Next, please. Next 2 or 3 slides, please. Next, please. I'll just rush through these. So, this is see here, tepotinib, where the response rate is, much more than crizotinib in the first line and second line, 60% and 60% here. Next. So, look for these MET exon 14 mutations to use these newer agents. Next, please. So this is RET mutation. Again, next is there in 1 to 2% of non-selected, non-small cell lung cancers. And you need to, this can be detected again by NGS or by FISH. Next. And the drug has been recently launched, which is LOXO 292, selpercatinib. Next, please. And you see a response rate of over 60 to 70%. So this is the, the duration of response. You see almost at 3 years, the progression-free survival is almost there. Next, please. So NTRK mutation, again, is to be reported in the NGS. Next. There in about 1% of lung cancers, you see here. And drugs like entrectinib. Next, please. So these are tongue twisters, these names, but then I think we need to be aware of those. Next, please. Next. So this is entrectinib and larotrectinib. You see a response rate of around 80%, as you can see here. And even the drug crosses the blood-brain barrier. Next, please. Next, please. So now, as I was saying initially, that adeno-CA is not one disease. You need to identify either of these mutations in your patient and choose an appropriate agent. Next. So now coming to the data on patients who do not have driver mutations in lung cancer. Next, please. So there, the role of chemotherapy is still there and immune checkpoint inhibitors. Next. So there are 4 or 5 slides or categories there. So patients who test positive for PD-L1, and that should also be done initially along with these driver mutations. So if somebody has more than 50% PD-L1 positivity and there's no driver mutation, there are 2 drugs which we can use. Next, please. So pembrolizumab in 024 study has clearly shown the overall survival advantage as compared to chemotherapy. So anybody who has PD-L1 expression more than 50% should be given either pembro, next, which is expensive at this time, but you have atezolizumab, which in May 2020 was granted approval, and you can see the overall survival advantage for TC2 or TC3 patients in patients who are exposed to atezolizumab. So this also is available and I think is FDA approved at the moment. Next, please. So for patients who have no driver mutation and patient is PD-L1 negative, so which is going to be a common scenario. So you see here, pembro plus chemo is better than chemo alone. So patients who don't have a driver mutation, who are PD-L1 negative, should ideally be given an immune checkpoint inhibitor and chemo, and you see the survival advantage. And there is the approval, FDA approval for this. Next, please. So similarly, you have in adenocarcinoma, PD-L1 negative. Next, please. The role of pembro and chemo, which is pem-carbo. Next slide, please. Okay, so again, you see here the overall survival in favor of, not only the other trial is pembro, the atezo, carbo, pacli, and bev is better than chemo alone. So in adenocarcinoma. So these drugs are all available. Next, please. And we are using them in our day-to-day practice at this time. So this is key 189 to show the pembro, carbo, and pemetrexed as compared to chemo alone. And this is superior. You can see the survival. You can see the plateauing of curve. It's so very important here in patients with immune checkpoint inhibitors. So I'll show you the slides there, that patients who are exposed to targeted drugs, as I've shown you, so they tend to die out at 3, 4, 5 years. But this is something unique with immune checkpoint inhibitors, that 20, 30, 40% 5-year and beyond survival is now being reported with immune checkpoint inhibitors. That is the plateauing of the curve. Next, please. So no driver mutation in non-small cell lung cancer, PD-L1 negative. Next, please. So now I spoke about the chemo and immune checkpoint inhibitors. So now, what is happening is Nivo-Ipi, which is the immune combination. So which is very important because you're sparing the chemotherapy here. So if Ipi was available, which I'm told is going to be available in the next 2 or 3 months, so one should think of Nivo-Ipi rather than chemo immuno, because you can use the chemo subsequently. Next, please. So you can see the overall survival advantage with Nivo-Ipi than as compared to chemo. So this is a viable combination. Next, please. So similarly, you have small dose of chemo and Nivo-Ipi. Next, please. This is the LA9 study, checkmate. And you can see Nivo-Ipi with small chemo. This is not full chemo. There are only 2 cycles of chemo there. And you just are better than chemo. And then you can continue with immunotherapy and use chemo again at the relapse setting. Next, please. So I think this is the the current paradigm. If you have PD-L1 high, you can use a PD-L1 inhibitor with or without chemo. But if the PD-1 is either negative, even squamous, non-squamous, you can use a combination of chemo and PD-1 inhibitor. And as I've shown you, even an immune combination when Ipi becomes available in our country. Next, I think the last few slides. So small cell lung cancer, again, there is use of atezolizumab with chemo, which is better. And I think it is approved and we are using it. Next, please. So the final specific study where stage 3 inoperable has shown durvalumab better in the adjuvant setting after the chemo radiation than chemo alone. Next, please. So this is the last part of the talk, which is the EGFR positive. I think it was mentioned, ADORA study. Next, where osimertinib was used in patients with stage 1B, 2, and 3A. And you see the progression-free survival and hazard ratio of 0.21, not heard of. So this is actually an amazing trial which is being reported on PFS. The overall survival will come in, but this is in comparison to placebo. Next, please. And this is the forest plot showing you the benefit in patients with stage 2, 3, and 1B in favor of osimertinib in the adjuvant setting, improving survival dramatically. Next, please. So I think I've covered most of the talk here. So you can see we are here actually 20% overall survival benefit with a combination of immune checkpoint, therapy with chemo or IO combination. But you want to lift the curve to 50%, 60%, 70% with various other combinations, and better understanding goes up. So, it's a huge improvement. And this is what I was talking about, that when you use the targeted drug, most of the people die out at 3, 4, 5 years. But that's not the case with immunotherapy. So I think we've come a long way in improving survivals in patients with lung cancer. The last slide shows you a publication from NEJM, where they reported in August 2020. Next, please. I think there's another slide. So I think the conclusion is must check for driver mutations before starting treatment. And drugs and targets are increasing rapidly, and therefore you should go for NGS now, because NGS gives you the opportunity for testing those 10 markers rather than sequential testing, because you will miss, because you're only doing 3 when you're doing sequential. For example, EGFR, ROS, and ALK, but you're missing on RAF and NTRK and RET and MET and so on. So ICS can be used, immune checkpoint inhibitors can be used in wild type lung cancers, either alone or in combination with chemo. And the survivorship is going beyond 5 years in patients with advanced lung cancer. So I think this is a spectacular development in lung cancers, where until about 30 years ago, the survival used to be just 6 months. And now you're talking of 4 years, 5 years and beyond. So I think I stop here, and thank you very much for my invite and the opportunity. Thank you very much.
Thank you, sir. I think in really last 10 years, there is an explosion of the data, sir. I will still say it's an implosion which is happening. And believe me, to come to the real clinics, it may take a very short time. And the drugs are becoming cheaper. They are becoming generic. And I hope it will come down to the last patient who can afford this drug. And I really thank you for showing so quickly all the hard work of so many investigators in such a short period of time. Thank you, sir. I hand over to Dr. Samir, my good friend Samir, if he wants to say something. Samir?
Dr. Samir?
Over to you, Nikita, then.
I think so. We've lost his video, sir.
Okay, so over to you. So we conclude this session with a grateful to everybody, including you.
Thank you, sir. Thank you, Dr. Sham. And thank you, Dr. JP Agarwal, sir. Moving on to the next session, we have Dr. Samir Kol, who's surgical oncologist in Delhi. He's going to speak on role of surgery in advanced renal cell carcinoma. Sir, are you online, sir?
Can you hear me? Good morning.
Yes, sir. Yes, sir. Good morning, sir.
Okay, I join everybody. Good morning. Thank you, Quebecon. Thank you, the OncoTELE-ONCOTHON.
Good morning, sir, and thanks for accepting our invitation. It's our honor to have you on board.
And it is really nice. I'm joining you from a beautiful early autumn morning in Kashmir, where the sun is just shining through and a little bit of cold. But like I say here today, I'm going to start with a disclaimer. And the disclaimer is, ladies and gentlemen, in the chair, particularly Dr. Ashraf and others, the research in the evolution of surgical oncology as far as trialing is concerned has not kept pace with the degree of trialing that happens in medical oncology. Now that's particularly relevant to the topic that I'm going to talk to you now. And the other disclaimer is that instead of talking to you about advanced renal cell carcinoma, which will be very difficult for me to do justice with over the next 15 minutes, I would like to talk just specifically about surgical metastectomy in metastatic renal cell cancer. To be a little more specific, let me not talk about the primary source, and let me not talk about neoadjuvant trials and other, because it will make it too vast for me to understand. Now, is there, just to give you because we are moving from lung cancer and Shyam Agarwal and his fantastic figures and the kind of research that has happened with lung cancer to an area where probably in targeted therapy, we have made some advances, but as far as surgical evolution of treating renal cancer is concerned, we haven't kept pace with the developments. Yes, the methodology has changed from open surgery to more minimalistic windows, but one sequencing in the current scenario, because if you remember, the role for metastectomy in metastatic renal cell cancer came from two trials, and both had the MD Anderson. Just a glance that renal cell cancer anyway is between 2 to 5% globally of all the cancers that take place. And when it presents, the synchronous metastasis is to the tune of about 30%. And metachronous another 30 to 40%, which means after some time, when you've treated the primary in someone who didn't have metastatic disease, there is a 30 to 40% chance of developing metastatic disease over the next 2 years. And then the 2/3 of these metastatic sites, they are multi-site. They're not oligometastatic. They're in more than two to three places. And if you talk about the sites, we obviously the highest score goes to the lung, 45 to 60% metastasis in the lung sites. Bone has another 30 to 40%, and lymph nodes have about 20 to 30% incidence, and liver is nearly the same as the lymph nodes. And of course, adrenals get about 8 to 10%. Brain gets something like 5 to 10% of these metastases. And there are some unusual sites also, as you will see, thyroid, pancreas, and testicular tissue, anywhere in the body. But we're mainly talking about lung and bone. And we all know, I mean, traditionally we've been defending this realm for surgery because we all know renal cell carcinoma is basically not a curable tumor if you treat it with chemotherapy and radiation. It has never been. And in fact, surgical metastatectomy has been in vogue when, Barney and Churchill did the first lung metastatectomy for renal cell cancer, 1939. It's been there ever since. And even today, complete responses to targeted therapies are rare. I'd like to hear from my august gathering of medical oncologists, how many complete responses, even after such beautiful advances in targeted therapy, have we been able to achieve? Metastatectomy in solid tumors only began the first only two randomized trials, and both not in renal cell cancer, were reported from the MD Anderson Cancer Center long back. One, I think, was for non-small cell cancers, and the other was castrate-sensitive prostate cancers. Now, because we live in a civilized world, so what do the guidelines say? Let's look at the NCCN guidelines, which are followed mostly. They clearly advise that the surgical metastatectomy for oligometastatic clear cell and non-clear cell disease both. Although we all know that the outlook with the clear cell is much better than with the non-clear cell disease, particularly the sarcomatoid variety, doesn't do well. Look at the ESMO guidelines, surgical metastatectomy for oligometastatic disease, when they have identified some prognostic factors, which are supposed to be predictors to how we are going to do with post-surgical survivals in these situations where we operate, where they say that some things are universally agreed on in various consortiums, like interval after your first treatment, if your metastasis appears after 2 years, 1 to 2 years. Some people use the 1 year cutoff, some use the 2 years. But most important, all of them tend to use completeness of resection. If you are able, through your radiological and your clinical input, to ensure that whatever you're going to resect in the metastatic site is going to be a complete R0 resection, then you're probably on. And a low pathological grade helps, because it's about the biology of the disease. The survival indices clearly follow the biology of the disease. And disease control, if you can, after you've operated, get your systemic therapy, particularly your tyrosine kinase inhibitors, VEGF inhibitors, in some sequence or the other to control the disease as a whole, then yes, go ahead with surgery. Saying that don't think of surgery as a be-all and end-all. Think of it as one cog in that wheel. Look at the other International Consortium Against Metastatic Renal Cell Cancer, again a 6-factor consortium. The primary size of the tumor, the bulk of the disease, the age of the patient, the comorbidities, and of course, various, some of them use the neutrophil score, the calcium score, the LDH score. So these are various prognostic indices that are still used to kind of give you an idea of how, as a predictability to what's going to happen after the surgery. And of course, now I must mention in this era of NGS, molecular subtyping of the clear cell disease, renal cell carcinoma. There are clearly 4 types identified based on their RNA quantifications. And it's very well known that 1 and 4 do not do as well as 2 and 3 do. Not only with surgery, but even with tyrosine kinase inhibitors that we use with them. It's clearly known. So maybe we are getting there. We are trying to find out subgroups. We are trying to find out patients who will actually benefit from using surgery as one of the things in the armamentarium. So as far as surgery is concerned, ladies and gentlemen, what is our current body of evidence? Can I have the next slide, please? Can somebody move the next slide? Yeah. So what is our current body of evidence? There, unfortunately, are no double-blind, randomized phase 3 clinical trials to talk about. All that I have for you, ladies and gentlemen, is a meta-analysis, retrospective, sometimes single institution trials with very biased data. But when you do these there are about 44 studies that have been looked at through the various electronic databases, and they're all retrospective. And we've been focusing on disease-free survivals and overall survivals as endpoints. And what I talk about holds true in 10,000 patients who've been observed. The median overall survival when you use surgery as one of the cogs is something between 36.5 to 142 months if you do a complete surgical metastectomy. That's why I'm again insisting completeness of surgery is an important part. And look at the paltry figure of 8.4 to 27 months if you do an incomplete surgical mastectomy. Huge difference. A decrease in mortality when you use surgery is significant. It's almost about 97% confidence intervals. And of course, there are case series. You can criticize it. You can say these case series are small, they are moderate sized, and of course, you have to account for patient heterogeneity, which we haven't in this. Let me go at it site-wise very, very quickly. I've put before you the various figures. Let's say the most commonly done lung sites. Lungs usually in the parenchyma, but you have incidence of metastatic disease in the mediastinal lymph nodes, which just makes it worse. But lymph node involvement, incomplete resection, and if there's multifocality and the size of these metastatic tumors in the lung, and of course synchronicity, these are all factors which mitigate against it. Look at the Mayo Clinic numbers or even the Heidelberg series. There is a huge difference. There's a 19% overall survival, incomplete resection. So I'm just saying that lung, Burney and Churchill did it in 1939. We still do it, but it has to be a decision which is clearly made out by looking at various figures. Look at, for instance, the surgical metastectomy for bone mets. Palliation and preservation of function is the only time that I would go for it. Would go for it. And the reason is that axial skeleton, where the spine and the pelvis is concerned, these are very, very bad because they take very long times and you can't get onto systemic therapies for long periods of time, many complications. So basically palliation, preservation of function is the only time that you would go in for something like that. And liver mets, again, not so good because more than 1 to 2. We do hepatic resections lots of times, but the thing is, so what I'm saying is, again, in the liver, we end up with incomplete resections and our margins come positive and there's a recurrence soon after. Patients don't go on to systemic therapies for long times. So wherever literature support, brain mets, again, most of the times, ladies and gentlemen, when it goes to the brain, it's in the choroid plexus and it causes a bleed in the plexus, and that's how you recognize it most of the time. But yes, and you compete for surgery with something like SBRT today, or with whole brain irradiation. So I would say, I think the slides are not moving. Okay. So there are no large series, and max with a single excision of a single focus in the brain, we mentioned overall survival of about 5 years, of just about 12%, 5 to 10%. But yes, I mean, if there is a solitary met and it's in the periphery, you can get at it without creating problems, then yes, go ahead and have a surgical resection. Unusual sites, pancreas. Outcomes are favorable in pancreas, but there's no improvement in overall survival because, like I said, and we all know that even this holds true even for the cytoreductive surgeries like HIPEC and all that we do. The outcome depends basically on the biology of the tumor, and pancreatic biology, tumor biology somehow is not shaping up. Now, therefore, ladies and gentlemen, a very precise topic. The benefit of surgical metastectomy is controversial. because there's lack of high-level index regarding survival benefits as on today. And currently published reviews support surgical metastectomy because there is no better. We know no better. Complete surgical metastectomy at the moment, as we observe, does improve survival when you sequence it well. And of course, integration of surgical metastectomy with the currently evolving targeted therapies seems to be a very valid option, and we need to look at it. Current studies suggest additional therapeutic value of surgical metastectomy prior to targeted therapy in intermediate risk metastatic renal cell carcinoma. That's what the RESORT trial seems to be pointing at. And of course, risk stratification is the key, and it has to be a multidisciplinary decision making. Thank you very much.
Thank you, Dr. Sameer. Any question for Dr. Sameer?
Over to the chair if they want to ask some question. Or we can start with next.
Can we proceed on to the next session if you don't have any questions for him?
Thank you very much, sir, for sparing your valuable and precious time and giving us this words of wisdom about renal cancer.
Can we move on to the next session, please?
Yes, please.
Okay. For the next session, we have Dr. Ankur Bhatt.
One second. Sir, I request you to be there during valedictory function. It will be late by, I had asked you to be present at 2:30, but it will be late by, I think, 20 to 30 minutes.
Oh, I will try.
Thank you.
Thank you.
Thank you.
Thank you.
Okay, for the next session, we have Dr. Ankur Bhatt. He is medical oncologist who would be speaking on immunotherapy in head and neck cancer, the recent developments.
Just a second. Yeah, can you hear me and can you see my slides, please?
We can see your slides, sir. Can you full screen view, sir?
Thank you. So thank you, Deepak, and thank you, the organizers of Trabicon. It's wonderful seeing you in all the years which have come through, and missing the hospitality of Deepak, which we see in Jammu. So the topic given to me is immunotherapy and in recurrent metastatic head and neck cancer. And I would like to take this opportunity to actually take you that with all the options of chemotherapy, targeted therapy, which includes cetuximab, and the various options of immunotherapy, how to choose the right patient and how to choose the right conducive environment to get the best survival of our patients. And this 15-minute talk will be on that only. So the first line landscape in recurrent head and neck metastatic cancer, as we have seen in last decade or so, a huge change. It's a paradigm shift in the armamentarium of the options which we have. Earlier, head and neck cancer was supposed to say that it's not as much as chemosensitive, but now with various options of platinums, 5-FU taxanes in combination with cetuximab has given us advantage. So we have exploited that advantage, which was called as extreme regime in last 10 years. However, there is always a resistance to this chemotherapy and targeted regime. And then came the immunotherapy agents, the nivolumab, pembrolizumab, and various others in the pipeline, which has given us a ray of hope. And this talk will actually tell us how to choose whether we should give cetuximab chemotherapy combination or we do a precision oncology kind of thing and do PD-L1 assessment and go for immuno alone or immuno plus chemotherapy. So as I said that in the chemotherapy part, not much advantage till late 2005 or 6, then came the extreme regime, which actually gave us the advantage of adding a targeted therapy, which was cetuximab, which was anti-EGFR therapy to our chemotherapy backbone. And it gave us a survival benefit of around 2.8 months with respect to chemotherapy alone. So when cetuximab was added to chemotherapy, it gave us a PFS as well as OS advantage, as well as quality of life advantage. And it was published in NEGM 2009. Then we have came of a data of checkmate and keynote trials, which was given immunotherapy in second line agents. And then we have multiple options and all those things which we'll be discussing. So this is the same paradigm shift. Just hold on for a second. Just hold on for a second. Let me close the door. Yeah, thank you. So it was, so as this PowerPoint says that in last 2 or 3 decades, except cetuximab, there was no much advantage given. And this was the extreme regime, which was published by Womakon in 2008, clearly saying that 10.1 versus 7.4 months overall survival benefit when cetuximab was added to chemotherapy, and then cetuximab was continued till progression. It gave us a disease control rate of 81% and an overall response rate to the tune of 35 to 40%. The cetuximab and chemotherapy arm also improved the quality of life, improved the symptoms, which was social contact, eating problem, speech problem, sense problem, and the sexuality problem. So extreme regime used 5-FU based combination with platinum and cetuximab. And if the patient is not suitable for 5-FU in view of the cardiac morbidity or in view of very GI toxicity, then we have taxanes which can replace 5-FU. And we have various studies, the GORTEC studies and the TP extreme studies, which say that 5-FU can be omitted with a similar or rather better overall survival or the PFS survival. So these are the multiple number of studies which have used taxanes in combination with platinum and 5-FU, the extreme regimes, the TP extreme, which was taxane based, the GORTEC studies, and to the extreme right is my study, which was published in Head and Neck this year in January, where 140 patients of recurrent head and neck cancer in combination with cetuximab and chemotherapy gave an advantage of 11.8 months survival advantage compared to 8 months when chemotherapy was not used. So this is a TP extreme regime. And if we compare TP extreme to extreme regime, the TP extreme is better in the sense that no chemo port or no PICC line has to be used. And the cetuximab in maintenance therapy can be used 500 mg per meter square in compared to 250 mg per meter square. And only 4 cycles were used in TP extreme rather than 6 cycles in extreme trial. So the TP extreme have a more favorable safety profile, higher compliance rate because of no hospital admission, and had a similar OS and had a similar PFS and a similar overall response rate. So TP extreme, which can be given very easily in daycare, is preferred therapy all over the world, particularly in Indian setting when the patient load is heavy. So this is our publication, which we done from Max Hospital, 6 cycles of chemotherapy, which were 220 patients were being used, and 140 patients were given chemotherapy and cetuximab, and 80 patients received only chemotherapy. This was the various combination of chemotherapy and cetuximab combination, paclitaxel, cisplatin, 5-FU, methotrexate, single agent methotrexate. So we clearly had with chemotherapy and cetuximab, our response rate increased from 44 to 77%. Our PFS was 8.1 versus 6.1, and our overall survival was 11.8 versus 8 months. So this is not the topic of today. The topic of today is immunotherapy, but I have to make a basis of this immunotherapy. So this was Keynote 048 study, which was having pembrolizumab monotherapy, pembrolizumab plus chemotherapy, and the extreme regimen. It was 1:1:1 randomization of 882 patients. So clearly saying that in Keynote 48 trial, 43% of the patient had CPS more than 20%, and the TPS score more than 50% was seen in 23% of the patient. So CPS, TPS, these are the things which our pathologists need to tell us, and we have to ask these scores when we are treating recurrent head and neck cancer. So these are the biomarkers which can differentiate whether our patient will be responding to immunotherapy or not. So clearly in these 2 charts, when the CPS score is more than 50%, the responses rates are more. And if the CPS score is less than 20 or less than 1 to 20, the overall survival and the PFS response is not that great if the CPS is more than 20. So the point is whether we will use cetuximab in our combination or we will use pembrolizumab, so extreme or Keynote 48. The Keynote 48 response rates was similar to extreme. However, the progressive disease was doubled. So the the patients not responding to IO and chemotherapy were doubled up, as if it's an indirect comparison if we do to an extreme regime. So PD was higher in Pembro plus chemotherapy arm vis-a-vis in extreme plus chemotherapy arm. Similarly, if we use a monotherapy as per Keynote 48, the progressive disease was as high as 30 to 40% as compared to just 9 to 12% in extreme. So it's a very high calculated risk of using IO plus chemotherapy or IO alone as compared to extreme. So we have to be very cautious. We have to choose patients who have a high CPS more than 20% as compared to those who have less CPS PDL1 scoring. So TP extreme is similar to Keynote 1 in terms of overall survival, which was 14.5 versus 13 months in Pembro plus IO combination. So we have to choose our patient very correctly, which patient require more cytotoxicity, which tumor patients require more reduction of the tumor, more pain relief, more swelling relief. So can Keynote 48 be extrapolated to Indian population? Yes, there's an answer to that. In ESMO 2000, ESMO article last year, it was published an abstract which says that the first line Pembro for recurrent metastatic head and neck cancer, Asian versus non-Asian. So it was clearly seen that Pembro plus chemotherapy versus extreme, the hazard ratio was 1.03 and the graphs were kissing each other. So there was no survival benefit in Asian subgroup. However, in non-Asian, it was in favor of Pembro plus chemotherapy arm and the hazard ratio was 0.71. So that has to be looked with great interest to our population. So our response rates are to the tune of 50 to 70%. Our paper showed 77%. A paper from Dr. Rangarao showed 82%, which is comparable to extreme regime, which was around 40 to 50 or better. So what is the right sequence of recurrent squamous head and neck cancer? Shall we give cetuximab or chemotherapy first, then give IO, or straight away we should go for IO plus chemotherapy, the Keynote 048, and then followed by cetuximab, for which there is no data to it. So this answer was given in ASCO 2020, this year only, and they say that extreme regime versus TP extreme. So what is difference in extreme and TP extreme is the taxanes. So those patients who have given extreme regime followed by IO, there was no survival advantage. So I'm repeating, cetuximab, cisplatin 5FU followed by IO, no advantage in survival. However, the TPEX regime, taxanes, platinum, and cetuximab followed by IO gave us an advantage in overall survival. So the reason behind it was that taxanes causes a shedding of the neoantigen, giving more T lymphocytes, more PDL1 expression, and more response to IO. So this could be a hypothesis why TP extreme followed by IO was given a
Sunidhi, I'm not getting the audio.
Yes, sir, we are calling Dr. Ankur. Actually, there is some issue from his side. We are calling, sir. So he is connecting, sir. There is some network issues from his side. He is connecting in 2 minutes.
So I think I'm audible now.
Yes, sir, you are audible, sir.
Yeah, thank you so much and apologize for this thing. Just a second. Yeah, so what I was talking about, TPEX and extreme, if we use immunotherapy after extreme and if we use immunotherapy after TP, so we get an advantage after TP extreme. So that has to be seen. It's favorable in our environment. It's easily daycare friendly, and followed by IO gives us an advantage rather than not using taxanes upfront. Yeah. So what we need more clarity on Keynote 48. Keynote 48 is not conducive to Asian population, and our tumors are different. Our tumors are a biggest tumor. Our recurrent head and neck cancer are not same as in European or American. So a second line sequential regime, which was clearly demarcated in ASCO 2020 poster, PDL1, which is the best biomarker, a CPS score or a TPS score, a better patient selection, CPS more than 20%. Do we need an additional biomarker, a high TMB or a high MSI, which we haven't talked about much in head and neck cancer? And certainly the response rates. The response rates are higher when we use a targeted therapy with the chemotherapy rather than IO plus chemotherapy. So Keynote 048 had a more progressive disease if we do an indirect comparison to TP, and certainly hyperprogression or pseudoprogression. Some studies says that we don't see in head and neck cancer, but in our clinical practice, we see the cabbage-like tumor coming up immediately after 2 to 3 cycles of Nivo or
Sir, can you
Pembro.
please share your screen, sir?
Oh, it's not coming.
Yes, sir. No, it's not coming, sir.
So I have just 2 minutes. I can speak, madam. I can speak. It's something problem here.
Okay, no issues.
Okay. So in recurrent second line in recurrent head and neck cancer, so when we have used cetuximab and chemotherapy upfront, we have a huge data of nivolumab and pembrolizumab in the form of Keynote 141 study. So which says that Keynote 55 and Checkmate 14 in one study. The Checkmate used nivolumab and the Keynote 055 used pembrolizumab. So both these studies, when given second line immunotherapy after cetuximab or chemotherapy alone, gave us a OS and a PFS advantage. PFS advantage of around 5 to 6 months or 8 months in one study, and the Pembro gives a PFS advantage of 5 to 6 months and an overall survival of 8 months. So it is very prudent, and we should be judicious using IO upfront or IO second line. In my practice, I have a tendency to use cetuximab and chemotherapy upfront and use IO in the later on, and IO plus chemotherapy at times with taxane in the second line therapy. So there are various studies which are coming with the use of durvalumab in phase 2 study, atezolizumab in the stage 3 and phase 2 study, the Condor study which use durvalumab plus tremelimumab IO combination as compared to IO alone. And the NCCN 2020 guidelines also says that the category 1 recommendation for head and neck cancer is cetuximab chemotherapy or pembro chemotherapy or pembro alone if the PDL1 score is more than 20%. So it all depends upon the CPS score. So I would like to conclude that both cetuximab chemotherapy and pembro chemotherapy are category 1 recommendation as per NCCN. However, no benefit is seen with pembro plus chemotherapy in PFS and ORR as compared to cetuxi and chemotherapy arm. Pembro plus chemotherapy has not shown any benefit in Asian population, even if the score of CPS is more than 1. Chemotherapy plus cetuximab is a flexible option, allowing treatment tailored to the patient and use IO later on when vaccines are used. So consistent benefit of PFS, overall response rate, and OS is seen in cetuximab and chemotherapy and IO later on. So favorable and better compliance seen with TP extreme regime. Those of us who are using extreme regime, I would urge and say that come on and go to TP extreme, which is friendly to our patient and has got a better overall survival as compared to the other regimes. And when with cetuximab and chemotherapy in the first line allows us and give us a literature benefit of using IO in the second line. So with this, all this literature, I would like to thank the organizers and again thank Deepak Abrol and apologize for my internet breakdown. Thank you so much.
Thank you very much, sir. Over to the chair.
Any questions we have, for Dr. Ankur? Dr. Ashraf, sir?
Yes, the two lectures we had in this session were very excellent. I think they are self-explanatory. Probably they have conveyed the messages, whatever was intended in this presentation. I compliment both the speakers of this session.
Thank you. Thanks, sir.
Thank you.
Thank you, sir. Moving on to the next session, we have a panel discussion on gynecological malignancies. On the expert chair, we have Dr. Sabhyata Gupta, who's Director Gynecology and Gyneco-Oncology at Medanta, the Medicity. Ma'am, are you online, ma'am?
Yeah, I'm there. Thank you, Nitika.
Okay, ma'am. For the moderators, we have Dr. Swarupa Mitra from Delhi. Ma'am, can you hear me, ma'am?
Yeah, I can hear you very well.
Right. On the panel, we have Dr. Meenakshi Rana, who is consultant at Government Medical College, Kathua. We have Dr. Archana Datta from Jalandhar, Dr. Rajesh Pasricha from Rishikesh. Then we have Dr. Saurabh Gupta from Jammu, Dr. Amandeep Anand from Jammu, and Dr. Anup Kumar from Ranchi.
Shall I begin?
Yes, ma'am.
Shall I begin?
Yes, ma'am.
Okay.
Rupa, yeah.
So, Rupa, ma'am,
Okay,
yes.
Hi, ma'am.
Yes. So I think let's be thankful to Dr. Deepak for inviting us over. And we thank you on behalf of all the panelists and Dr. Surupa as well.
Thank you, ma'am. Thank you, ma'am.
Yeah, thank you, Dr. Deepak, once again. And congratulations for this lovely conference, very well awaited. So let me begin with the panel discussion, which is about cancer cervix. Is that probably Dr. Madhu is not here, Dr. Shaukat is not there, and is Dr. Umesh also not?
Yes, ma'am. I didn't mention the names who were not online.
Pardon?
Dr. Umesh is here?
So, ma'am, I skipped the names who were not online.
Yeah, could you repeat that once again, please? The
Yes, ma'am.
panelists who are
We have
present,
Dr.
or who are not
Meenakshi.
present.
Yes, ma'am. We have Dr. Meenakshi Rana, ma'am. She's a gynecologist at Government Medical College,
Yeah.
Kathua. Then we have Dr. Archana Datta from Jalandhar. She's a gynecologist. Then we have Dr. Rajesh Pasricha, who's from Rishikesh. Then we have Dr. Saurabh Gupta, who's a radiologist from Jammu. Then we have Dr. Amandeep Anand, gynecologist from Jammu. Dr. Anup Kumar from Ranchi. We are missing with Dr. Madhu Digra, who's a gynecologist. We are missing with Dr. Nishupriya, ma'am, Dr. Sujit Bhatt, and Dr. Rajiv Saini. As soon as they joined, I'll introduce them.
Okay. So I think we'll have to distribute the questions among ourselves, the rest of the radiologists, radiation oncologists, and Dr. Archana. She will be alone for the medical oncology. Okay. So in the beginning, I would like to say that what is the aim of a panel discussion? In the beginning, we should accept that we have a heterogeneous and diverse strata of patients, and there are varied levels of healthcare, even with limited facilities. Many of them have very limited facilities, and yet we strive to offer the best possible care to all our patients. And this panel discussion is all about sharing the recent guidelines and recommendations that can be practiced within our limitations. So coming to the patient, we'll have just one patient. This is a 55-year-old female, normotensive, non-diabetic, postmenopausal for about 3 years, and with an obstetric history of about these para 5 and alive 5, no abortions. The last childbirth was 23 years back. She had full-term normal vaginal home deliveries for all her babies, and there is no relevant family history. She came and complained of painless, blood-stained vaginal discharge since 1.5 months and bleeding PV since about a month. On examination, she had an average build, mild pallor was there, breasts, abdomen, chest were normal, there were no lymphadenopathy. PSPV PR, we found a foul-smelling blood-stained discharge on PS examination. There was a large growth occupying both the lips of the cervix, which bled on touch. Posterior vagina seemed to have involved, and also the upper 1/3 of the vagina. The left parametria was involved, but not reaching up to the pelvic wall. The investigations which were done, of course, were the biopsy, test, CBC, KFT, LFT, the viral markers, urine routine, chest X-ray, ultrasonography, abdomen. Now, what is Next, my first question will be to Dr. Meenakshi. There is a routine practice when we were studying that examination under anesthesia was very important. So I'd like to ask you how relevant it is, and do you practice in your practice or not? And I'll request all the panelists to be very brief and to the point. Yeah, Dr. Meenakshi. Dr. Meenakshi, I think you are muted.
Hello. Hello.
Hello, Dr. Meenakshi. Yeah, please unmute yourself. Yeah.
Ma'am, good afternoon.
Yeah.
Ma'am, examination under anesthesia should be done in setting where the facilities for the imaging is not available, especially MRI, because the MRI gives the detailed information about the size of the tumor and the extent of the tumor. And the institution where these facilities are not available, we have to go for the examination under anesthesia for the clinical staging.
Yeah, and does Dr. Amandeep also
Yes,
agree
I'm
to
here,
it?
ma'am.
What is your practice, Dr. Amandeep? Yeah, is this your practice to do an examination under anesthesia for all?
No, not for all
Do you
patients,
skip
but
for some patients?
rightly, as Dr. Meenakshi has told, where we don't have imaging facilities, and also in a very debilitating patient, if patient is not cooperative, like a very old patient, we have to make, we have to see involvement of parametria and the involvement of vagina, then we prefer E. Otherwise, we skip this.
Yeah, okay. So many times we see in our OPDs also, a patient comes with a pap smear. She's not ready for a biopsy, and she wants you to start the treatment on the biopsy. My question is to Dr. Rajesh and Dr. Amandeep. Would you like to treat a patient on the basis of a pap smear? Dr. Rajesh first.
Thank you, Dr. Swarupa, for involving me, and thanks to Dr. Deepak also for giving this opportunity for us to interact to all our colleagues in these times of COVID. Here I will like to say that, as you know, that pap smear is, I will not like to start the treatment based only on the pap smear, because there are so many confounding factors on pap smear. There's difficulty in interpretation, and then how the sampling was done. So plus the biopsy gives us a lot of information. What is the depth of invasion? What is this histopathological subtype? So my take will be that we should do biopsy wherever possible. In certain circumstances, when the patient is not willing, and then you have to explain the patient in a manner that she should understand. If still she is not willing, then maybe after taking consent, we might start a treatment in exceptional circumstances. But as a routine, I think it should not be done.
Yeah, absolutely. Dr. Amandeep?
Yeah, I fully agree with Dr. Rajesh Pasricha, because we have to find out stromal invasion and grading, and especially in cases of adenocarcinoma, pap smear is not fully, informative. So I would also like to go for a biopsy before definitive.
Yeah, exactly. So I think we should all insist and counsel the patient that a biopsy is required. Now coming to we have to do the scans for the patients. So my question to Dr. Saurabh. So radiology is becoming very, very important these days, and all tumor boards, the radiologists need to be patient. So for a carcinoma cervix patient, what are the local imaging facilities which we have and which we would like to, which are indicated for a carcinoma cervix? CT scan, MRI, and a PET scan. I'd like you to speak about all these three.
A very good afternoon to everyone. So imaging, as you all know, has been very recently incorporated by the International Federation into the staging of the CA cervix, and it definitely plays an important role in prognostication as well as deciding the management. So for the local disease, I would say MR is the best imaging modality, especially in the patients who are looking up for a fertility sparing surgery in the stage 1. And it is so because of its high soft tissue contrast abilities. And such patients who cannot undergo an MR or it is contraindicated, we can definitely go for an endoluminal sonography, that is transvaginal or transrectal, because it can provide that high accuracy if done by an expert. And secondly, in very large tumors in later stages, local spread, again, MR is a favored choice amongst the others. But again, if it is contraindicated or not or cannot be done, we can go for a contrast CT, CT with IV contrast, because it provides a wider field of view, and definitely the nodal spread and rest of the nodal spread can be seen. So PET I would consider for for not for the local spread, but definitely for the distant metastasis in the later stages, because PET has a high ability to pick up very small metastases, which are not, like in normal sized nodes, or which are not picked up by the by the non-functional imaging, that is morphology, that is CT or MR. So that is it for the radiology, ma'am. But
Yeah,
yes, imaging always depends upon the ability of the radiologist, and definitely affordability also.
Absolutely, absolutely. So I do agree. So we do MRI, we definitely do the MRI and CT scan, and between the PET scan, again, it depends. There are several guidelines and recommendations, which I'll come to in the next slides. Now, Dr. Anoop, we have been taught that cystoscopy and sigmoidoscopy are necessary. Without, we cannot proceed. That is what we were taught. When do you do, in your patients, when do you do cystoscopy and sigmoidoscopy?
Good afternoon, ma'am.
Yeah,
as you rightly said, as per cystoscopy and sigmoidoscopy is not, they do not go for cystoscopy and sigmoidoscopy, but when the staging is done, CT or MRI, then if you see that there is an invasion in this CT or MRI, then you can confirm it to the cystoscopy or sigmoidoscopy. Hello?
Hello, yeah.
Am I audible?
Yes, Dr. Anoop, yeah. Go ahead. Yeah, yes, I can hear you now. Yeah. So only when you see it is suspected
invasion.
as invasion on the MRI or has some symptoms, then we probably would like to go for cystoscopy and sigmoidoscopy. Okay, now HPV is becoming more and more important. So Dr. Rajiv Saini is not there. So Dr. Archana, if you would like to take that question, when would you do the HPV for patients and what is the significance? Is it overemphasized or is it actually important to go ahead with the HPV tests? Dr. Archana?
So, yes, ma'am. So HPV, I have seen that certain cases where we are taking up the patient for surgery, where we are doing a hysterectomy along with some lymph node dissection. So there are papers where they have said that when lymph nodes are dissected, if we are able to find out human papilloma virus infestation in that, we can correlate it with the primary pathology. Otherwise, there are many people who do it. I have seen gynecologists doing it for many patients. Sometimes even in the screening OPD also they are doing it. But in that cases, I think it has relevance only with the vaccine, not as far as the treatment part is concerned.
Yeah, so let's move ahead. So this is a paper which says that CT scan, as rightly said by Dr. Saurabh, it can assess the regional lymph nodes, distant metastasis, hydronephrosis, but it has very limited assessment of the cervical tumor invasion, and which can be done by the MRI. And there is 90% accuracy and superior evaluation of the tumor size and extension, especially for cervical tumors more than 1 centimeter. Now, PET CT, more than us, I think it is the patients who are more who want to do the PET CT. So the limited usefulness in very early stage tumors, but valuable in the assessment of distant metastasis. This is what the NCCN guidelines say. The NCCN guidelines, they do say even in stage 1, the whole body PET CT is preferred, or of course a pelvic CT scan, pelvic and chest abdomen. And when in stages 2 to 4A, the whole body PET CT is preferred, or else if you don't have the facilities, then just CT scan, sorry. So this was the finding of the MRI in our patient. There was an altered signal intensity lesion circumferentially involving the cervix, complete stromal thickness, extending to the inferior half of the uterine body, complete obliteration of the cervical canal. The lesion extends to the superior vaginal wall and the posterior vaginal fornix. The left parameter, fat stranding and extension not reaching the pelvic side wall on the left side. and there was a sub-centimeter lymph node that is the left obturator level. So this is how the MRI looked like. Dr. Saurabh, would you like to say something? Any other important information with this MRI, which the clinical examination may not provide us?
I think you have rightly just told the findings. Can I just, do I have a, do you see my cursor over the screen? No.
No.
So what we can see is an altered signal intensity lesion, mass lesion in the cervix involving it circumferentially, and if you're able to see the hypointense in the third image on the left lower quadrant. So yeah, so there's a breach in the hypointense line over there, which is the left parametrial spread that is being mentioned. So this is a stage 2 disease.
Thank you.
Yeah,
absolutely.
What about the lymph node, ma'am? What about the lymph node that we were finding out in the scan?
There was a sub-centimeter lymph node.
It's
Yeah,
not
there was a
seen in this
sub-centimeter
image.
lymph node.
Yeah.
It's not seen. We couldn't see. So the biopsy comes out to be adenocarcinoma, and the final diagnosis is adenocarcinoma cervix stage 2B. The patient did come with a PET CT. We did not ask him for the PET CT. The patient came with a PET CT, and there was a lesion. And here too, we could not spot the lymph node. So now the important decisions, what to be done. So Dr. Amandeep, what would you consider? Would you consider this patient for surgery, or would you refer her to the radiation oncologist? Dr. Amandeep.
And as it is a local cervical cancer, like radiation is the preferred mode of treatment. Although that American Society of Clinical Oncology in their 2016 recommendations, they have recommended that we can go for extrafacial hysterectomy in cases, limited resource settings where radiation is not available, or in cases where brachytherapy is not available. There we can we can give radiation, and for the residual tumor of 2 centimeter, there we can do extrafacial hysterectomy. Otherwise, preferred mode is refer that patient to radiotherapist, radiation oncologist.
Dr. Meenakshi, what is your opinion?
I think since she's stage 2B, chemo radiation
She's a
will be
55-year-old
better.
lady. Yeah, yes. So we also did the same thing. And
Ma'am, chemo CCRT is better than the surgery.
Yeah. Dr. Rajesh, what is your take on radiochemotherapy versus surgery?
Dr. Sarupa, as you know that in adenocarcinoma, they are less radiosensitive as compared to squamous cell carcinomas.
Yes.
If it is possible to incorporate surgery in any form, it will be preferred in adenocarcinoma. Here, I may differ a little bit here, because on MRI, like radiologist opinion would be very valuable, because there was only a parameter on one side. So I will also consider the findings of EUA especially in this kind of cases. So given the chance that if EUA findings are corroborating with the MRI findings, I'll go ahead with the chemoradiotherapy. But if EUA finding clearly says that there is no parameter standing, means parameters are not involved, so I will like to consider surgery also. But like I hope that it is clear-cut stage 2B, so we will discuss according to stage 2B only. So obviously, I will like to go ahead with the chemoradiotherapy in this case, as we assume that it is a 2B only. So chemoradiotherapy will be a preferred choice in this case.
I think that's a very important thing you suggested, that examination under anesthesia. This is actually the patient who could be taken up for an examination.
Exactly. These kind of patients are actually the
Dr. Archana, yes, they are the actual candidates. Dr. Archana, now, yes, like Dr. Rajesh said, these are not adenocarcinoma, they are not very radio sensitive. So would you consider her for a neoadjuvant chemotherapy?
See, if we see the papers, there are basically 2 randomized trials that have incorporated neoadjuvant chemotherapy. One was published in JCO by Gupta and Maheshwari. And the other one was the EOR-TC trial, where almost more than 600 patients were evaluated. Though in one of the papers it was for squamous cell carcinoma, but they usually extrapolate the data of squamous cell carcinoma for adeno in case of cervix. Both the papers, it was seen that the 5-year disease-free survival rate was worse in neoadjuvant chemotherapy arm than the concurrent chemoradiation arm. But one point which was considered almost equivalent was the overall survival. Both the studies had shown that overall survival was comparative. So, in my suggestion, only in those parts of the world where radiotherapy is not available or the patient cannot access to radiotherapy, I think there only we should take up the patient for neoadjuvant chemotherapy followed by surgery.
Correct.
So the next question, Dr. Umesh is not there. Anybody who wants to take up this question? Is adenocarcinoma cervix different from
So
squamous cell
earlier,
carcinoma?
sorry,
But still treating them as both. Yeah, Dr. Rajesh.
I think earlier it was considered that they have a poorer outcome as compared to squamous cell carcinoma. All the studies are published earlier, but recently study has been, the SEER database study has been published in 2020, which shows that at least in locally advanced, there is no difference between the outcomes of squamous versus adenocarcinoma. I will also like to share that file here in the chat if anybody is interested.
Right. So these are the guidelines, the ASTRO guidelines. So I'll just mention a few. There's a 10% 5-year survival benefit and the lack of toxicities. All these give us to the recommendation that CTRT with cisplatin is the standard of care. Whether tri-weekly cisplatin can be given or not, the TACO trial will tell us. In the 1A, 1B, 1B2 and 2A1, they are eligible for radical hysterectomy or definitive RT alone with or without chemotherapy. With chemotherapy, the long-term toxicities are 2 to 3% toxicities of 29% in the combined modality group. And the adjuvant hysterectomy after radiation is no longer recommended according to the GOG-71 trial. Now, the role of neoadjuvant chemotherapy. So this is the study we all know. This is from TMH. And the neoadjuvant chemotherapy, the conclusion was that cisplatin-based concomitant CTRT resulted in superior DFS compared to neoadjuvant chemotherapy, followed by radical surgery in locally advanced cervical cancer. Now, this is another study where the highlights of the studies are, this is actually the first meta-analysis to evaluate the efficacy of neoadjuvant chemotherapy between adenocarcinoma and squamous cell carcinoma. And the short-term outcomes were similar in both the squamous cell carcinomas and the non-squamous cell carcinomas. It was not only the adeno, they were the non-carcinoma. But of course, it did indicate that histological type may be in future used to predict the long-term efficacy of neoadjuvant chemotherapy, especially those patients with FIGO stages above 2B. Now, this is also a comparison to see whether the adenocarcinoma behave differently from the squamous cell carcinoma. And a very few important points are adenocarcinoma cervix actually comprises about 25% of the cervical cancers. And the squamous cell cancers, they have higher lymph node involvement than adenocarcinoma in stages 1B1. But after that, there's been no difference. And regardless of the radiotherapy or concomitant chemoradiotherapy, adenocarcinoma had worse overall survival and disease-free survival than squamous cell carcinoma. The poor radiosensitivity of the cervical adenocarcinoma versus squamous cell carcinoma is probably the reason. And the adenocarcinomas had a poorer complete response rate and the poorer local control rates as compared to squamous cell carcinoma. That is the time required to reach complete response is also larger or longer than the squamous cell carcinoma. And adenocarcinomas were also more likely to have distant failure rates. So these are the findings of some very recent studies. So the mode of treatment, Dr. Anoop, we know that we would be treating this patient with radiotherapy. So could you tell us what radiotherapy you give, conformal or IMRT or conventional? Dr. Anoop? Dr. Anoop, can you hear us?
Dr. Anoop, kindly unmute, sir.
Yeah. Can you hear me now? Hello?
Yeah, yes.
Yeah.
Yeah, if you could tell us
As you rightly said,
points.
Our country has been having the heterogeneous facility and radiotherapy as well. So depending on the center, but this could be at 3D conformal RT will be treatment of choice, but it could be treated by two-dimensional method also, depending on the separation of fixing. Maybe the separation is less than 20, we can treat by two fields. If it's more than 20, you can treat by four fields, box technique. And as far as the IMRT is concerned, the latest guidelines do not show any advantage in stage 2B, especially in operative or not operative patient. I mean, especially it has shown advantages is shown in post-op setting, the use of IMRT. So I think
what is the dose you generally give?
Would be 50 gray is in 25 fractions, followed by as per the insistent protocol. 7 gray or 7.5.
And do you follow the bladder and bowel protocols as well, strictly?
Yeah.
Do you follow the bladder protocols?
Yeah. When we consider the treatment for it's bladder and rectum.
Yeah, so I think these are really accepted protocols. And our patient received IMRT 50 grays in 25 fractions with concomitant chemotherapy with cisplatin. And this is the pre-ICRT. So we generally do an MRI after the completion of the external RT. And this was she had almost complete regression in spite of being an adenocarcinoma. And we planned her with 3 sessions of ICRT of 7.5 grays per fraction. So now this is very important. Follow-up is very important. Dr. Rajesh, how important do you think is follow-up? And how difficult is it, especially in government setups, to follow these patients up? And what is the protocol you all follow?
I agree entirely with you that it is very difficult for patients, because patients only think that once the treatment is over, they can go home and they never bother to come back. So in fact, what I insist to my residents also and myself also, I tell patients, because since you are in a government setup, we are offering you almost free of cost treatment. The only thing which we require from you is a constant follow-up. So being an academic setup, little advantage is that all the residents are there for thesis and other research protocols. They keep a tab on the patients. But as such, it is. I agree with you. It is very, very difficult to convince the patient for follow-up. So our protocol actually includes a first examination after treatment is complete. We first examine the patient at around 15 days just to see whether there is any acute toxicity or immediate treatment-related toxicity or issues are there. Followed that, we examine patient at every 3 months. Radiology investigation at around first investigation at around 3 to 6 months, but it all depends then what is the situation of the patient, clinical situation of the patient. If there is a CR, we do the first radiological investigation at 3 months, and after that every once in a year MRI, and after 2 years the follow-up is changed to 6 months, and after 5 years in a yearly follow-up.
Yeah, so I think all of us follow this guideline. What is the NCG? The National Cancer Grid Guidelines. It says that I'm especially quoting NCG because it is relevant in our country. Follow-up every 4 months up to 2 years, and every 6 months after that for another 3 years, and then yearly. Cytological evaluation should be considered as an option. Follow-up imaging should be directed by symptoms and not recommended for all patients. This is for post-operative patients. And for post-RT patients, the follow-up should include per speculum and bimanual pelvic examinations every 4 months for 2 years and then every 6 months, and thereafter the symptom-directed imaging can be indicated. And routine cytological evaluation is not recommended. This is what the NCG guidelines say. Now, again, Dr. Umesh is not here, so maybe anybody can answer this question. This is very important. Residual disease after treatment. What do we do? Dr. Rajesh, would you like to take
Yeah, I
this?
think
Because yours is an academic setup.
yeah, if the residual disease is there, the first option will be surgery. Like in your case, suppose we assume that if there was some residual disease, but all the parametry is clear, a simple extrafacial hysterectomy will also can also be considered. Or if the expertise is there of a gynecological oncologist, and if excitation is required, so be it. So the surgery will be a preferred mode of treatment in after completion.
But when would you do that? How long will you?
At least 3 months.
Would you do it in the first 3 months itself?
Yeah, we have to re-examine after 3 months. We can repeat a biopsy, and if there is a residual disease in that we can, then we should in fact ideally do a PET scan also, and then followed by a decision for surgery.
Can we speed up, please, because of time constraints?
Yeah, this is the last one. This is the last slide. Okay. So this is the last slide. The residual disease, what do the recommendations say? Not recommendations, these are published in some journals. So we allow time for delayed response. Then, like adenocarcinoma, we saw that there's a delay in response compared to squamous cell carcinoma. Consider what Dr. Rajesh said. PET imaging should be done, could be done 3 to 4 months after the treatment. And if there is a recurrence or a persistence of disease, biopsy can be done at 8 to 12 weeks, not necessarily at the first follow-up itself. Salvage hysterectomy or excision is the treatment which can be offered. Again, it depends on the gynecologic oncologist. The prognostic factor, this is very important. The prognostic factors at diagnosis, the extent of the residual disease is helpful in determining the benefit of the salvage treatment. So we need to assess the benefit of the salvage treatment as well. So this is my last slide, and thank you very much. I think this was a useful discussion, and maybe Dr. Sabhyata would give her opinion.
Dr. Sabhyata ma'am, please give your final expert comments.
Yeah. Thank you, Dr. Surupa, for conducting the panel so well, and thank you all the participants for contributing, in a brilliant manner. Just a small comment that if we talk of the significance of HPV testing, we need to know that 16, 18, HPV 16, 18, 45 are known to, cause adenocarcinoma, and 71% of the adenocarcinomas are because of it. So just that's to be kept in mind. And of course, all patients, they deserve the best treatment, but one has to keep in mind the facilities available and the fitness of the patient. I think with this will conclude. Thank you, Dr. Deepak Abrol, and thank you all the participants.
Thank you, ma'am. Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Nitika, please take over.
Thank you, ma'am.
Thank you.
Good afternoon, everybody.
Yeah, Dr. Saima Sadiq would take over the session from now on.
Saima, please start.
Hello.
Dr. Saima,
Yes,
you're audible, ma'am.
Okay. Thank you, Dr. Swarupa, madam, Dr. Sabhyata, and all the panelists. Now, without wasting time, let's move on to the next session on genitourinary malignancies. May I request Dr. S. Hakku, who is Chairman and Senior Consultant Radiation Oncology at VLK Super Speciality Hospital, Delhi, to kindly chair the session on the genitourinary malignancies. I welcome the moderator, Dr. Gagan Saini. He is again a radiation oncologist at Max and Fortis Hospital, Noida. May I call upon the panelists, Dr. Ilyas Sharma from Jammu, Dr. Nikhil Vaid from Gurugram, Dr. Rajiv Saini from Katra, Dr. Amit Suri from Jammu, Dr. Shekhar Kesri from Patna, Dr. Rahul Gupta from Jammu, Dr. Ranjit Rathore Kathua, Dr. Rahul Sharma Jammu, Dr. Rajpal Singh from Srinagar, Dr. Shikha Chawla from Jalandhar, and Dr. Suman Gupta from Delhi.
Good afternoon, everyone.
Start and because we are running late. Go ahead.
Yeah. So I'm not sure who all are there. Are all panelists there, Saima?
I could not find Dr. Rajiv Saini.
Two or three are missing.
Dr.
You just
Rajiv.
because we are running late, I'll let you know.
Yeah, Dr. Rajiv Saini is not there. Dr. Amit Suri is not there, and Dr. Rahul Gupta is not there. Rest everybody is there.
All right, all right. This is useful. Thank you for this input. So we'll start with the genital urinary panel. I thank Dr. Deepak. Dr. Deepak, I can hear your usual hurried tone, which we hear every year at this time. We used to be catching flights, return flights every time.
That
so
time it was for flight, and now it's for lunch, sir.
Yes. So now I will, yes, that would be lunch actually this time. Absolutely was. So I'll be starting very quickly and we'll finish in our designated time only. The slides generally take some time to start moving. Yeah, now they are moving. So I welcome the esteemed panelists who all of them have been listed out and called out by the host. And we start with the case. The patient is Mr. ABC. He was a screen detected CA prostate. And the initial PSA at diagnosis was 28 nanogram per ml. Biopsy was done, trust guided biopsy. 8 out of 12 cores were positive. Perineal invasion was there, and Gleason score was 4+4. Then, as the practice is, PSMA PET scan was done, and it showed seminal vesicle invasion with no metastasis, no lymph node, no metastasis whatsoever. So only locoregional disease, but a locally advanced one with seminal vesicle invasion. So I would like to ask our uro-oncologist, neurosurgeon, if we have any in the panel, is surgery an option for this patient? How would you, is surgery an option for this patient? Do we have any neurosurgeon in the panel? I'm sorry.
I am Dr. Ilyas Sharma. I am Dr. Ilyas Sharma.
Yes, Dr. Sharma, good afternoon.
Good afternoon, Dr. Gagan. And as you have enumerated that this is the locally advanced disease, and really the options for surgery in this patient has to be discussed in detail with the patient, and it has to be done only if he is ready for the active treatment.
So Dr. Sharma, in the interest of time, can I ask you the one compelling reason why you would do surgery for this patient? In comparing and contrasting, anything you would like to weigh for surgery? To make things.
I would like to see whether there is a pelvic involvement or there is involvement of the sphincter. If these two factors are not there, and patient is having good performance status, and I would advise surgery for him. And upfront, I'll tell him that this could be a multimodality treatment with a need for radiotherapy and ADT also post-operative.
Okay. So you would offer surgery because if you think the patient is technically operable, and
yes.
then because of the biology of the disease, you would praise them that there would be a need for adjuvant treatment anyway.
Yes.
So there will be so-called the multimodal therapy, which is being talked about these days for locally advanced CA prostates. Any of my radiation oncology colleagues would like to chip in?
Yeah. Dr. Gagan, I'm Dr. Rahul Sharma.
Hi, sir. How are you?
Yeah. I would like to differ with Dr. Ilyas on this. In this case, this is a high risk case. And what we find from the data which is available to us so far, if we do surgery in this case, this high risk case, there are 40 to 70% chances of biochemical failure. If we do a radiation therapy with the latest techniques which are available to us, the chances of biochemical failure are less than 15%. But this is not a head-to-head comparison. This is the retrospective analysis of the surgical series with the radiotherapy series.
Thanks for putting it so succinctly, Dr. Sharma. Hanji.
Dr. Gagan, I am the medical oncologist on the panel.
Hi, Dr. Sharma.
I am Dr. Sharma.
Can I switch on your camera first?
Yeah, I'm driving right now. So, okay. So, can I open the bag of worms now?
Yes, please do.
Okay. So, I'm really sorry to interrupt in between. I want to support my uro-oncologist here in this. So with the available data, why don't we offer this in the MDT? Why can't we offer a new adjuvant approach through the surgeon here and then make it operable for him?
Okay, but there is really no data which supports neoadjuvant
Yes,
use of hormonal
absolutely.
therapy.
Yes, there is very small data series, but again, there is no head-to-head data. I know this is a
Historically, neoadjuvant ADT, Dr. Sumant, has absolutely not helped in helping improve outcomes. I mean,
yes, yes, I totally agree with you. But
and for a case like this, they will find the plane between. I'm speaking for you, Dr. Sharma. I'm sorry. They will find the plane between the rectum and this thing to be more and more obliterated because of the effect of ADT. I mean, that's my thought.
yeah, your thought is absolutely correct. But again, if you see in this particular case, there is no pelvic lymph node. So this case is a borderline case. So if you're talking about a multimodality case, so this is just opening a bag of worms. This is just a discussion. We are not taking the patient for this. But as the neurosurgeon in this case is trying for something, then and if you don't compare the head-to-head cases, I'm just saying that if we pitch in, then in a multimodality case, that is also one option. If the neurosurgeon is going for this, a new adjuvant approach can also be tried in this. So I'm just opening the bag of cans for a discussion, nothing more than that.
Thanks, Atal.
Sir, new adjuvant hormonal therapy really does not help doing surgery. It makes surgery more difficult. So usually we avoid new adjuvant hormonal therapy before surgery.
Yeah, but certainly it was. He did open a can of worms. Yes, Dr. Shekhar.
I would like to comment on that. There is the SV invasion. If suppose that surgeon goes for the surgery also, the chances of adjuvant radiotherapy is very high. So why not we should plan for the definitive or radical radiotherapy up front? Giving up so many morbidities after the surgery, patient definitely will have, because you know the operative for the prostate itself is really a big challenge. And once patient has SV invasion, that is the particular point to be noted out. And then at that time itself, we should see that there is a
so what you are saying. So what you are implying is that the need for adjuvant treatment is almost sure here. However, I think Dr. Sharma would mention that he may put the patient on follow-up if the PSA and all has regressed. You know, if you find it undetectable, then there's probably no need.
I would like to see the post-operative PSA. And if PSA is less than 1 and patient is having favorable factors like ISUT score less than 2 and the PT less than PT3 stage, and there is no capsular perforation or there is no positive margins, and there are lymph nodes which are less than 3, and the lymph node density is less than 20%, you can even observe the patient and don't need to give any post-operative RT, and you can wait for the PSA to rise to 0.5.
Sir, in the interest of time, we'll just move ahead. I'll just add some data. This is a very recent data, AUA 2020. It was presented, which showed that the failure rates were as the survival probability was just 60% after 3.
Good afternoon, Dr. Gagan. Can I come in, sir?
Yes, Dr. Ranjit. But I was hoping that we can have your inputs and others' inputs on because there are more topics to be discussed. We move ahead from there. We move ahead from here. And in fact, these are radiation therapy results, the EORTC 22961, where the 8-year survival was about 85%. So there, it's probably, sometimes it's hard to imagine why, but somehow for locally advanced prostate cancer, maybe for the reasons of putting the patients on follow-ups and observing the PSAs, I'm not sure. I mean, this is conjectural, but maybe that kind of spoils it. But fair enough, this argument will continue to go on. So, Dr. Ranjit, will you please tell me that if surgery would have been done, would you undertake the patient for adjuvant RT, assuming that pathologically it comes as T3B, or will you wait and watch? What will be your principles either way, Dr. Ranjit? Dr. Ranjit, you are a radiation oncologist, right?
No, sir. Sir, I'm a urologist. Sir, I'm a urologist.
Okay. Sorry. Okay. Yes, certainly. You please make your point.
So I would actually see what Dr. Ilyas said. We together have worked together in super specialty hospital. I have worked under him. And we have seen so many cases in which the tumor has infiltrated the seminal vesicles, but not involved the lymph nodes and sphincters and other surrounding organs. We can go ahead with surgery. We can go ahead with surgery and follow up the patient with the, we can start with multimodal therapy like salvage radiotherapy or ADT later on. So surgery is possible in this case.
Dr. Rathod, it is not about what you can do. It is generally about what you must do. I mean, that is where the science actually takes us. I mean, that is technique, what you are talking about. You can do it. But what you must do is what has to be, what is being discussed. I mean, that is my thought. I mean, I'm not saying you cannot do a surgery in such a case, but the nuances of doing it and not doing it is also relevant.
The points in favor of doing surgery in this case is you have shown the Gleason score is 4+4. It's a high grade, and 8 out of 10 reports are positive. So, seeing the cancer aggressiveness, the surgery
aggressiveness means that you will require more adjuvant treatment. Anyway, you made your point. I would like to ask my radiation oncology colleague. Maybe, you know, my colleague Dr. Shikha can come in if she is logged in, or Dr. Rajpal can come
Dr. Gagan.
Hi, Dr. Shikha.
Yeah. I would like to give adjuvant RT if it is PT3, any positive margins or frank seminal vesicle involvement is there. In these three conditions, definitely the patient will require adjuvant RT.
Certainly.
So if it was clear in PET, we could have given a single modality treatment, thinking of RT only at the beginning.
It's technically dual modality. You give AGT as well, but yes, you made your point.
Well, yeah.
So I would like to ask Dr. Rahul now. Dr. Rahul, would you give adjuvant RT, or would you do wait and watch, please? Dr. Rahul Sharma?
I will not allow the urologist to operate this case if there is a combined clinic, because we have now nomograms which can predict what are the chances of lymph node positivity in this.
But sir, we want your comment only on the surgery once it has been done, and you know, the urologist
the surgery has been
the patient
done
to you with a low PSA, with the PSA under control. The way Dr. Elias Sharma was talking about that, you know, you have, and you know, even Dr. Ranjit was saying that, you know, sometimes it's possible. So it's, let's assume this is that sometimes case, and you know, you have a PSA which is in control. And you know, would you like to do adjuvant, or will you wait and watch? This is the point which you know, I want to bring forward about.
If the margins are negative, nodes are pathologically negative. If only seminal vesicle involvement is there, I will wait for the biochemical recurrence to occur and then try for early salvage RT. But if the margins are positive, if lymph nodes are positive, then we have to start hormonal therapy plus adjuvant radiation without waiting for the biochemical recurrence.
Right. So
because that is bound to happen.
Yes, because that is bound to happen, and it's evidence based to do that. I agree. Lymph nodes are negative, however, in this case. So Nikhil, would you like to, you know, tell me at what, suppose we are following Dr. Rahul Sharma's strategy of waiting and watching. So what is the PSA at which you would like to start radiotherapy?
If there is PSA more than 4 or 5, but if it is T3,
4 nanograms?
If it is T3, if there is seminal vesicle involvement, yes, we'll consider the patient for adjuvant radiotherapy.
No. What is the PSA at which you will initiate? I mean, we are talking about a very specific strategy. Dr. Rahul Sharma is emphasizing upon the early salvage strategy, which is being investigated and also presented lately, but has been followed for a very long time. People have been following it as a strategy. But recently we have some early results. So what is the PSA at which you like to give that early salvage RT?
If PSA is more than 5, sir.
5 nanograms? No. Would anyone else like
after
to?
The nadir, sir.
Yes. I would like to clarify on this. If there is the PSA should be undetectable after a radical prostatectomy. If there are 2 readings which show that it is a rising, then we should go for an early salvage RT.
So what is that level at which early salvage RT makes sense? Dr. Rahul, that is the real practice.
The level is 0.05 nanogram per ml.
So Dr. Sharma would like to start RT at 0.05 nanogram per ml. Okay. And anyone else? I believe he's also here. Dr. Rajpal is here. Dr. Rajpal, you're here? Yes. Dr. Rajpal, unmute yourself. Muted है. मैं unmute कर दूँ.
Thank you, sir.
Yeah.
Dr.
Speak again, please.
Sir,
Yeah.
the indication for post-operative RT, as per
No,
guideline is.
I'm not talking about post-operative RT, Dr. Ashmal. We are talking about early salvage RT, the ESRT protocol. So you are not doing adjuvant RT, you are doing an early salvage. If you are following an early salvage, what is the PSA at which you do early salvage? This is a very important practice point. Everybody talks about early salvage RT, but at what point is an early salvage an early salvage? That is a very important question.
Sir, ideally, as Dr. Rahul sir said, that there should be no PSA which is detectable. So any two readings more than detectable two readings is an indication for early salvage RT. Now, moreover, the value which we'll take is 0.5 nanogram per ml.
Okay, so this is a very interesting. So here I'd like to, bring in my urology colleagues, Dr. Elias and Dr. Ranjit. We are not stopping you from doing anything. We're just bringing forward some science. So, what he just said was 0.5. So all the, the trials which were presented recently, they did not present a very long-term data, by the way. It's just 5 or 8 years. But nonetheless, they are kind of right now telling that maybe you can avoid adjuvant RT in many, maybe in 70% patients, maybe in more even, or maybe in less. The time will tell. But now 8 years down the line, we can say 70% patients maybe not given RT as an adjuvant and sometimes as an early salvage. But the PSA, sir, is 0.5 at which it is done. So here I'm bringing my question to you. This was not I'm not giving a comment. I'm bringing a question to you. The question is that suppose you are having a patient on follow-up and he is having, say, a PSA of 0.1 or 0.2. Would you wait for 0.5 to happen for an early salvage? I mean, what is your criteria for early salvage? I mean,
there are multiple criteria you have to see. Now, if the decent score in the specimen is around 8 to 10, and if it is T3 stage, and margins are positive, and the lymph nodes are present more than 3 in number, and there is R1 presence is there, which is
no, sir, you have done the surgery. You have done the surgery. Lymph nodes are all negative, and we are having a PSA, the follow-up PSA of 0.1, something like 0.1. So what is your thoughts now? So you're having a PSA of 0.1 here. Would you consider this patient now for adjuvant RT, or would you call it early salvage, or would you still keep the patient on follow-up and let it rise up to a certain level? What are your thoughts here?
That is what if the 2-3 factors are there. Like if the T state is high, that is T3, and recent score is high, which is 8 to 10, and the margin positivity or capsular perforation is there, we would probably think of RT immediate post-op once the patient gets the control of continence and all, maybe within 6 months. And if these factors are not there, it's a disease which is low grade, then we can probably wait for the PSA to rise to 0.5 and then start the RT.
Fine. The definition of a successful surgery is undetectable PSA.
Yeah.
Suppose you assume it to be less than 0.02 to be, an adequate PSA. So that's what is practically done. Undetectable is less than 0.02.
Yes.
So why would you let it go to that level? I guess that is the point I'm trying to impress. The fine point that I really like Dr. Swarupa Mitra's statement a while back. That, all this is written in the books. What we are bringing forward are the nuances of practice. So I'm not trying to put you in a spot here, Dr. Elias.
I understand the question. You said that the PSA is undetectable and then it has become.
It's 0.1 post-op. The patient came to you on follow-up, and it's 0.1.
If 0.1 is almost taken as a normal after, it's a good surgery. I mean, if it is undetectable, 0.1 is acceptable.
Is it?
Yes.
Sir, it's more than 0.2. It's more than 0.2. Sir, I am Dr.
If
Ranjit.
it is more than 0.2, then there is probably a disease there, and then you have to go immediate RT.
Dr. Rahul, would you like to, bring forward some other aspect of this?
If it is 0.1 in one reading, and I repeat the reading after 4 weeks, and if it is 0.2, then I will go for early salvage RT, because there is no role for a late salvage RT, because it has been shown that if you do a late salvage RT, the results, the outcome is impaired significantly. So we have to go for early salvage. Any two readings which show a rising trend, we have to go. I will not wait for it to rise above 0.5 or 0.1 because the studies have shown that if we wait for it to rise above 1 nanogram per ml or 0.5 nanogram per ml, then our outcome is going to be impaired and we are putting the patient at peril.
Anything above 0.5 is considered to be quite impairing. And nonetheless, so the point has been made. I would like to just bring forward a very interesting observation from the SWOG 8794, which was an adjuvant RT trial. And we have all been talking about early salvage for some time now, and some adjuvant options were also given. Just a very simple point that in this SWOG 8794, they took in the seminal vesicle positive patients and they gave RT and randomized to observation. And all I'm trying to just bring forward to you is that the patients with seminal vesicle positivity were anyway doing poorly, and RT helped them here. And it was also very helpful for improving the biochemical failure-free rate and hormone-free, period, hormone-free survival, that is salvage-free survival. And I did put in another slide here, and it was interesting that historically the seminal vesicle positive patients have been doing very bad, and maybe, just maybe, since the long-term data and the final data of the ARTIST meta-analysis is not out, maybe seminal vesicle positive patients should still be considered for adjuvant RT and not for an early salvage. Just maybe. This is my point, because there is a very strong statistically significant data already supporting adjuvant RT in this particular subgroup. Just my
Sorry, another 5 minutes to wind up the session.
Yes, please. So, Dr. Sumant, can you please tell me, the ADT duration which you will use if this patient is treated radically? Radical RT.
So usually the usual practice is 24 months, but now most of the trials have shown that 18 months is enough.
18 months is enough as well. So great. Yeah. So it's very interesting that there is almost a 5% jump in the mortality, the benefit when you're using long-term suppression, but it's still just 19%. It's not like it goes very high in absolute terms. So I'll just. So what are the likely side effects with Buzerelin? If any one of my radiation oncology colleagues can come in, Dr. Shikha can come in.
We could have hot flushes, bone pains, change in lipid profile, weight gain, gynecomastia. All these could be there with the use of Buzerelin.
Right. And any long-term effects? Cardiovascular effects and
cardiovascular effects, definitely long-term cardiovascular
sugars and all. So great. So we don't have a lot of time, I guess. 25 minutes may not be enough. So we see that there is in various studies, different aspects have been pointed out. So any practice points that any one of my colleagues would like to share so that they can ameliorate these side effects? Anything you would like to do? Dr. Shekhar has not spoken in a long time. So Dr. Shekhar, can you please help?
No, Dr. Gagan, just I wanted to put you in between. That
you're not a part of the panel? No, you are a part of the panel.
I'm the part of the panel. That's what I am here. That's why I am here. The thing is that for the PT3 disease, if you see there are 2-3
No. The question is not that anymore. I mean, we really can't debate on controversial things. These are just controversies which go on and on. My question to you is,
take-home message from you only. I want to have take-home message regarding the related of our ADT duration that you mentioned, that short-term or long-term. What is your take-home message? Long-term or short-term? Because on the basis of conditions we do plan our the practice also, isn't it?
Okay.
So the thing is that we should be very much clear about once we're discussing the panel. See, short-term either for the 6 months or something like, long-term for the 3 years.
Yeah. 2 years, and 18 months, as Dr. Sumant has pointed out. So Dr. Shekhar, I'll clarify it. I'm happy that you you asked it. So the take home from this is that yes, there is an improvement in survival with the long term ADT, and yes, we must use that only. But what also must be understood is that the difference, in some studies it's 10%, I did study, but in most studies it's not more than 10%. So try to understand that in a disease where you are going to do radical treatment and going to get 75 to 85% 8 to 10 year survival, biochemical relapse-free survival as per various studies, a difference of 5 to 10% is very important, yes. But if there is a patient, and this is what I wanted to build through this panel, that we are having a lot of side effects. We are ameliorating the side effects by doing a lot of prophylactic things. We're telling, I think we have to wind up now. I can see the host's face now. So, it's time to go. So, just let me complete. You asked a very good question. So I guess it will be the take home from this discussion that there's a lot of things that you do. But sometimes if the patient is having a very serious issue, say the patient has had an embolus, a stroke or something like that on your ADT. So don't be shy of stopping ADT, because the difference in survival is there, but it's not like it makes like a sea of difference. So those are the practice points. I'm not saying stop doing long-term ADT. But try to understand that where what is leading to. I mean, as a clinician. So I wanted to debate this actually. I want lots of eminent people are there on the panel. I wanted each of them to bring out different aspects of this.
Dr. Gagan, I would like to add that I would like to prefer Degarelix as androgen deprivation.
So this is a very interesting point,
to
Dr.
take
Rahul.
care of the cardiovascular.
Yes. So Dr. Rahul, it is very interesting that this is a point I had kind of made here, and this I'm moving ahead from the guidelines which the bone density and all that was made. Now this is the question: do the GnRH antagonists actually reduce cardiovascular mortality?
Gagan, if I can intervene, Dr. Rahul.
Trial. There is an ongoing pronounced trial which is going to answer this question.
Maybe,
the results are not available.
But till
yet.
date, it is not.
But
it is not cut and dry.
Theoretically,
yes.
Theoretically, yes.
Dr. Rahul,
and there is some data also.
Yeah. So I guess we'll let Shekhar make a last comment, and maybe we'll wind up from here. You were making your comment, Dr. Shekhar.
Yeah.
Who was making the comment? I'm sorry, I thought it was you.
Dr. Rahul Sarma is speaking that Degarelix is the thing that we should use for the cardiovascular risk patients. And the antagonist definitely has reduced incidence of the cardiovascular risk.
So what will Dr. Sumant prefer? Dr. Sumant, will you prefer GnRH antagonist?
Okay. Coming to this, Dr. Rahul, it was a very valid point raised by you versus antagonist and agonist. So those are small studies, but in the ASCO GU update, which was recently held, there has been a very good meta-analysis which has clearly talked about cardiac mortality and morbidity. So right now, there is no data which shows any benefit between agonist and antagonist use. And between Shekhar sir's very valid question about long-term and short-term, so the benefit and side effects outweigh long-term and short-term. So right now, 18 months is the gold standard. And right now, with the available data of the meta-analysis, which is on 39,000 patients, there is at present no difference between agonist and antagonist. So the only role of using Degarelix or these drugs is only for visceral crisis, or where we have an impending bone marrow, where we have a marrow, where we have any cord compression or any visceral crisis. So these are the only indications where we use Degarelix as such. In cardiac morbidity or mortality, there is no such differences at present in the meta-analysis. These might come out in the near future, but right now, for a take-home message, there is no difference between the two. And for the, as Dr. Gagan said, right now, the take-home message is 18 months is sufficient if we outweigh the long-term advantage and disadvantages. Over to Dr. Gagan.
I thank everyone. I thank the organizers and all the esteemed panelists for very nice discussion. I'm very sorry if I could not shed enough light on the points which were, every one of you were trying to make. I had a time to keep. I apologize, and maybe I can make up for it the next time. Thank you.
Thank you. We have some last words from Dr. Hukku sir, the expert chair.
Thank you, Gagan and the panelists for quite an extensive discussion. Now, just to summarize in a couple of minutes, this case, of course, if you are operating, the surgeon should tell the patient that patient will need adjuvant treatment later on. So because when you open up and the pathology, so the patient should be, it should be made clear to the patient in the beginning. Now, when it comes to giving an early radiation or a late radiation, there are trials, there have been randomized trials. One has shown benefit with early radiation, other two have not shown. Surgeons would say that even if you leave these patients, more than 50% patients will not fail. Then why to give an early radiation and add complications? The radiation oncologist will say that if you find a positive margin, if the Gleason's grade is high, it is better to give radiation earlier. So this debate will continue. There are no clear-cut answers to this. The other important thing is that in practice, we should realize that if we treat the patient at a lower PSA level, and the lower PSA level, according to me, would be about 0.2. So if you treat the patient at that level, 0.2 or 0.3, probably you will get a better result than treating the patient at 0.5 or 1. So those things should be kept in mind. 2 or 3 readings rising, what is the level of the PSA, what was the pathology report, and based on that, we should take a final call as to give radiation earlier or later. The randomized trials have shown us that there is no difference in overall survival, whether you give early or late, and there is no difference on the distant metastasis. So it is the departmental and the consultant's, choice of the tumor board decision as to what is to be done. So I think at the end of the day, there should be a correlation between the practice of a urologist and a radiation oncologist for the patient to get the best result. So thank you very much, Deepak, for this discussion and enlightenment. Thank you.
Thank you very much, sir. And over to Saima.
Thank you, sir. Now moving on to our next session, that's a panel discussion on managing colon cancer in the Indian scenario. I welcome on chair Dr. Neeraj Jain, and to moderate the session, I would like to call Dr. Randeep Singh, who is a medical oncologist at Narayana Super Speciality Hospital, Gurugram. I cannot see many panelists. I'll call out only who are available online. Dr. Pooja Nandwani Patel from Ahmedabad, Dr. Madhu Rastogi from Lucknow, Dr. Nafees Ahmed Siddiqui from Lucknow, and Dr. Sajal Kakkar from Mohali. Anybody else who has joined?
Abhinav is there? Abhinav?
No, I cannot see him.
Oh, okay.
Dr. Abhinav, I cannot see. Dr. Vinod, Dr. Vijayant, Dr. Arvind, Dr. Vikas, Dr. Sunny. If anybody is there, please.
Okay, Saima, thank you for the introduction. I hope you can see me, my slides, as well as I am clearly audible.
Sure.
Yes.
Hi, Deepak.
You can please start, sir.
Okay, so we have...
Dr. Randeep, you can start without wasting any time, since we are running behind the time. So please go.
I will need Saima's help to know that who all are available, because the questions were directed to the panelists. Can you please let me know who all are there once, and then we start.
So Dr. Pooja Nandwani from Patel is there.
Okay.
Dr. Madhu Rastogi from Lucknow.
Okay, no, it's okay. Just tell me the name. Pooja, okay. Dr. Pooja, Dr. Madhu.
Pooja is there. Dr. Madhu Rastogi is there. Dr. Sajal Kakkar is there, and Dr. Nafees Ahmed Siddiqui.
Okay, fine, perfect.
Okay. I think we, Dr. Randeep, you can involve Dr. Neeraj and also he can also be a expert panelist with us.
Dr. Neeraj is a surgeon.
He's a radiation oncologist.
Okay, fine.
Senior Vice President Radiation Oncology Association.
Okay, thank you. So I think we will start away with the case and we will try to wind up. So I will request an organizers to tell me 5 minutes before, and we will try to wind up early as we are already running very late. So
sure,
45-year-old male.
25 minutes.
I have 25 minutes, yes. Okay. A 48-year-old male diagnosed in December 18 with pain abdomen and underwent some imaging and lab parameters. CEA is 80. LDH is 602. Normal bilirubin and liver functions. No comorbidities. CT scan shows a thickening of the ascending colon with liver metastasis. Colonoscopy lesion is about 7 centimeter in length near IC junction. Biopsy adenocarcinoma. Site of metastasis on staging liver only. No lymphadenopathy in the abdomen. No peritoneal seeding. No lung metastasis. So this is the case. So I think any of the panelists, we can start with Dr. Pooja. So it is a liver limited ascending colon adenocarcinoma.
I think Deep addressed to somebody else. Pooja has left because of some urgent commitment.
Okay, so
Yes, left just now. She
anyone,
just
I
messaged
think
me.
in this scenario, anyone can take the question. It is better. Anyone can take this.
Can you specify the number of metastases in the liver?
We will be coming to that. It is a liver limited disease. Dr. Neeraj, you can also take this question that would you like to do any biomarker assessment in this case?
First, what about the biopsy? It is adenocarcinoma. What about the grades?
It is adenocarcinoma. It is adenocarcinoma grade 3.
IC junction, so there is no role of any KRAS or NRAS mutations.
You would not like to do any
So
biomarker assessment.
it has been done. I think there is no other BRAF mutations have been done.
Like, I mean, I could not get it, Dr. Neeraj. Would you like to do any biomarker assessment or not?
No.
No biomarker assessment. Any other panelist? Any other panelists would like to do any biomarker assessment in this case?
Dr. Nafis, you can take this.
Dr. Nafis? Okay, fine. So I think, I mean, in the interest of time, I think biomarker assessment, I may slightly differ from Dr. Neeraj. Biomarker assessments are necessary, especially when we are dealing with a liver limited metastatic disease, because we will be adopting a pre-operative chemotherapy approach and not directly operating this patient, because I will show the images. I think this was the reason Dr. Neeraj said no biomarker assessment. It is Dr. Neeraj, we have total 5 metastases, all restricted to the right side. Largest is 3.2 by 2.8 centimeter. So what next? Any of the panelists would like to take? Anyone? Dr. Nafis, would you like to give pre-operative chemotherapy or surgery directly?
I think they have not unmuted themselves.
Okay, I cannot. Please unmute yourself.
Ravinder, please. Ravinder or Sunidhi?
Sir, I'm doing, sir, but he is not. He has to do it from himself, sir.
Dr. Nafis, please unmute yourself, and all the other panelists also. We have 3
Dr.
for only.
Sajal is also there. He can take on. Dr. Sajal, are you there? I think we have to convert it into speaker presentation.
If you're okay, I can actually take this forward in a more of a discussion format on my own, Deepak, because Sajal is not there, Pooja is not there.
I think because of getting late, this has happened. You can please carry on. We have experts here to give us comments.
Okay, so Dr. Neeraj, pardon, I think so. What?
Can I add something, Dr.
Yes, anyone can add it. Please, Dr. Meenu, go ahead.
This is a case with a 5 liver, 5. I think I'm seeing the slide with a 5 number of metastasis. Why not to start the neoadjuvant chemotherapy? This
Perfect. So I agree we don't have a surgeon because, but I also agree that there are 5 metastases. It would be a better approach to start with the pre-operative chemotherapy rather than directing this to surgery, because it looks, though the limited number of images are there, but it looks that it is unresectable.
Yes.
So whenever we have to take the patient for surgery, I think to a surgeon, many factors matter, such as the comorbidities of the patient, fitness for surgery. Side, I think, may not matter much to the surgeon, but yes, gradually it is becoming one of the very important factors to decide the type of treatment. As Dr. Neeraj was pointing out, right-sided, he may not do any biomarker assessment, and left-sided he may do. I will be coming to Dr. Neeraj for that comment back again. Colon or rectum is one of the very important thing, because the whole colon is not treated in a similar way nowadays. Right is treated separately from the left, and and rectum, even rectum is also not treated uniform. Upper rectum is not treated similar as the middle and lower rectum nowadays. Age and tolerability for extensive liver resection, liver limited or spread to the nodes or lung nodules, obstructive versus non-obstructive mass. Because if you have a similar situation where there is an obstruction symptoms, then you would like to approach the primary also first, then give neoadjuvant chemotherapy, and then do the liver resection later, especially if this patient is having obstruction. Sidedness already, and yes, RAS MSI status is important in both right and left sided. At least we shall do these 3 biomarkers as of today in Indian scenario. So there are many factors on which systemic treatment regimen matters as depicted on the slide, and these factors play a role not even in a liver limited first line therapy, but also in the later lines of therapy. So suppose we presume this patient of 48-year-old right-sided colon cancer has all RAS wild type, and all RAS wild type means KRAS wild type, NRAS wild type, BRAF negative, MSI microsatellite stable. I think we don't have Dr. Neeraj. This was actually one of the comments that are you planning to add a biologic in this case? If the surgeon says, and as Dr. Meenu is saying, if the surgeon says that please go ahead with neoadjuvant therapy, would your choice be only FOLFOX, FOLFIRI, CAPOX, or it will be a targeted therapy? And if you add a targeted therapy,
I will like to add bevacizumab in this case. Since it is metastatic colorectal cancer and it is right side, so my choice will be FOLFOX plus bevacizumab.
okay. Anyone from the group, anyone who's present from the attendees, if they can suggest anything else or any, I mean, difference from Dr. Neeraj. This is absolutely a valid choice, FOLFOX plus Bev. So I may slightly differ. I agree, FOLFOX plus Bev is a valid choice. The problem comes that Bev has to be stopped at least 6 weeks before surgery. That is one of the impediment, because you are not able to give the complete 6 doses. Even if you give 6 FOLFOX, you will have to omit the Bev at least in the last cycle. Also, there is some data to suggest that we all know what Dr. Neeraj is saying is actually quite well established, that on the right-sided anti-VEGFs work better, and on the left-sided anti-EGFRs work better for all RAS wild-type tumors. But if you talk about responses, the responses are much better when we combine a doublet with anti-EGFR. And this is the ESMO 2016 guideline table. Sorry for missing out the reference on this slide. The sequencing of therapy also matters about the goal. For example, in a liver-limited colorectal cancer patient, the goal is actually a rapid response and a cytoreduction. Though if you talk about overall survival and we are not operating this patient, then there will not be much difference between anti-VEGF or anti-EGFR being added. But if you talk about cytoreductions and responses, adding a cetuximab-based regimen to doublet in the right side also makes sense. In the left side, definitely most of us will add. But in the right sided also, the point which I'm trying to make here is, in the right sided tumor also, doublet plus anti-EGFR is one of the comparable therapy. What Dr. Neeraj has said of adding a doublet plus anti-VEGF is absolutely not wrong. It is absolutely acceptable therapy. When we see the data from all the trials, whenever the FOLFOX is given with or without Bev, the response rates don't differ much, as you can focus on the cursor. Even CAPOX with and without Bev, the response rates are similar. Only regimens where the response rates increase are the triplet-based regimens such as FOLFOX, FOLFOXIRI-Bev, or FOLFIRI-Bev. So whenever the triplet is added, the response rate increase. But whenever a Bev is added to a chemotherapy backbone, the response rate does not increase. So that is the point I said that anti-EGFR is a valid therapy. On the contrary, if FOLFIRI is given with and without cetuximab, you can easily see across a trial, whether it is PRIME, OPUS, CRYSTAL, PRIME is panitumab, CRYSTAL, OPUS are landmark cetuximab-based trials with and without chemo. Chemo with and without.
Dr. Randeep, we have an interventional radiologist with us. Sorry for disturbing. Dr. Saurabh, please unmute yourself. If you want to ask about liver related things, the metastasis or some intervention radiology is there.
Okay, I will. We will definitely involve Saurabh. So,
very good afternoon.
I just
Dr.
Dr.
Meenu is a radiation oncologist at Dehradun.
Dr. Meenu, your comment, and then I would take help of
I
Saurabh.
just wanted to add one thing. As you told, definitely these addition of the anti-EGFR versus as of serious. I just wanted to have the perspective because part of the puzzle is the timing of the resectability. But there are various randomized controlled trials and there is I think comparable giving the this doublet along the bevacizumab. What is your, because you yourself are the expertise as a medical oncologist, the apart from the timing of the resectability, bevacizumab versus this EGFR, if there is nothing additional resectability difference between the two regimens.
So, Dr. Meenu, as far as the anti-EGFR is there, you can resect after 2 to 3 weeks. Folfox is not very myelosuppressive. 3 weeks is a safe time. If you are giving a bevacizumab, 6 weeks is to be the time between any surgery, whether you are giving pre-operative to ovary or colon. These are the two tumor settings where we use Bev. 6 weeks gap is to be there between the last dose of Bev, both in the pre-operative and post-operative settings. So, Dr. Saurabh, since we are dealing with a liver-limited disease, you can unmute yourself and help us and just share your experience in very brief 2 to 3 minutes, that how you have been helping the surgeon in your institute. Whenever we talk about liver-limited colorectal cancers, and though this, I will go back to the images, is not very difficult resection, but sometimes you have bilobar metastasis, sometimes you have metastasis near to the porta. So in just brief, how you have been helping the GI team or the surgical team?
So a very good afternoon, sir. Yeah.
Cancer. Liver
Yeah.
limited operable colorectal.
So in liver limited operable cancers, what is being said is resection and ablation, percutaneous ablation using microwave antennas or radio frequency ablations. They can provide almost equal efficacy and results as per the surgical resections with less, I would say, surgical complications, all the things. Definitely, interventional radiologists, they have their role when the lesions are central to the areas which are not easy for surgical resections, like you said, near the portal bed or near the IVC ostium and those areas which are not amenable for surgeries. Even for peripheral also, patients who are not ideal surgical candidates, is sometimes the patients are old, they are not to be taken up for major surgeries like liver resections, and in those patients also definitely IR has a role. Also, there have been studies uh, who have been looking up the role of SERT, that is Y90 in CRC mets. But yes, CRC mets are generally hypovascular. The results are not that great as HCC, but definitely it's also coming up as one of the modalities.
Thank you. I think that was quite brief. And yes, Dr. Meenu.
Urgent chemo has to be tried for any local hepatic intervention.
Yes. So, Dr. Meenu, I think what Dr. Saurabh and I were alluding to was that sometimes even after giving 4 months of, 2 to 4 months is the time where we give pre-operative therapy, sometimes there are some difficult lesions. For example, you have 4 lesions which are clearly resectable, but the 5th one is near porta, near the IVC ostium, or on the opposite side, and you cannot.
This can be supplemented with this.
It is always supplementary, and of course, in the non-adenocarcinoma settings, in neuroendocrine tumors, the interventional radiologist for a liver-limited disease plays a major role. So, I think skipping this part, let us come to one thing which is actually we don't have a surgeon, but suppose the situations were same and this was a rectal primary. How would the group like to treat it? I mean, everything is same. The liver lesions you have seen. He's a 48-year fit male. There are no comorbidities. Only one thing is that instead of ascending colon primary, the tumor is in the rectal primary. So anyone from, if Dr. Neeraj or anyone is there who can take, whether they would like to go for CTRT followed by surgery, CTRT followed by 3 cycles of chemo or surgery, and total neoadjuvant approach. I think Dr. Sajjal is here. And
Yeah, hi, Dr. Randeep. Good afternoon, everyone. In this setting with the synchronous liver metastasis on presentation, I think probably we can start with neoadjuvant chemotherapy, and post 2 to 3 cycles, we can add short course of radiation, not the full long course radiotherapy, maybe short course of radiotherapy to the rectal disease, followed by surgical resection of both the primary as well as the liver lesions if it is possible.
Great.
I would like to start with chemotherapy.
Okay.
I am a radiation oncologist.
No. Dr. Sajjal, I mean, are you of the favor, and you know the data in ASCO 2019 has been there has been 2 randomized trials for total neoadjuvant approach.
Yeah.
So would you like to finish all the 6 cycles of chemotherapy and then give short course and then operate?
No, I would like to give initially with 2 to 3 cycles of chemotherapy and then assess the disease first.
Chemotherapy with targeted or only chemotherapy?
That I think better the medical oncologist should decide regarding this.
Okay, Dr. Randeep, if the tumor is deficient MMR, would you like to give chemo or immunotherapy?
In a liver limited disease, Dr. Neeraj, it is a difficult question to answer. I mean, in a patient where the plan is to go for a neoadjuvant approach, as of now, we don't have the data to use immunotherapy. If it is clear
that DMMR tumor are not responsive to chemotherapy now, it is clear. And then if we are giving neoadjuvant chemo.
Dr. Neeraj, just give me 2 minutes. I will address this question. Can you?
5 minutes to wind up, please.
Okay, fine. So I think I will just go forward with this and come to Dr. Neeraj's question directly. And so this is a question which Dr. Neeraj was asking, and it was already there in my mind. When you have a patient who is deficient MMR or MSI high, what do you use first line? So you can use a Folfox, Capox, Folfiri, Bev, as well as you can use pembrolizumab. And this is a recent change in 2020, where earlier the usage of pembrolizumab was not permitted in first line. But again, Dr. Neeraj, this is a setting where we are thinking of an advanced metastatic disease and not a liver limited disease, not a preoperative setting. It is a purely palliative setting. And the trial was a plenary presented at ASCO 2020, which is also called as Keynote 177 study, where MSI high stage 4 colorectal treatment naive patients were randomized to pembrolizumab for 3 years versus chemo targeted combinations. Primary endpoint was PFS as well as OS. PFS data is out, and I think few of you must have seen these curves. I mean, it is such a wide gap. We usually say if you can keep a finger between the curves, here you can keep the complete hand between the curve. And you can easily see that at very early separation, around 4 to 5 months, at 24 months, more than doubling of progression-free survival. Everyone is benefited. Even BRAF wild-type patients with MSI high are also benefited. KRAS and RAS wild mutant are on the borderline, which is a debatable issue, but otherwise, every subset which we talk about, irrespective of the age, more than 70, sex, geographical region, BRAF mutated, everyone is getting benefited. So this is the data which Dr. Neeraj was alluding to. I think I will wind up. Only thing last, we don't have Dr. Madhu, but Dr. Sajjal can case. Dr. Sajjal, how do you follow your colon cancer patients?
So we actually do the history and physical examinations every 3 months. And once in a year, we do the imaging, maybe a CT scan and the colonoscopy. And follow-up is every 3 months for first 2 years, then every 6 months for the next 3 years, and annually thereafter. Serum CEA can be repeated maybe 6 months or once in a year.
I think for the first 2 years, most of the guidelines, it is absolutely what Dr. Sajjal has mentioned. Only thing is that imaging is a bit more frequent. At least for first 2 years, you have to go for a 6-monthly imaging. Most of us, I think in Indian scenario, are using an ultrasonography, though that is acceptable, and few of the institutes and oncologists do follow CT scan. But at least an imaging shall be done every 6 months. Rest is what Dr. Sajjal has said. I think in the due interest of time, we will save a couple of minutes here. If there are any comments from the panelists, we can take it, or from the organizers, else I will hand it over to the organizers for the expert comment of Dr. Neeraj.
Just a small point, Dr. Randeep. Though for liver metastasis, surgical resection is always the initial, the first treatment we should always think about. But apart from radiofrequency ablation, we have SBRT also nowadays for the liver metastasis. Just the sequencing and when to introduce it, it always should be discussed in multidisciplinary settings. But in a case like what you presented up to 5 lesions, and where the maximum diameter is obviously less than 5 centimeter, probably if surgically not resectable, or if surgery is not an option, SBRT can be considered, even if it is close proximity to porta hepatis.
Thank you. Point well taken.
PRT should be considered if the surgery is out of question in these cases.
Dr.
I think
Randeep,
the SBRT should be promoted.
Dr. Randeep, thank you very much for doing this. And I'm sorry, we are short of time. That's why we have to cut it short. And second time in succession, we are doing that. But next year, I commit to you that you will be delivering plenary lecture at our conference. Thank you.
Thank you, Dr. Deepak. Thank you. Okay, bye.
Thank you, Dr. Neeraj, Dr. Randeep, carrying on the discussion so well. Now, next, we move on to case-based discussion on childhood malignancies. May I call upon the chairperson, Dr. Purohit from Mumbai. She is a professor, pediatric oncology. Dr. Munish, has he joined? Dr. Munish Gerola from Delhi, has he joined?
Yeah.
I cannot.
Yeah, I've joined.
Welcome, sir.
Yes,
welcome,
sir.
Sir is the Director of Radiation Oncology, Rajiv Gandhi Cancer Institute, Delhi. Now I request Dr. Shweta Bansal, Mumbai. She is a pediatric oncologist at HN Reliance Hospital, Mumbai, to moderate the session. The panelists, I have 4 people in the panelist list. Dr. Meenu Gupta from Dehradun, Dr. Dilip Ramakiani from Jaipur, Dr. Kajal Shah from Ahmedabad, and Dr. Saket Das from Bhopal. Can we start?
Dr. Poorna Kurkure has also joined as expert chair, Dr. Saima.
Yes, I have welcomed, sir. I have welcomed, ma'am.
Okay.
Thank you,
Saima. Ma'am, welcome to the conference.
The Shweta is here already. Dr. Shweta,
Dr. Shweta, please start.
Okay. Can you hear me now?
Yeah.
Okay, I'm starting this. So in interest of time, I'll just welcome all the chairpersons and panelists to be on board for this discussion. So just keeping this childhood cancer in perspective, we have a huge Indian population in which 0 to 14 years is 30% of our population, and we have almost the children is equivalent to USA population. And considering the childhood cancer, we have almost 15 to 75,000 new cases which happen per year, and that means around 100 new cases every day in India it happens. So next slide. India, yeah. So mostly in childhood cancers, we find the cancers early in the age and then later in the adolescent age. And there are different cancers which happen at different times, different ages. We mostly have neuroblastoma, Wilms tumor, retinoblastoma at early age, and then followed by leukemias, non-Hodgkin's lymphomas. And then in the adolescent age, we may have more of a bone tumors and Hodgkin's lymphoma and germ cell tumors. So this is the incidence of childhood cancer. Acute leukemia is the most commonest, followed by CNS tumors and lymphomas, and then other tumors. And over the years, definitely the survival is improved. We all know that. And childhood cancer actually leads in telling us how to treat the cancers overall. And there is a lot of difference between childhood cancer and adult cancer. We all know that they are more aggressive, they grow fast. We don't know their cause, but they are much more treatment responsive as compared to adult cancers, and they are curable in all stages. So now coming to the case-based discussion, I would like to take the first case as lymphoma, because lymphoma is one of the commonest malignancies in children. And this is the first case scenario. So this child, who was 12-year-old, he presented with a history of cough and fever for 2 weeks. And he had worsening of cough, which was more on lying down. He had breathlessness, he had severe respiratory distress. His bloods were done, which was within normal range, but his LDH was very high, uric acid was very high. So I would like to ask the panelists what is their thought on seeing his underwent the CT scan, and CT scan shows this. So maybe I can start with Dr. Mini Gupta, if she can comment upon this CT scan and tell us like what's her thought.
Thank you, Dr. Shweta. I was just thinking because we are discussing in the era of the COVID pandemic, and to be very frankly and honest, if this child with the fever, and this is the actually phobia at this maybe point of time going for the COVID test or not, or what are the ICMR guidelines, that is another part of the leaving COVID apart at this point of time. Okay, so it's a 12-year-old child, and I can see their symptoms are there, and the mediastinal, I can see the mediastinal widening is there, and there is some compression of the SVC also. So because of childhood malignancies, I would go for the workup like lymphoma or some germ cell tumor, but it can be symptoms. The fever is there, weight loss is there towards the lymphoma.
This child was admitted to ICU and he was intubated and ventilated. As Dr. Minu Gupta has rightly said, that in this COVID era, we have to think about multiple differential diagnoses. And we need to do a COVID testing in these patients and followed by other investigations. And considering the typical presentation of this patient with a very short history and which is worsening very rapidly, we need to think lymphoma or malignancy as one of the important or the first most differential diagnosis. So my next question is to Dr. Saket Das. What would be your next step in management of these patients, and what relevant investigations would you like to do for the management of this patient? Dr. Saket Das, is he here?
Am I audible?
Yes, sir.
Yeah, I think good afternoon to all. I think this is a very common presentation of the childhood malignancy as far as lymphoma is concerned. And in this current context, as Dr. Minu Gupta has told, that evaluation for the COVID also becomes important. Now, as far as the management, the next step of investigation is concerned, it would be classified into establishing the diagnosis, then emergent situation, which are the investigations to assess the emergency status, and also for the management. Now, as for the diagnosis, in this situation, as the child is presenting with pleural effusion, pleural fluid evaluation, cytological evaluation to establish the diagnosis would be relevant. And since this child is presenting with SBCO, chest X-ray has been done, which shows quite a lot of mediastinal widening, and also the tumor lysis workup, because that is one of the commonest emergency complications which can arise due to the therapy. So, and for the investigations for the therapeutic management like this LFT, RFT, complete blood counts, which has been done. Now, as far as CT scan chest is concerned, I would like to wait, because that would not add at this moment, and given this hemodynamic, it will depend on the hemodynamic condition of the patient, because in view of mediastinal compression due to SBCO, this may not be feasible. Initiation of the treatment can be done, and at an opportunity, at whenever feasible, CT scan or cross-sectional imaging can be added.
Dr. Shweta, from my perspective, if the child is there and with the symptoms are there and suspicious of lymphoma, without wasting any time for the prompt diagnosis, we have to proceed for at least we can take out the pleural fluid aspiration for some flow cytometry, whatever, and do the some medical management and the biopsy wherever possible, or the some further diagnostic point of view.
Absolutely.
Dr. Shweta, can I come in, please?
Yes, ma'am. Yes, ma'am. Please, Dr. Kulkuri, yes.
The only thing is that we should do the pleural fluid aspiration under local anesthesia, no GA or no positioning can be given to this child, because CT is out of question. He is already intubated and very breathless. But bone marrow aspiration and pleural fluid can be done by the bedside. And then he should be challenged with the chemotherapy like high-grade lymphoma with only the pre-phase COP-like regimen to avoid the problem of non-manageable tumor lysis syndrome. So these two being very volatile, particularly the bone marrow aspiration, And that too in a 12-year-old child, if we can manage by the bedside under local anesthesia, it would be adding to the information.
Absolutely, ma'am. So this is a very common scenario which actually we face in our day-to-day oncology life, I would say. And these patients, they come in a very rapid progression of the tumor and they do land up in ICU. And management of these patients definitely requires a team effort and a very judicious use of the resources which we have at that point of time. So minimal invasive procedures and trying to reach to the diagnosis is very, very important. As Dr. Meenu Gupta and Dr. Kurkure ma'am has highlighted that we need to do a pleural fluid aspiration, and that is the best way to go about the diagnosis in these patients. And we can send it for cytology and flow cytometry, and we can get a test. We can reach the diagnosis and accordingly treat the patient. So my next question is to Dr. Kajal Shah. What are the oncological emergencies she is anticipating in this patient, and how she would like to manage?
In this patient presented with superior vena cava syndrome. So patient have a tumor lysis syndrome because of disease also, and after treatment also. So we have to manage tumor lysis syndrome, and we have to manage superior vena cava syndrome with a ventilator and intubation, and the patient should be admitted in critical care unit for observation. And after starting with cytoreductive CVP, we have to monitor the tumor lysis parameter. We know there is a Carlo-Bishop criteria is there, and we have to give hydration and brassburicase if needed, and then we have to treat with the multi-agent chemotherapy like BFM90 protocol.
Absolutely. So actually, definitely there is a tumor lysis syndrome. We know that the lymphoblastic lymphoma, they are very aggressive tumors. They grow rapidly and they respond to the chemotherapy also very well. And there is a huge tumor lysis which happens. And because of this rapid tumor lysis, we can land into tumor lysis syndrome. So in this patient, definitely there is a double whammy. Patient is already having a superior vena cava syndrome, and plus the patient can go into tumor lysis syndrome. So managing the IV fluid is very, very important. The only thing which I would like to differ from Dr. Kajal Shah is that maybe CVP is like we don't use in pediatric patients, considering that these tumors are very, very sensitive to steroids. So mostly if you give DEXA alone for 2 or 3 days, the tumor, everything gets settled down, and then you can embark on the complete protocol-based therapy. I would like to have Dr. Kurkure's comment also regarding this cytotoxic therapy in these patients as initial therapy. What she would like to use in patients. Ma'am, can you have some? Can you highlight what chemotherapy would you like to initiate in these patients initially?
We can give only DEXA to begin with, and that shows a very dramatic response. It's like a therapeutic challenge for a child without even a diagnosis, cytological diagnosis. And then we can embark on the definitive treatment in form of, also if it turns out to be a leukemia, it will serve as a pre-phase for leukemia. Because there is a leukemia can also present with the mediastinal mass like this. So that is why I suggested that we should do the bone marrow aspiration by bedside and rule out leukemia with a mediastinal mass rather than lymphoma alone.
Dr. Dilip, would you like to add anything regarding the diagnosis of this patient? Would you think that you will require a tissue diagnosis, or you would like to do a diagnosis on pleural fluid only in these patients?
Yeah, I think ideally both should be obtained, and I think sometimes the pleural fluid tap might, when subjected to flow, may not be just sufficient. Yes, obviously biopsy, if done, would be more beneficial, a bone marrow biopsy. So I think we should use both these sites, and so that we are able to reach at a convenient, comfortable diagnosis in this patient.
So other question is the practical question which we always ask: so how much pleural fluid you always want to get to give us a cytological diagnosis?
You mean to say by flow?
By flow as well as by cytology.
Cytology, I think we just need a few mLs of fluid just to prepare. But yeah, but I mean, if you get 10-20 ml, then we centrifuge it, and then we try to give a cytologic diagnosis. So flow, that will suffice for flow as well, I guess.
Okay, thank you. So these are the guidelines to how to manage tumor lysis. And as Dr. Kajal Shah said, that rescue case should be used, and it is now easily available in our country at much cost, for quite affordable prices. So these can be preemptively can be used in these patients. So this patient was urine fluid analysis was done in this patient. He was given hyperhydration and allopurinol, and patient was started on steroids. He became stable, and then multi-agent chemotherapy was given for this patient as per the BFM protocol, and he improved and was doing well. So next is another lymphoma case. So he's a 7-year-old child. He's a 6 month. From 6 months, he had a painless neck mass, 12 centimeter matted form. He had fever, cough, weight loss, chest X-ray normal. Montus was 10 millimeter, and he received ATT treatment. So I think this is a very typical case scenario which we again see in our daily practice. And so he had a progressive painless, no inflammation. These symptoms were there, and rubbery feel was present. So what are the differential diagnoses? Maybe Dr. Kajal Shah, what would you do in this patient? And would you advise for FNAC, core biopsy, or whole lymph node biopsy in these patients?
This is a 7-year-old child presented with 6-month history of lymphadenopathy with P symptoms. So most likely the diagnosis is Hodgkin's lymphoma, and we prefer excision biopsy if possible, otherwise core biopsy to get the proper diagnosis.
Okay. So now, so Dr. Dilip, can you tell us how would you like to, what material would you like to receive in these patients? Whether you think FNAC is good enough for core biopsy or whole lymph node biopsy, what you would like to prefer?
Yeah, I would always say that ideally a full excision biopsy, but if not possible, then a core biopsy. FNAC would usually not be, I would not prefer an FNAC because sometimes it confuses you in diagnosis. Rather, you are not able to get a very clear-cut diagnosis because the material obtained in especially for lymphomas, if you are doing, I mean, FNAC does not serve a purpose. So either ideally an excision biopsy, but if not available, then probably core biopsy would be sufficient. And I would like to suggest that it should be taken from a representative lymph node of probably a more than 1 centimeter size. It should not be an inguinal node if possible. And you try to get a whole node, and especially if it's not a mediastinal or abdominal node. So these are the things I think. I would prefer an excision biopsy, and if not possible, a core biopsy, and definitely not an FNA for management.
Absolutely. So essentials of biopsy is very, very important to understand. Mostly we delay the treatment or proper treatment of these patients by doing FNAC, which is like very not a standard of care for these patients who are presenting with 6 months of a lymph node mass, and mostly they have lymphoma. So lymph node is very, very important. So if you're not able to get it, then then
can we request the organizers to please mute all others except the panelists?
Sure, ma'am.
Okay, Shweta, please go ahead.
Yeah. So then other question is how to do a staging workup in these patients. So there is one is that we can have a resource limited facility, and we can have a complete where everything is available. So my question is to Dr. Meenu Gupta, how would you like to stage this patient once this patient comes to you?
Dr. Shweta, definitely resource limited as the child is ambulatory. I think basic workup like X-ray, ultrasound and all that, but the CT scan, definitely I would like to go for the CT scan of the neck, thorax, whole body CT scan, and bone marrow aspiration and biopsy, along with the biochemical, all those basic hemogram, cell FT, RFT, and because it was the node was there, and we have to sometime, this is very important, the basic slide workup, hemogram, and we have to see the what is the characteristic of these lymphocytes and all that. Some associated infections we have to rule out because for the different, but once the diagnosis is there, CT whole body that is recommended. along with the basic hemogram, LFT and all.
So this patient final diagnosis was Hodgkin's disease mixed cellularity, and I think if there is no there is PET scan is not available, then definitely we can just go ahead with the CT scan chest and abdomen, and followed by a bone marrow aspiration and biopsy. So this is good information. Sorry, yeah, Dr. Meenu Gupta.
If we are Hodgkin PET is not available everywhere, basic CT has to be done. But if the PET is there, then definitely for the management perspective. After the staging, then PET-based treatment is there, but CT has to be done.
Yeah, absolutely. So next question
and,
is.
Only one addition. If you do the PET, you can avoid doing bone marrow because you can get the delineation. But if you don't do PET and you do CT, one should do bone marrow, bilateral bone marrow biopsy to complete the staging. So that point has to be remembered, which modality you are using for staging.
Thank you, ma'am, for very good point. So this patient, like we have multiple chemotherapy protocols for this. So Dr. Sakib Das, can you tell us, like in your institute, what protocols are used for the Hodgkin's lymphoma? Dr. Sakib Das?
Yes. As far as I'm from the radiation oncology department, but as far as this chemotherapy protocol is concerned, there are various protocols and it varies from institute to institute. In our institute, usually this EuroNet protocol is used, which is a combination chemotherapy, and also ABBD also can be used. It depends on the resources and varies from the institute to institute.
So actually, when we are using some protocol, chemotherapy protocol for our patients, especially when they are in pediatric age group, we always have to think about long-term side effects also. So ABBD chemotherapy definitely is a very good chemotherapy, but because of the high dose of cyclophosphamide, which causes infertility issues in the later age, and doxorubicin, which causes more of a cardiomyopathy in patients, and bleomycin is also there, which is used, and we do see lung toxicity also in these patients. So considering all these issues, nowadays many of the institutes for pediatric patients are not using ABBD as a regular treatment. We are using more of a OEPA, COPDEC, VAMP, these therapies where the toxicity is decreased. Because we know that Hodgkin's lymphoma patients, they live for long and they get cured, and ultimately they don't suffer from the disease, but from the late side effects. Other important point we need to understand is there any role of RT? Dr. Meenu, can you tell us, is there any role of RT in treating Hodgkin's lymphoma, or we can just treat them with chemotherapy?
But this is actually quite a concern. We can't avoid RT to go for the various limited or intermediate stage. For this, RT has to be added, and although there are many debates about the addition of RT in some cases, but we have the trials like CCS, and there was Hodgkin 1-1 where they have shown there is a good event-free survival. Significant, there was event-free survival with this addition of the RT, and pattern of RT has already been changed with the new technology, that is the local site, inward site RT, and we can use the other modalities like IMRT and all that. That is safe for the pediatric patient, and doses are also 20 gray or 30 gray as per the risk criteria. There, this child, 7-year-old child, and the age of the patient with some bulky disease is there, RT has to be added after the.
Yeah. So if I can just add a point here.
Yes,
the role of radiotherapy in Hodgkin's lymphoma, particularly for pediatric age group, is evolving, and this is more weighed in terms of the benefit of versus the long-term side effect, as you have rightly mentioned. Now, most of these German protocols and a lot of other trials have routinely used radiotherapy. But as far as this EuroNet protocol is concerned, which is actually a PET-based evaluation, because this radiation and the combination chemotherapy, one point which you have mentioned, this also depends of kind of evaluation you are doing. So, and the risk stratification. So for group 1 and group 2, if they are PET negative in this EuroNet protocol, actually they are avoiding radiotherapy, and the interim result has been presented. But for the PET positive disease, or if there is a residual disease, definitely in this protocol also radiotherapy cannot be avoided. Apart from that, most of the other protocols, as mentioned, the German protocol and others have used radiotherapy.
Dr. Shweta, please hurry up.
Okay, yeah. So this I
Another 2 minutes.
The last case. Yeah, please go ahead. Anybody?
2 minutes remaining.
Okay, okay. So I think point well taken because actually radiation therapy, I would say most of the protocols, they show that the radiation, adding radiation to Hodgkin's lymphoma do benefit. And by giving a low dose radiation, it actually helps in reducing the chemotherapy also in these patients. And plus it improves the benefit and it consolidates the treatment very well. So we had a paper from Tata Hospital also, which showed that if you, at the end of the chemotherapy, if you consolidate these patients with radiation, they do very well and they have almost 98 to 100% survival in their core group. And I really like this paper in which they have written that don't throw out the baby with the bathwater. So which means that by reduce the toxicity of Hodgkin's lymphoma, we need to take care of multimodality treatment, and radiation should be considered in most of the cases. And if you look carefully in most of the protocols or the published literature, if you see, though they say that radiation was not given, but if you go carefully to the population, mostly 80% of the population has received radiation. So this is the point I would like to highlight, that most of the patients would require radiation and it should be given to these patients. So conclusion is RT is an important part of Hodgkin's lymphoma treatment, and it has more than a little role to play, and we are far from foolproof risk stratification of Hodgkin's lymphoma, which can be benefited by limited chemotherapy alone. And emphasis is to develop ISRT and deep breathing techniques to deliver RT safely. And maybe proton therapy is the way, and treating only post-chemotherapy volume should be the answer. So definitely radiation is the way to go for these patients. And as Dr. Deepak has said, I think I will not take the third case and just go and my slides. So the take-home message is that childhood malignancies have a very high cure rates, and if diagnosed early and treated appropriately, and it always requires a multidisciplinary team approach. Thank you to all the panelists for having a very good discussion on these two cases. And I would request Dr. Kurkure Madam and Dr. Manish Goraila to have a last word on this session.
Thank you, Dr. Shweta, for that well-conducted panel discussions to bring out certain points. Unfortunately, because of the lack of time, we could not discuss many of the solid tumors also, which require inputs of radiation oncologists. But as she concluded, I also would say the same thing and emphasize that pediatric cancer, it is like it takes the whole village to treat the child with cancer. It requires not only the 3 modalities of treatment, but also requires a lot of support system in place if you have to go through the treatment completely and properly, including the therapeutic alliance from the society. And this all ultimately lead to good outcome, because having the good protocols and good treatment and knowing that these childhood cancers, most of them are curable, is not only sufficient. The science is only not sufficient, but this science has to go with the art and the passion of a therapeutic alliance of the society to support this child and family through the treatment for the completion of treatment to see the outcome. Thank you.
Thank you so much. Over to you, Dr. Deepak.
Dr. Manish Goraila, sir.
Yeah, thank you very much. I think everybody has said a lot of things, and the only take-home message from my side is it requires multimodality treatment, which we have already discussed, that every modality has its own role in the management of pediatric tumor, and similarly in leukemia, lymphoma, as well as solid tumors. So again, I would like to thank Dr. Abrol for conducting such a nice, conference second time, and hopefully next year we will be meeting at Jammu.
Sure, sir. Thank you.
Thank you, Dr. Deepak. Thank you, Dr. Deepak.
Thank you, ma'am, for attending.
Thank you, Dr. Deepak. Thank you for inviting me.
Thank you, Dr. Kurkure, Dr. Gairola, and Dr. Bansal and the panelists. Now, I request our next speaker, Dr. Chitresh Agarwal, who's a medical oncologist in Chandigarh, to speak on the topic, picking the right strategy for patients with hormone receptor positive, HER2 negative, PIK3CA mutation. To chair the session, I welcome Dr. A.K. Rathi, who is a radiation oncologist at Lok Nayak Hospital, Delhi. Over to Dr. Chitresh for next 15 minutes.
Good afternoon, all. Thank you, Dr. Abroad, for giving me this opportunity. I request for these slides to be please put on the screen. So the topic given to me is picking the right strategy for patients with hormone receptor positive, HER2 negative, PIK3CA mutation. This is a new mutation which we have started checking in all our patients. And I am going to talk about this in next coming couple of minutes. So PIK3CA is the most commonly mutated gene in hormone receptor positive, HER2 negative advanced breast cancer. If we see the incidence, it is around 40% of patients with this subgroup of people who have a PIK3CA mutation positive. And why it is very important for us to know is because it is associated with the poor prognosis. So the analysis and a meta-analysis of all the cases who were hormone receptor positive and HER2 negative, it has been shown that the presence of PIK3CA mutation was a negative prognostic marker, which was associated with poor response to therapy and also a worse overall prognosis in breast cancer. So it is not only a biomarker for response of treatment, but also a predictive marker. So why do we want to check this? We want to check this because we have a specific drug which can block this PIK3CA mutation, and the alpha isoform of PI3K can be blocked with the drug which is called as alpelisib. And it is a drug which inhibits the alpha isoform of PI3K 50 times more potently than the other PI3K isoforms we know of, that is beta, gamma, and delta. Alpelisib does not work alone; it works in synergy with fulvestrant, and both this alpelisib and fulvestrant, they work synergistically to inhibit the PI3K and ER pathways respectively. So, targeting these mutations may overcome resistance to endocrine-based therapies, which are used in hormone receptor positive, HER2 negative advanced breast cancer patients. So, why do we test this? As already told, that 40% incidence, negative prognosis. So, we want to test these. When to test? So, all advanced breast cancer patients who are hormone receptor positive, before starting treatments, we should be, looking for PIK3CA mutations. What are the mutations specifically looking into? So which thing to look for? It is the exon 9 and exon 20 mutations basically. How to test? Two tests available: the next generation sequencing and the QIAGEN ThermoScreen PIK3CA RGQ test kit, which is available in India nowadays. And with sample, both the tissue sample and the liquid biopsies can be used for this testing. So what is the available data to use this alpelisib? Alpelisib is the drug which was specifically approved after the SOLAR-1 data came in. SOLAR-1 is the first phase 3 trial leading to an approval specifically for advanced breast cancer patients with a PIK3CA mutation. So a total of 572 patients were enrolled in this trial. Out of these patients, they were hormone receptor positive, HER2 negative advanced breast cancer patients. They were PIK3CA mutation identified patients who were randomized to either Pluvicto plus fulvestrant combination or only to placebo plus fulvestrant. So one group got fulvestrant plus alpelisib and the other group got only fulvestrant and placebo. The primary endpoint of this trial was PFS in patients with a PIK3CA mutation investigation assessment done. So, if we see this, curves here, we see that the separation of the curves are quite early. If we see by the end, starting of the second month, there is a wide difference in the two curves. So, the alpelisib plus fulvestrant arm had a median PFS of 11 months versus only fulvestrant arm had a median PFS of 5.7 months. So, there was near doubling of PFS when alpelisib was added to fulvestrant in this setting. So PFS results across subgroups was that the benefit was consistent in across all subgroups. I will like to, take your attention only to one specific thing, that if we see this cursor here, prior CDK4/6 inhibition treatment, this is a point which you should definitely look upon, because this is for our practice. Most of the patients usually get CDK4/6 inhibitor plus an AI in first line. So only 20 patients were those who had received this therapy earlier, and then this therapy was started. So basically, for a particular group of patients who have received previous CDK4/6, we do not know for sure how much is the actual benefit of using alpelisib in those settings. So coming to response rates were definitely doubled with use of fulvestrant plus alpelisib in this setting. Tumor shrinkage was observed in 3 out of 4 patients with a PIK3CA mutation and who had a measurable disease at baseline. So the responses achieved were deeper with Pluvicto plus fulvestrant. So coming to the dosing administration, Pluvicto comes as a 300 milligram tablet, 150 milligram tablet, actually 2 tablets to be taken, and they should be swallowed whole and to be taken with food approximately at same time each day. And fulvestrant, we know the dose is 500 milligrams on day 1, 529, followed by monthly. And if we see the dose modifications, we have to see that the starting dose is 300 milligrams. The first dose reduction is 250 milligrams, and the second dose reduction is a 200 milligrams. So when we encounter side effects, 50 milligram of dose is to be reduced each time. Now, manageable side effects are there with in this combination, but I will like to take just your attention to 2 side effects which are really important. One is a metabolic side effect of hyperglycemia, and other of skin and subcutaneous tissue disorders, rash. So if you see this, there is around 37 to 40% incidence of hyperglycemia, around 20% incidence of rash when we use alpelisib in this setting. So why hyperglycemia? As we all know that PI3K is a target through which the glucose is transported into the cell. So if we are using a PI3K inhibition, so it blocks the glucose uptake by the cell, and once the glucose uptake is blocked, definitely it leads to hyperglycemia. So dose modifications, the recommendation is that fasting plasma glucose levels and HbA1c should be monitored, and baseline before starting these treatments, fasting plasma glucose and the HbA1c should be controlled. If a patient is a diabetic, then metformin and all of the medications should be started, and we should be very, very particular about the hyperglycemia as well as the rash side effects for this treatment. Not only medical management with the use of metformin or insulin, lifestyle change is equally important when we are dealing with hyperglycemia in this setting. So the only laboratory monitoring needed for patients on Pluvicto is for fasting glucose and for HbA1c levels. So, once per week, we should be able to assess fasting plasma glucose levels and very frequently the HbA1c levels, because this is the primary side effect for these patients on treatment. For patients who have rash or which are known to cause side effects of rash, prophylactic management of rash may decrease incidence and severity of rash, and the most commonly accepted treatment for prevention of rash is a non-sedating antihistaminic treatment. And if we use up prophylactic measures like usage of antihistaminics at the initiation and during the treatment, then the incidence of these rashes are considerably reduced in comparison to when they are not used. So
I welcome Dr. Rajesh Angral, who has joined to chair the session. Dr. Rajesh, welcome, sir. You can continue.
Please continue, sir. Please continue, sir.
So Pluvicto plus fulvestrant is a category 1 recommendation for NCCN patients who are PIK3CA positive. So as I had previously told, that this PIK3CA mutation can be tested either on a tumor tissue or a liquid biopsy. And if these patients come out to be PIK3CA positive, then Pluvicto plus fulvestrant is the preferred modality to go forward. So to summarize, not taking much of the time, PIK3CA mutations are present in approximately 40% of the patients of hormone receptor positive, HER2 negative advanced breast cancer patients. and presence of this mutation, it indicates a poor prognosis. These tablets, they target the PIK3CA mutation, specifically the alpha isoform, which is 50 times more potent than the beta, gamma, and the delta isoforms. As per the Solar 1 trial data, there was a median approximately doubling of the PFS when Pluvicto plus fulvestrant was used in combination. So 11 months versus around 6 months. And not only the increase in progression-free survival, this combination is also associated with the increase in the durable response rates. And for safety management, only 2 side effects to be very careful about. Number 1, diabetes, and number 2, rash. So Pluvicto alpelisib is a biomarker-driven therapy with NCCN category 1 evidence in combination with fulvestrant for advanced breast cancer patients who are having PIK3CA mutations. Thank you.
The chairperson, please, your expert comments. Dr. A.K. Rathi, sir.
Dr. Rathi, sir? Dr. Rathi, sir, please unmute. I think sir is not available. Sunidhi?
He is unmuted, sir. He's already unmuted.
But he's not audible.
I'll check.
Start with the next lecture. I'll speak to sir.
Okay, sir is the chairperson for the next session as well. So the topic is personalized therapy to further improve outcomes in BRAF mutated metastatic small cell lung cancer. And I would like to welcome the speaker, Dr. Jatin Sarin, who's a medical oncologist, Chandigarh. Sir, you have another 15 minutes. And Dr. Rajesh Angral will also again chair the session.
Dr. Rathi is online.
Good evening, everybody. And thank you, Dr. Deepak Abrol, for giving me this opportunity to deliberate on this very wonderful conference that you organized. And now we are switching gears. We are talking about now metastatic non-small cell lung cancer. And like Chipresh spoke on breast cancer, targeted therapy on breast cancer. Now this is targeted therapy or personalized therapy on lung cancer. Well, this is about a new target, that is BRAF mutation. Next slide, please. Next slide. Next slide. So the objectives of my presentation will be in 3 parts. We'll understand the role of BRAF in metastatic NSCLC. What is exactly BRAF? We'll gain awareness about the testing methods and diagnosis of BRAF positive non-small cell lung cancer. And finally, we'll review the clinical data on the recently launched TKIs attacking this particular mutation in advanced NSCLC. So what is BRAF? Next slide. So BRAF is an important component in cell signaling pathway, which we all have been taught in our oncology training, that is RAF, MEK, ERK pathway. In short, it is also called as MAPK pathway or mitogen activated protein kinase pathway. And BRAF is an important protein. Sorry, previous slide, please. BRAF is an important protein in that cell signaling pathway, and which is mutated in many malignancies, namely melanoma, colorectal, thyroid, and also it has been now shown to be mutated in some adenocarcinoma of non-small cell lung cancer. Next slide. Next slide. So, 1 to 4% of all non-small cell lung cancer adenocarcinoma are mutated in non-small have BRAF mutations, and the important thing is they typically do not overlap with other common mutations in non-small cell lung cancer. So they are actually, when they're present, so they are the key driver mutations. And in contrast to other oncogenic driver mutations in NSCLC, BRAF mutated NSCLC do not have clinical characteristics which are well characterized. Like they do not appear to correlate strongly with age, sex, stage, and diagnosis of smoking status. However, some studies have suggested that BRAF mutations are more likely to be are present in female patients having a history of smoking, in contrast to that EGFR mutations in which you have the characteristic of a presence in non-smoker and female patients. Next slide. Among although V600E, that is the most important BRAF mutations, which is the driving force in most of the NSCLC tumors, which is present in about 50 to 70% of cases. There are other BRAF mutations which are identified, but to be very clearly telling you that the TKIs which are targeting these BRAF mutations have a specific activity against this very particular mutation when it's a point mutation at the 600 level where valine is substituted with glutamic acid. Next slide, please. So, what are the how do the BRAF mutated NSCLC behave? BRAF mutated NSCLC, the ones who are mutated have features of very aggressive tumors. They have worse outcome with platinum-based chemotherapy, which is the backbone of all lung cancer therapy, as compared to BRAF non-mutated cases. Next slide. Next slide, please. Again, showing the same thing that BRAF mutated have very low PFS, as you can see on the right hand side of your on the slide. That BRAF mutated have a median PFS with platinum-based chemotherapy of 4.1 months as compared to routine other cancer, other types having 6.7 months, and median overall survival is also relatively less in patients receiving chemotherapy. Next slide. Next slide, please. So, till date, the treatment for BRAF mutated lung cancers remains suboptimal. 33% of BRAF mutated NSCLC they present in such an advanced stage with very bad performance status that they do not receive any. They are not able to receive any treatment, and they go on to receive just best supportive care first line. And the ones who receive some first line therapy, just 57% of them out of those progressing on first line, they receive best supportive care only. They are not fit for any second line therapy. And doublet chemotherapy has been shown in one of the century history to be the most common option in BRAF mutated non-small cell lung cancer. And in patients, it has been shown that if you give targeted therapy for an identified mutation, driver mutation, you help the patient, you increase the survival by an average of 1 year. This goes for all kinds of targeted therapy. Next slide. So this has been a way of managing adenocarcinoma that we use in adenocarcinoma or non-squamous non-small cell lung cancer carcinoma without any targets, that is without mutated ALK, EGFR or ROS1. They currently receive chemotherapy or chemotherapy plus immunotherapy combination followed by maintenance, and then they receive subsequent therapy. And while ECOG performance status 3 or 4 patients, they receive just best supportive care and having ECOG performance status of 3 to 4. Next slide, please. Next slide. So now it used to be that we always used to order a serial testing with companion diagnostic. We used to test for EGFR mutation first, then we used to go for ALK mutation testing, and then ROS1 mutation testing. But the current paradigm shift has happened in the form that people tend to send NGS the first line, because of the wide availability of next generation sequencing, a broad molecular profiling of tumor is possible, which helps us identifying these rare mutations. Yes, they will be considered rare mutation because they are present broadly in 1 to 4% of advanced NSCLC. And these days, there are a lot many other rare mutations for which the drug therapies are available. So it is always better to give treatment which is personalized according to the driver mutation. It always helps the patient. Next slide. This was what was told in ESMO consensus guideline as well as NCCN treatment guidelines. And EGFR, BRAF, ALK, ROS1 are currently recommended by NCCN guideline as a minimum assessment of potential genetic alterations. And it is always better to go for a broad molecular profiling by companion diagnosis and GS technology. Next slide. Next slide, please. Next slide, please. My slides are not moving. So about the treatment against BRAF inhibitor, clinical data on dabrafenib and trametinib, respectively called Refinlar and Mexel. Next slide. Next slide, please. So dabrafenib is a BRAF inhibitor, particularly affecting BRAF V600E and V600K mutations. And trametinib is a MEK1 and MEK2 highly selective inhibitor, which comes subsequently in the cell signaling pathway after BRAF. Next slide, please. And DCCI approval is there of dabrafenib in combination with trametinib for BRAF V600E mutated non-small cell lung cancer mutation. Next slide. Next. Why combination? Because it has been seen that if you attack BRAF mutation, the subsequent step in the pathway of cell proliferation, that is MEK1 and 2, they immediately become consequently activated, or BRAF inhibitor monotherapy when given tend to show resistance, and patients do progress because MEK1 and 2 start getting activated constitutively. So to prevent the resistance and to have an efficient inhibition of this whole pathway, we give combination TKI. So this is one thing which we differ in how we treat with EGFR inhibitors. So we are simultaneously inhibiting two subsequent steps in a pathway. So this was the most important study on the basis of which it has got approval in non-small cell lung cancer, and this was a phase 2 study, of course, in which there were 3 cohorts. Cohort A was when dabrafenib monotherapy was used in already pre-treated patients. Cohort B was when combination was used in pre-treated patients, and cohort C when combination is used in first line. Next slide.
So another 5 minutes
slide,
to conclude, please.
Sure. So the primary endpoints were overall response rates, and these were the secondary endpoints. Next slide, please. Next slide, please. I would request the organizer to please comply with these on moving the slide faster. These were the clinical characteristics. 2/3 of patients in cohort A were current and former smokers, and nearly all patients had adenocarcinoma histology, and almost half the patients were in second line and beyond. Next slide. Same with cohort B, and next slide. And this was about cohort C. Nearly all patients had adenocarcinoma histology. So it is a very important driving mutation in adenocarcinoma. Next slide. So it enrolled 169 patients with stage 4 BRAF V600E mutations, and the patient who had no prior treatment with BRAF or MEK inhibitors, and majority of patients enrolled had adenocarcinoma and were either current or former smokers. Next slide. So the best response for cohort A, as you can see, that disease overall response rate, that is CR plus PR, was around 33%, and disease control rate was around 58%, and duration of response was around 9.6%. While in cohort B, you can see that the overall response rates have jumped to 63%, and disease control rate is around 45 to is around 79 to 75%, and duration of response is around 9 months. Next slide. This is about cohort B once again. Waterfall plot. Overall response rate of around 63%. Next slide. And that is the duration of response. So again, the results of cohort B. Next slide. Next slide, please. This is about cohort C. Again, the overall response rate ranging to 64%, disease control rate of around 75 to 72%, and duration of response in independent assessment, you can see going up to 15.2 months. Next slide. This is the waterfall plot for the same. Next slide. Next slide. Next slide. Next slide, please. So this is a comparison of all the studies. You can see that doublet is always better than a single agent therapy, and there is not much of a difference whether you use these BRAF inhibitors first line or second line. The only thing is the duration of response in some cases is slightly longer in first line. The common side effects are pyrexia, and you have to reassure the patient that this will be the side effect to look for, and you should counsel the patient that they should not be really worried about it, because it's only the first 2 months of using these drugs which is torrential. Otherwise, once the patient gets adjusted to the treatment, it is very, very comfortable to have. I have one of the patient who is more than 15 months on this therapy. All grades of side effects, so nearly all patients experience more than one adverse effect, and almost half are had grade 3 to 4 adverse effects, but nothing to really worry about because the discontinuation rate was just 14%. Next slide. So pyrexia is the most common adverse effect. Next slide. Just some practical aspect about managing pyrexia I want to tell you. Next slide. Next slide, please.
Please speed up.
Yeah. So the most important thing, there are 3-step management of pyrexia. You have to either interrupt the treatment for a day or two, and when the pyrexia settles, you can use antipyretics. If these measures don't lead to pyrexia remission, then you can consider use of oral corticosteroids. Next slide. Next slide. Same thing. So these are the various dose reductions you can do. For dabrafenib, you can go for every 50 mg dose reduction, and for trametinib, you can go for 0.5 mg dose reduction. Next slide. So in safety summary, the safety profile was manageable, similar to that reported previously in the melanoma trials, and the most common adverse effects were pyrexia, GI-related toxicity in the form of diarrhea, and skin reaction. Pyrexia was most common adverse effect. Next slide, and thank you. Thank you.
Thank you, sir. Thanks for attending.
Thank you, sir.
Thanks for sparing your time. Over to the chair.
Dr. A.K. Rathi, sir.
Dr. Angral, sir, भी होंगे.
Dr. Rajesh Angral, sir.
Dr. A.K. Rathi, sir. We can start with the next. I think he has
Thank you,
lost his
Dr.
connection.
Suresh and Dr. Jatin, for such an enlightening talk. Now I invite Dr. Kanu Charan Patro, who's a radiation oncologist at Mahatma Gandhi Cancer Hospital and Research Institute, Visakhapatnam, to talk on progress of radiation oncology from ortho voltage to mega voltage era. Over to you, sir.
Thank you, Dr. Kanu, for bearing with us. And the best things comes last. And I think you will do justice to this conference now.
Sir, good evening. Good evening, all. Can you? I can share my slide if it is possible.
So Nidhi sir want to share his own slides.
Okay, sir, you can start, sir.
Dr. Kanu, please share.
Yeah, I'm saying. Is it visible?
Yeah.
Okay. So good evening, all. My talk was yesterday, but because of some reason I could not present. But thank you for the bearing with me, Dr. Deepak. So history of radiation oncology from ortho voltage to mega voltage era. So if you see the cancer word is a big word, but we have solved in many ways with radiation, chemotherapy, and surgery, and many things. So if you see the statistics, more than 10 million cases are detected each year. Half of the people die because of lack of awareness and improper treatment. And every day around 2,000 Americans die, and around 20 million people live in the cancer every day, and 1 in 3 people diagnosed with cancer in UK, 1 in 4 die of disease. So there are lots of chemo, radiation, surgery, but with the the person has to suffer. So there is always a hope from a doctor or a consultant, so it gives a hope to the patient. But we should not think alone when there is a cancer diagnosed in a family level or doctor level. So we should work together to decrease the suffering about the cancer to the society. So if you see, there is not only the radiation oncologist, medical oncologist, nursing staff, audit, psychiatrist, all are important people involved in the diagnosis and maintenance of the cancer. One of these is the radiation. So in if you see the radiation mostly needed in the mostly head and neck cancers, mostly radical radiotherapy, nasopharynx, cervix, larynx, hypopharynx. Most of things also needs like rectum, cervix, stomach, head and neck cancers. Even there is a nothing can be done, like in compression, stenting, bleeding, obstruction and pain. The radiation does many more things. So if you see the discovery of radiation is a part of our life, and we are exposed to background radiation every day. So it comes from the memory line 1895, discovery of X-ray by Röntgen. 1896, discovery of radioactivity by Purohit. Then radium polonium by Marie Curie and Marie Curie. So if you can see these stickers, the first is the Röntgen, and he is the Becquerel, second one, and Marie Curie, they are the couples. They given many things to the radiation society and cancer society. So if you see the history of radiation, first Becquerel discovered the radioactivity. Madame Curie and Marie Curie discovered the radium, and they received a Nobel Prize for the Nobel Prize for their discovery, and first successful treatment of malignancy and basal cell of carcinoma of face in 1903. So if you see, he is the William Conrad Röntgen, who was working with cathode rays, and he discovered that there is a photography plate, and that is getting radiation, and there is a change in the fluorescence. So he named it X-ray. And he also noted that X-ray could be the image of the bones, and he took the first X-ray of his wife's hand. We can see the engagement rings in finger, and this news traveled rapidly around the world, and he received the first Nobel Prize in the physics in 1901. After that, basis on the discovery of the X-ray, Henry Becquerel discovered the uranium salt. He discovered the radioactivity, and he showed that penetrating radiation is in fatigue of photography plate from the uranium. And his student PhD student Marie Curie and Pierre Curie. They discovered the polonium and radium in 1898, and they received the Nobel Prize for that also. And Marie Curie received 2 times Nobel Prize, one in physics, one in chemistry, for their discovery. After that, the history started. The medical student in Chicago, Emil Goodby, noted that peeling of skins after multiple exposure to X-rays. He convinced his professor that X-ray machine in Chicago 1896 itself, and he treated a patient named Rose Lee with recurrent carcinoma of the breast. In 1896, by 1960, he instructed 7,000 doctors about the X-ray, and because of his repeated exposure to the X-ray, he has also done 19 surgeries in the multiple cancers caused by intense ongoing exposure to the radiation. Then regards experiment, you know everybody. So Claude Regard, he started that you can sterilize the sheep's testes by sterilize the sheep by irradiating the testes of the sheep. So he given a big dose, but it sterilized it, but there is a large skin reactions it happens. So he told that sterilization can be achieved without excessive damage to skin by making the fractionation. The fractionation era started by 1920 1920 era. Then Henry Cottard, he the French radiation oncologist pioneered the use of fractionated radiotherapy wide variety in the tumors, and he experimented in the laryngeal cancers in 1934, and he got the good results. Then drawbacks of orthovoltaics problem was that it only treating the superficial tumors, but it is very difficult to treat the deep-seated tumors. So then era of cobalt-6 isotope by Glenn T. Seaborg said the Nobel Prize for the discovery of cobalt-6 isotope. Then he is the Harold John. He told he requested to the Canadian, he's a Canadian physicist, and he requested the National Research Council to approve the cobalt-60 for the treatment of the cancer, and he took he started the Victoria Hospital one cervical cancer patient, and that is the important milestone in the fight against cancer. Then cobalt was spread rapidly with cobalt machine. This is the first cobalt machine installed in the Canada. And but the main disadvantage is the cobalt is the only more deep tumors and main skin reactions. And but still around 70% of the world using the cobalt because of the effectiveness and the reliability of the use. So then came the linear accelerator. It is a mega voltage X-ray, and very first time it introduced in the linear accelerator. First time linear accelerator Ginton developed the first medical linear study in the Stanford University of San Francisco in 1956. After his invention, they treated Gordon Isaac, the 2-year-old patient with bilateral retinoblastoma, and the fortunate thing is that after his treatment, the patient survived another 40 years with that disease free. So this is the first, Gordon Isaac is the first patient who got treated with linear accelerator. Then if you see the radiation dosimetry quality assurance space, like mostly the Sievert and the Condi, they own the dignity. Then one is the Roentgen therapy versus radiation therapy. Roentgen is the mostly the distant, like the teletherapy, and radiation therapy is the brachytherapy. So if you see that there is alpha and particles discovered by Rutherford, and he proposed the half-life of the radioactivity, and he also received the Nobel Prize. And cure of skin cancer by Thor Sternberg, who had to cure the BCC of nose. Tech surgeon treated the squamous cell carcinoma, squamous epithelioma by 50 treatments over 30 months. So if you see over the years, the computer taken the advantage, and they mainly 3D CRT, IMRT, IGRT technologies have taken over. And this is the 3D conformative therapy started in the early 1990s, and to decrease the side effects and treatment related side effects. After 3D, then came to the intensity modulated radiotherapy, where given treatment with the shape and size of the tumor, with modulating the intensity beam. So it is very popular, and still it is the main standard of the treatment most of the cancer patients. Then image guided radiotherapy, what we follow like exact track technique, CVCT, MVCT. What is the main things of the bread and butter of the IGRT treatment, and this is mostly we can found in various institutions. So growth means change, and change involves the risks, stepping from the known to unknown. And whatever our goals, so high dose to the tumor tissue, decrease the tumor dose to the tumor normal tissue, minimizing long and short term toxicities, better quality of life. So how the radiation treatment given, it is a 5 days per week, roughly 5 minutes to 25 minutes according to your technology. It is mostly painless, but no radioactive substance involved in the linear accelerators. Side effects usually temporary, and some side effects are late effects, and most of the covered by the insurance people. So if you see the teletherapy and the brachytherapy, one of the two therapies. Sorry, the movie slide is not moving.
Kanu, you can move to next slide.
Yeah. I'm just moving. So this image guided radiation therapy needs image guided, and as well as the treatment policy. You know, the CT scan, MRI, and PET CT according to your need. This is the most cobalt machine found in the mostly government hospitals and some private centers. And the linear accelerator, these are the various machine mostly by the Varia and Electa. There are two companies they give. So previously, if you do go for the immobilization, so this is the immobilization device. Uses plaster of Paris, and after that we need the customized headrest. We developed the mask to immobilize the procedure. Then these are the abdominal pelvic masks, then locks. Then the stereotactic techniques, either frame-based or frameless technology was used. And this is the customized blocks what we used before. And now we have a multi-leaf collimators where the customized blocks to use to the block the normal tissue. Now this is the multi-leaf collimator, how according to the shape and size of the tumor you can use the multi-leaf collimator, and it's a big advantage in the starting from the 3D to stereotaxy era. So this is the you can shaping the tumor in the saving the normal structures. And then I came the IMRT technique modulates the intensity and each segment. And these are the technology where we can spare the most of the spinal cord, brainstem, optic apparatus. And if you see, this is the 3D CRT technology where we can most of, if you're treating one side of the tumor, it is getting half of the brain is getting treated, but with this is the modified 3D CRT, and with IMRT and stereotactic technology, we can able to spare many structures in the brain. This is the mesothelioma for the tumor chest wall. We can see that treating the chest wall without much dose to the heart and lungs. Like that, if there is you are treating the retinoblastomas or some optic tumors or some orbital tumors, we can spare the eye. And this is the pituitary tumors or skull-based tumors also we can spare, you can treat easily. Then in the target motion in radiotherapy, mostly IGRT and gated radiotherapy. If you think that you go into the mythology, if you are interested, you can see the target movement, the Arjun Swayamvar, as well as the golden deer by Ram. So these are the most mythological things. So we have taken the advantage and taken the IGRT, and this is the breath hold techniques. We can spare the heart in the treating the breast cancer patients and many more uses like in stereotactic technique, long tumors and liver tumors. Another thing is the extracorporeal radiotherapy. in these situations, we can take out the bone directly after excision and treating the only bone without any patient. And we are giving much more dose, like what we are giving in 2 gray, and in extracorporeal therapy, we are giving 50 gray, 25 times of the 2 gray, and giving radiation again, we implanted in the tooth. This is the most linear accelerator you will find in most of the cancer institution now, and most of the technology conventional 3D CRT, MRT, and PET guided and functional guided radiotherapy. And so these are the things you can use: the fusions, MRI, CT for the treatment of the cancer. And this is the PET when there are many immobilization devices, imaging devices also you can use. These are the most advanced technology like chemotherapy, halcyon, and now the technology is the proton beam and particle beam radiotherapy, where is the BRAF peak is the taken the advantage, giving less dose to more and less dose to the deep tumors and pediatric tumors. And this is the proton therapy, what mostly and the going on. So frankly, we have tired of being cutting edge of the technology, but we are getting an advantage. Sir, shall I stop, or some brachytherapy is there? I will continue. Dr. Deepak? Hello?
Yes.
Shall I continue, or we have time, or I will stop here?
So you have 2 minutes.
You have 2 minutes, sir.
Okay, no
Please
problem. 2 minutes I will finish. Okay. So then brachytherapy is a form of radiotherapy where sealed radiation source placed inside the next to the area of treatment. So after Marie Curie's discovery, they suggested Dunlos, where radioactive substances can be inserted in the tumor. He is the Marie Curie who guided the Dr. Dunlos for the treating of the tumors by inserting the radioactive source. So they successfully treated the lupus skin lesion with a radium. Then Peterson, who has the radiologist, has an interest in the advanced technology. He was the director of Fort Radium Institute, and then Patterson Parker, they developed the Manchester system of radiotherapy. Then these are the radiotherapy brachytherapy machines with what they can take care of radiation, and this is the mostly sources of iridium or cobalt. Then it is the first radium surface brachytherapy treatment of skin cancer in Paris 1922, and use of needle implants in the rectum cancer in the London Hospital 1929. Then Stockholm technique for the CS cervix by 2 persons guided for the Stockholm technique. Then Manchester dosage system came into the action in 1934 for the surface applicators. Then Paris system for the interstitial radiotherapy, picorin and Euclid's in 1978. And earliest intracavitary applicators looks like this. And these are the brachytherapy machines. Mostly you can flexitron, nucleatron, and gamma meds. These are needles, seeds. You can number of channels. You can treat many needles. So you can use in the surface tumors like sarcomas, breast cancers, and even ear canals. And these are the early ear lesions, ear canal lesion. I have developed this technology. And penile cancers also we can treat with brachytherapy, so that we can no need to go for amputation. And so don't try with radiotherapy for organ preservation, limb salvage surgeries, and even soft tissue sarcomas we can treat. These are the brachytherapy applicators for the CS cervix, newly developed Vienna applicators, Fletcher sheet type applicators for the radiation treatment. These are the radiation isodoses, anal cancer canal, early cancers. These are the tongue cancers for early long tongue lesions. We can do the brachytherapy. Lip cancers, we no need to go for the aggressive surgery. We can do this is one of the technology we are using. The patient, if you see the whole tongue lip is involved, we just given a mold, and patient is early reactions, and this is the recent picture. So these are the easy advantage of the brachytherapy compared to the surgery, where no needle, no anesthesia is required. These are even benign lesions like keloids. We can treat esophagus cancers, prostate cancers, then prostate sheets, eyelid tumors, skin cancers, we can treat as soon as per the requirement. So we have to think smartly, and we should take the advantage of the technology. We should update ourselves. Don't go for amputation, and but sharp gun we target needs the better training and technology. So just do it, but doing it is not enough. We have to take care of the technology. We should get trained and wait for the invention. But you should these technologies. We should not like that Gandhi's monkeys. We should not tell, listen, and speak. We should change ourselves to spread the messages. We have to talk, we have to speak, and we have to ask, so that people will understand the need of radiotherapy with organ as well as the brachytherapy organ preservation. Thank you very much, Dr. Deepak and team, for the great virtual meeting, and I am very grateful to you for the invitation. Thank you very much.
Thank you, Dr. Kanu. Over to the chair, Dr. Rathi sir, for final comments of the session. Dr. Rathi sir or Dr. Angral sir? Dr. Saima, I think they are not there. But Dr. Rathi.
So thank you, Dr. Petru, for your beautiful slides and wonderful presentation. I congratulate all the speakers, the faculty and delegates. So over to you, Dr. Deepak.
Yeah. So we are here at the valedictory function. Ravindra, am I audible? Sunidhi? Ravindra and Sunidhi?
Dr. Arun Kumar Rathi has joined.
Yes, sir, you
he is
are
raising his
audible.
hand.
So Dr. Rathi sir, please give final comment of the previous session. Then we can proceed with valedictory. Dr. Rathi sir, you are not audible.
I can see him.
Sir, can you type your comment then? Sir, you are
unmute.
Please unmute yourself. So then why we are not hearing him? Sunidhi?
Yes, sir.
Sir, can you type your comment? Dr. Rathi sir, we are not hearing you.
Maybe he need to rejoin the conference. There would be issue with the network.
Sir has typed thanks. Sir is here, but I think there's some technical snag. We are missing him. His audio is missing.
Sir has conveyed his thanks in the chat.
Sir, thank you for being here, sir. You were the president. Sir, there is some problem, but you are hearing to me. I just want to put it on records that you were the person who persuaded me to organize a conference in 2015 in Jammu, and that's how Krabicon was born. Thank you, sir. Thanks for being here, and be there here in valedictory function. Will just take 10 minutes, not much. Principal ma'am is here. Saima, principal ma'am has joined.
Okay. Welcome, madam. I welcome the principal, madam, Dr. Anjali Bhatt. Ma'am, can you hear me? Good evening, madam.
Hello. I can hear you, but I was trying to unmute myself. Hello, everybody.
Okay, ma'am.
Welcome, madam.
Thanks for being here, and you have to take this function along and be presiding over this valedictory function. I'll just speak about this virtual conference, as we were the first one in Albion Radiations of Hope, which organized the first ever TELE-ONCOTHON in 2018, and the persons who attended that conference must be remembering that it was a 24-hour live event, and that was even acknowledged by UICC Geneva, and we even got a invitation to present it ourselves in Guinness Book of World Record that time in 2018. And that time it was no COVID, but we thought to reduce the cost of conferences by doing such hybrid meetings where we can invite 5 or 10 speakers and rest of us can join through virtual mode. But somehow right now, because of COVID, we have to organize in this way. But this is such a cost saving procedure that we can save the money, thus generate it for the benefit of our research, for the benefit of our patients. This was what told yesterday in session of Fighting Two Big C's with K Factor by none other than Dr. Anil De Cruz sir, who is President-elect UICC, Geneva, Switzerland. He is to take over on 6th. He was President-elect and he is taking over on 6th of October. So before I announce the prizes for which many students have joined and they want to know who has won, I'll just please request our worthy principal ma'am to please say a few words about our this 3-day conference. And she was the driving force behind this conference because she supported in everything which we have done here. Ma'am, please say a few words.
Thank you, Dr. Deepak. And let me begin from the end. So I would like to congratulate you, first of all, for holding such a successful conference for the last 3 days. And it speaks of your passion and the intense effort that you put into it. I'm sure everybody present this time will agree with that. So many congratulations to you for putting in so much hard work and seeing it to an successful end. And I would like to apprise everyone also that since our college, GMC Kathua, is just in its infancy, just about 1 year plus old. So with our limited infrastructure and limited, we can say, resources, Dr. Deepak is doing very well, and the amount of effort he puts into treating patients is commendable. And with the knowledge that all of you, me have, and all the attendees have gained, I'm sure it will help us in going ahead in a much better way. So thank you all for attending the conference, all the national, international delegates who took out their time to listen to the lectures, and I'm sure we have all gained by it. At least I did. Thank you again, all of you.
Thanks, ma'am, for
Thank
your
you,
kind
Dr.
word. And thank you for sparing your valuable time. Next slide, Sunidhi. I just want to announce the prize. And so third prize goes to Pallavi Kalbande. Is she there? Dr. Pallavi? Dr. Pallavi, are you there? We got, ma'am, for the last 7 conferences, we have to ask people to just give us papers and like that. But this time we got 37 papers, out of which after screening, we got 17 papers screened as best. And then out of that, we had to, because of time constraint, just present 11 papers. And out of that, these are 3 winners. Dr. Pallavi is number 3rd. Next slide, number 2nd. Dr. Rashmi Yadav has stood 2nd. Is she there, Dr. Rashmi?
No, I cannot see her.
Ravindra, please send the e-certificates. We had tried to convert this virtual conference into a virtual reality. So what we are doing is, as we are announcing, Ravindra is sending these e-certificates on WhatsApp. So delivering then and there. So the much awaited winner of the gold medal, P. Ravinath Memorial Gold Medal, and I'll tell you why we have named it, but first announcing the first one. Next slide. The winner is Dr. Shivani Mehra from Dehradun, and she has also won P. Ravinath Memorial Gold Medal. P. Ravinath ji was associated with our trust for I think last 10 years, and he was supporting us in every endeavor. He was Mahanta Pirkho, the famous temple of Jammu, and he was a man of development. He did everything to develop that area into what we are seeing today, and he was helping our cancer patients with money and all the help which they needed. he left us too early in this March of this year. He left us, but he wanted us to create a Crabecon studios, Crabecon this auditorium. I can't create that because of constraints of money, but we had created virtual studio and virtual lobby in his honor. May he shower his blessings from heaven always. Next slide, please. Next slide, please. So now I would like to present the vote of thanks. I am thankful to Honorable Financial Commissioner, Health and Medical Education, Shri Atal Dullu sir, for sparing his valuable time in inaugurating the conference. Thank you very much, sir, for your patronage. I'm very much thankful. Actually, Sanjeev Verma ji, Divisional Commissioner, Jammu, has to come today virtually for presiding over this function, but because of his busy schedules, because of the things which we all know are going on, he couldn't turn up, but he's kind enough to send us a WhatsApp message. And please, sir, allow me to read it out. I had taken a printout from the WhatsApp. I quote him as, "My deeply felt appreciation and acknowledgement for holding this annual event. I very strongly feel that the event must be organized after every 6 months to draw maximum benefit from cross-learning and sharing of experiences by experts. Respectful regards to you, sir, for sharing this message, and we will try our best to organize it biannually, sir, as suggested by you. Thank you very much, sir. I'm thankful to Mr. O.P. Bhagat, DC Kathua, who has been, I requested him to come, be present here virtually, but because of Back to Village program, he has to go to Mahanpur, so he couldn't join us virtually, but he has kind words for us. So thankful, sir. I'm thankful to Dr. Sameer Kohl, a senior consultant, surgical oncology and robotics, Apollo Cancer Institute, Delhi, who joined us at a very short notice and presented a beautiful talk. I am thankful to Dr. Anjali Bhatt ma'am for her patronage to this event, and Dr. Yashpal Sharma, who also patronaged this event. Principal, our worthy principal ma'am, has been kind enough and always kept patronaging the good works being done by faculty in GMC Kathua. Thank you very much, ma'am. I'm thankful to all the media colleagues who have joined us, who have covered it so nicely, so that the knowledge of cancer awareness and the knowledge of COVID awareness can go down to the lost corner, every nook and corner of the state and country. I am thankful to all the eminent international and national faculty, all the pharma industry, virtual conference organizing committee, session coordinators, Dr. Ritika, Dr. Shalu, Dr. Nitika, Dr. Saima, Dr. Pallavi, and Dr. Preeti. I think Prachi is typo error. I am thankful to the office bearers of Cancer Research and Analysis Bureau, Dr. Rahul Sharma from GMC Jammu, and Dr. Vikas Roshan from American Oncology Institute, as well as I am also thankful to office bearer of Integrated Indian Journal of Cancer Sciences, Dr. Jyotsna Suri from GMC Jammu, and Dr. Kesh Kumar from Mata Vaishno Devi University. The journal, which was started last year, inaugurated by Shri Atal Dullu ji, Honorable Financial Commissioner last year, was a yearly annual journal, but this year we had converted it into an online journal, and this will be a quarterly journal very soon. So, next slide, please. I'm also thankful to Dr. Manish Talwar, my dear friend, who has always helped me in my endeavors. And Manish, are you there? Am I audible, Sunidhi?
Yes, sir, you are audible, sir.
So I am sorry if I had forgot any name. I never, actually I was occupied for last 3 days. I haven't slept for last 2 nights. So pardon me if I have not taken any name. Thank you. Over to you, Sunidhi and Ravinder. Ravinder?
Yes, sir. So
if there is any media colleague who want to interact or ask some question, there was Deepak Khajuria ji. I had seen him. Deepak ji, are you here?
हाँ जी हाँ डॉक्टर साहब, I am here only.
Sir, Deepak Khajuria ji is a very senior editor. Right now, he is working in a national channel. Sir, you want to ask something?
Dr. Saab, I just want to ask you one thing. First of all, I just want to congratulate all of your team and the Krabicon team and all the members, and especially you, to conduct such a wonderful international interactive session this time. But I just want to know, in this pandemic time, especially for last 5-6 months, I just want to know how you people handle all this awareness campaign about cancer especially, and what are the plans for future months as corona is still here, and you cannot work in the open atmosphere as you worked earlier. So this is very important thing, just want to learn.
Very important and pertinent question you are asking. Actually, this when pandemic started and when lockdown started on 23rd of March, we were in this dilemma. And actually, if you would have attended yesterday, Dr. Abhishek Shankar, a preventive oncology expert, has presented a paper on this, that preventive oncology is taking a backseat, and so were we. In March, when this pandemic came, we suddenly stopped working, and for 1 month it was a total lockdown. And after that, we thought that, because I saw in Kathua OPD that patients are coming in very late stages. When 1 month lockdown was there, patients were not getting biopsies done. There were no FNSs, there were no surgeries. That time, only in that period I am talking about. So in that first month of May, we thought that awareness we have to carry out. So how to get it done? One idea which came to me is that the volunteers who are working with us were there at their native places. So what we did, we asked them over phones, over mobile phones. We did WhatsApp calling also, so that they in their areas just go to the other house, not coming with maintaining social distancing and other factors, and just ask for, is there any problem to you? So that way we carried on this, and I had shared on my Facebook page also. If you can see, one of our volunteer Mazhar Khan and other Yasir Chauhan, who are working with me also all the time, they went to Mender and Balakot and did these activities, and in Mansar also we did some activities. This way we carried out, and we will try to carry out in more innovative ways, and with friends like you, I think these times will also pass.
Thank you very much, Dr. Saab. I just want to add one more thing here. As you all, maximum people are here, are doctors, and you all are known, and you all are working really, really very well. You all are the warriors of this pandemic, and I am really thanking you for all this. But I just want to add one thing more, that journalists like me and some other colleagues who are always standing with you since you start this Krabicon, and this is really a wonderful initiative. I just want to add one more thing, that if you people can just create small capsules of your this awareness campaign, and during this pandemic, God knows how much long it will continue, we can highlight this on the web portals and digital media, so that people can aware about these such things, and how this corona affecting, and how the non-COVID patients are suffering, and how they can help themselves during this pandemic. So here I just want to add, we are standing with you. If you can create just small capsules, 2 or 3 just videos of you people in a week, just forward it to me. I will help it out, that we can share it on various web portals, and we can highlight, and we can viral such videos, so that a large population of people who are on internet now these days, they can get benefit from that. I just want to add anything, and once
Thank you
again,
very much,
congratulations.
Deepakji. That's why I love you, because you are always there with innovative ideas and help. This is called real journalism. I thank you very much.
Can I make a point?
Yes, Dr. Abhishek is here only. Yes, Dr. Abhishek. Deepakji, are you here?
Thank you for asking this question.
Dr. Abhishek is, let me introduce him. He is editor of Asian Pacific Journal of Cancer Care, and working in Lady Hardinge College. ex-alumnus of AIMS, and now he's also president of Indian Society of Clinical Oncology, or I think honorary secretary. Sorry.
So,
Good to know you.
very good question you asked. And when Sir said that preventive oncology is taking the backseat, it's always on the backseat. People use this word so regularly to gain the benefits of social respect. But when you look at the work, nobody is actually interested. And it's always a secondary work for most of the people because of the non-glamorous nature of the work, because it's very difficult to make people understand. You just start from your family, somebody is smoking, you can make it understand, but making understand other people is so difficult. So media has a very important role to play. It's very pertinent, but I think I'm not sure whether you will be able to do it. And first of all, it's good that you show 10 minutes or 20 minutes or 1 hour of the cover on the cancer, what are the important things, but at the same time, you people don't leave advertising for the pan masala, which is again harming. So at the same time, I will request you, don't put any advertisement for the pan masala company, and just have a fight, because it's very easy. And I will expect a first page ad, to make people aware that don't eat pan masala, it kills you. If you people can do it, and when somebody opens the first page, probably they see only one thing, that any form of tobacco kills you. Probably this will help the purpose. You don't have to write so many articles, so many things, because everybody loves fiction. Nobody is interested to go into the detail. For us, we just look for every confounders, every detail of the tobacco, and there is a need of awareness. Probably we can touch the opposite trade. The problem is the people, teach the people lower socio data, which is not using the technology for the bigger gain. So probably media is having very important role, and it has been debated for many years, but probably we have not seen anything substantial. We have also seen the first page ad for pan masala on Times of India, many of the newspaper, but we haven't seen any ad on the first page to make people aware that smoking kills you, don't take alcohol, related to anything which is causing cancer. So probably if you do it, this will be a great service to the humanity, and probably your work will be more respected than what we are doing right now. So if you can do it. Thank you.
I just want to add one point, Mr. Shankar. Really, you're saying really very well that we have to avoid such kind of advertisements. But as far as we field journalists are concerned, we almost always try to avoid such things and to highlight and aware the people that avoid such pan masala and all that. Even just for your kind information, last year
in office, because I have seen most of media, it is related to every profession. But when I go to offices in media houses in the ITO, you will find lots of smoke, because everybody smoke like chimney. So that is the one thing you should. And this is, as a doctor, as an oncologist, we are concerned for your health. So probably
we will promote that. We are running short of time. Dr. Deepak, Mr. Deepak ji, please last words, and then we'll wrap up.
No, this is just he said very well, Mr. Shankar. Thank you very much, and in future we'll take care of such things. Thank you very much.
So we will wrap up, but before that, I'll request Ravindra to put on the national anthem for wrapping up. Ravindra?
Yes, sir.
Can everybody stand up?
Can everybody stand up, please?
Yes.
In respect of our national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, Ravindra. Thanks, Sunidhi. And thanks all the faculty who attended. Thanks all the delegates.
Deepak sir, I want to tell you one thing. Please organize a media workshop because you can do, things like that. So this will be a very interesting for them to organize a media workshop for the cancer care and how to report.
I want you to help me. I'll work out on
I
that.
can
But you
drive
have
the
to
concept,
involve.
how to do that. What are the things you can involve?
National and international faculty into that. International
Yeah,
and national
sure. I
media
will do
channels
that.
into
I can rope in many people, and probably this will help because we have done it in Delhi. So once we have seen, lot many people were interested. They participated, and when we, read their article afterwards, it was a huge change. So that changed their perspective, how to report the cancer related thing and how to just behave at their workplace. This will help them to understand. Thank you.
Thank you, Dr. Abhishek. Thanks, everybody. Thank you, Sunidhi. We can close the meeting.
Sure, sir. Thank you, sir.